Pediatric Gastroenterology, SGPGIMS, Lucknow, to kindly grace the dais. Thank you, sirs.
Good morning, everybody. Good morning, everybody. It's indeed a great pleasure to be here. SGPGI is not new to us. We've been here many times before. I've seen the Department of Pediatric Surgery grow, and it's a wonderful effort primarily from Richa, who laid the foundations for this department, and now is being very ably handled by all the youngsters with all their specific skills and knowledge. So, without much ado, we'll begin the first session. This is a session on biliary atresia, and I'm going to invite Dr. Moinik Sain Sharma to do the first presentation with the title Neonatal Cholestasis, Diagnostic Workup and Algorithm for Surgeons. So, Dr. Sharma.
Thank you, sir, for the kind words. Dr. Moinik Sain Sharma, sir, is an associate professor in the Department of Pediatric Gastroenterology, SGPGIMS, Lucknow. Sir's key areas of interest being portal hypertension, complications of cirrhosis, celiac disease, endosonography. Sir has authored several book chapters and modules and has multiple national and international publications. And over to you, sir. Thank you.
Good morning. Sorry, how do I go back? Good morning, esteemed surgeons and colleagues. I feel very humbled because who am I to teach the surgeon anything about what an algorithm should neonatal cholestasis be? But nevertheless, I'll make an effort, and if I go wrong anywhere, please pardon. I'm a physician, so things may be different. But we'll just start with a little bit of humor as to what is the natural history of a physician versus a surgeon when we get a neonatal cholestasis, and most of the time it is biliary atresia. So the first thing, as a physician, we ask, where is the surgeon? And deep in our heart, actually, as a physician, we want you to operate tomorrow. That is the real truth. We want you to take the case, operate tomorrow, but I understand that is not possible. So the surgeon asks, are you sure? Are you really sure this is going to be biliary atresia or not? Then we enter the second phase where the POC is normal and the surgeon says, I told you so. Or we have an intrahepatic cause and we say, no, I don't need the surgeon anymore. Then we come to the third phase where again, now we are so burdened with the intrahepatic cause that we can't control the pruritus. The patient has progressed. We need a transplant. Again, we ask, where is the surgeon? And now the surgeon once again asks, are you sure you really want the transplant or you really want the diversion? And at this intersection is where we want our clarity. We want to have an algorithm that finally distinguishes what belongs to you and what belongs to me. So what diseases are important for the diagnosis? For a physician, we have a whole lot of complex disorders, mind-boggling, which are metabolic diseases, bile acid transporter defects, genetic diseases, sepsis, infective, gestational alloimmune, which are very boring, diverse, complex, and possibly very confusing. And for the surgeon, it is biliary atresia 9 out of 10 times. And sometimes we are overjoyed to find a choledochal cyst because we know the prognosis is going to be much better than the biliary atresia. And rare once in a while inspissated bile duct syndrome. Biliary atresia We should be cautious about some conditions that appear like biliary atresia, but they are really not. One is Alagille syndrome, which has ductal hyperplasia, and you know that those Alagille who have had a cascipotomy done, survival are lower, according to a recent meta-analysis. Sclerosing cholangitis, HNF1 beta mutation, cystic fibrosis with a small gallbladder, and in the West, they all look at alpha-1 antitrypsin deficiency, which is not routinely tested in India. We don't know whether it really exists, but most likely it does not, can't be sure. This is not moving. So what is a biliary atresia to a physician and a surgeon? The physician says, my job is done, this is yours, and after the Kasai is done, the surgeon says, my job is done, back to you now for the portal hypertension and all the complications. And this partnership brings good outcome to the patient. But what really is mind-boggling is when it is not biliary atresia, we are uncomfortable. We think it is, but it is not. So we ask that one fundamental question, did I miss biliary atresia? And all the algorithms actually start from there, the crux of all algorithms. This is the consensus report on neonatal cholestasis syndrome, which came 22 years ago in the Indian pediatrics, and we've been following that very religiously in all the tertiary care centers as well as the referral centers. And in that, you give vitamin K, refer the patient, classify as sick and non-sick. If it is non-sick, if it is pale stools, you go ahead and investigate for biliary atresia. This is what we knew till then. Have things changed? Thereafterwards, this is that yellow alert campaign, and Professor Yacha spearheaded the same. And with this, there was a dent to the referral, early referrals, better referrals in UP at least. And but thereafterwards, again, it's taken a setback. And in 2020 with the COVID, we had a lot of delayed referrals. What has changed in the last 10 years? Screening has changed, diagnosis, there are new entities, diversification, there are clarities in the natural history, and outcome and therapies, all because of genomics, metabolics, and basic sciences. Many things have changed. So we'll just highlight a few things. On screening purposes, here is a concept of integrated stool color card from our own center. And this was published in Indian Journal of Gastroenterology. Here what we've done is, we've taken the urine color, we asked the parent to see, is it high colored or normal, and thereafterwards to look at the stool color, grade it as pale or pigmented. And if you notice from the previous Taiwan card, which we used to use for stool color, there's a 7th color that has been added, which was not classified there, and that was a pigmented card. And in this research, we also found that parents and fellows had the best correlation, because probably those two were very dedicated for the survival of the child. But when we saw parents with the nursing staff, or maybe with the technicians or anybody who's not medical, then the correlation was not that great. But this needs further validation, and possibly we need to bring it to the grassroots level and integrate it there. This is a Sanjeev Harpawat study in USA, Texas, where they are actually looking at all neonates being born and their direct bilirubin level. And they're saying that even if you don't have the total bilirubin high, but you have the direct component which is higher than the total bilirubin, in a ratio that is higher, then this child might end up with biliary atresia. This was the first part of the study. And the second part of the study, they took all these patients, they screened about 1 lakh infants. They followed up and they found those patients with biliary atresia they could identify earlier, and the reduction by the Cascipoton was by 19 days, and they found this has a better survival. Now, regarding the diagnosis of biliary atresia, we have the conventional and the unconventional. You have this typical, which I call the CRH model, where you have the clinical, which is pale stools, radiological, you look at the gallbladder, and histological. Add a little bit of scintigraphy probably to the same, and the patient, if everything goes right, will end up with a peroperative cholangiography. This is the standard, comfortable, and we are all prepared for a Cascipoton. Now, new things are coming up. People are talking about lap cholangiography. You don't want a scar. People are talking about percutaneous radiological cholangiography and contrast-enhanced ultrasound, which are novel and exciting, but they need more literature for us to be really, really convinced. Then you have the ERCP, MRCP, elastography, and the scoring system and biomarkers. These are risky. They have fallacies and they are not foolproof at this point of time. Nothing new in this ultrasonography. You all know these are the signs that are there in an ultrasound. But if you take a single or a multiple parameter and keep combining with so many parameters, the best you can actually achieve is only up to 85%. That is what a meta-analysis is saying. If you look at scintigraphy, excretory hydra excludes biliary atresia. Not very helpful when you have an obviously pale stool. And it is best done in those patients who have ambiguity. The sensitivity reported is 99%, specificity is 70%, but this is from a meta-analysis. And they prefer mebufotenin over disulfiram because the hepatocyte uptake is better. But you have to be cautious. We all know that there may be urinary contaminations, there may be inadequate labeling of the radioisotope. And so people are now, instead of diagnostic, people are saying, can it be a screening test more than diagnostic? Histopathology, the presence of steatosis and a glycogen-filled hepatocyte obviously rules out biliary atresia. If you have paucity, again, it rules out biliary atresia. If you have portal tract and you are not seeing the changes in the portal tract, it again probably rules out biliary atresia. But again, histopathology is only 88 to 90%, not more than that. This is our own study from here many years back where we looked at and that our patients of biliary atresia versus non-biliary atresia, and finally we saw that the sensitivity and specificity is only about 88%, and that is almost universal for other disease or other studies as well. And this is the meta-analysis that came in 2016, which said for all ages the best you can do is 93%. But if you look at patients who are less than 60 days, maybe in that subgroup, the diagnostic accuracy is a little higher. So what we want is that we should not subject a patient unnecessarily for a POC. And this is just very rudimentary data from our institute. And if you look at the 221 cases operated between 2006 and 17, that is 20 cases per year, we've had patent, on a POC, we've had a patent duct only in 1.3 cases per year. So that's a very, very good number. And the liver biopsy accuracy is about 94% in our setup. To me, there is a limited role of liver biopsy now in neonatal cholestasis, and the current indications, I'll tell you, I feel is suspected biliary atresia where you are really suspecting but has a good sized gallbladder. Prior to biliary diversion, if you have a PFIC to rule out cirrhosis. Persistent ogoromegaly despite jaundice, so you might end up with a storage disease or a congenital hepatic fibrosis or something like that. Indeterminate causes where you're not finding anything. Suspected CMV hepatitis in our scenario, which is very, very rare, but you may want to look for an inclusion body. And if your tyrosinemia has ended up with a liver SOL, then for ruling out a hepatocellular carcinoma, this is where a liver biopsy is probably required. Preferentially, we can avoid liver biopsy in atretic gallbladders and cyst of the porta because obviously this patient will require a POC. So why go through a liver biopsy pathway? Ultrasound guided percutaneous transhepatic cholangiography. Here, the technical success rate is about 80%. And what they give is they give a pre-procedural antibiotic, they pre-fill the gallbladder with saline, they take out whatever bile is there and fill it with saline, they put a non-ionic contrast. And in this particular study, which has come from Korea, they said there is no cholangitis, no peritonitis, and they've only done when the gallbladder lumen is visible and about 1.5 centimeters long. This is data that is from ILBS Delhi, and they've given me this to kindly lent it to me. And they have 13 patients who underwent Ptcc. 1 had a failed cannulation, 12 successful, 7 had a patent system. So they said we saved POC in 58%. 5 with an obstructed system, 3 of them were confirmed to be biliary atresia, 1 progressed for a transplant, and 1 unusually ended up being sclerosing cholangitis. So POC is also not 100%. Contrast enhanced ultrasonography with Ptcc, this is also a very encouraging method. Now what they're doing is instead of subjecting the patient under fluoro, they are taking out whatever is there in the gallbladder, pushing some microbubbles and agitated saline, just like we do our saline echoes for microbubble echoes for hepatopulmonary syndrome, exactly like that. They put microbubbles inside, then they see how much of it is flowing serologically into the duodenum. Remember, they are not using fluoro, so they are not going to give radiation, but this is 100% observer dependent, and there may be chances that we may go wrong in this particular scenario. But what they are also doing is, during this procedure only, they are doing the liver biopsy just to confirm that yes, this was what we saw. Now comes the laparoscopic cholangiography. This, I think, is a very upcoming modality, and this is to avoid scar, lesser time for your POC, lesser post-operative burden. And this is a study from China, which has looked at this particular entity, a lot of cases, and biliary atresia was 70% of their cases. There was technical success in 85%, and their definition of technical failure is when they have not been able to see the gallbladder or cannulate the gallbladder or put a cannula in the gallbladder. The procedure time was significantly reduced. This is another study where they said, if you use HIDA and you use the Ptcc and the liver biopsy, can you actually do away with the unnecessary laparotomy? So they did about 46 of these cases. 41 of the patients also had a liver biopsy. Again, technical success is only 83%. The negative laparotomy rate here was 17%. And the complications in this particular study, which is more of a realistic picture, the complications was 9%. Some patients had bleeding, fever, or desaturation during the time of Ptcc. This is another way of looking at the same thing in a different way. They are saying don't cannulate the gallbladder, but you look at the liver surface by laparoscopy. If your liver surface is showing spider-like telangiectasias, chances of you having biliary atresia are going to be very, very high. It's how people earlier used to look at hepatic subcapsular flow on the ultrasound. And they said that is probably much better than doing a lap-assisted cholangiogram. This was a group of Egyptians who came up with a very nice article in Journal of Hepatology, and where they found a scoring system, diagnostic scoring system, but was highly criticized because it does not really follow the algorithm. So these are basically various scoring systems. They are old wine in new bottles. Nothing is popular. Still, POC is the gold standard. Another similar paper came in a pathological scoring system for biliary atresia. That also was not very helpful. Ercp, there was a era in 2010, probably till 15, I don't know, where Ercp was being promoted, but there was a lot of issues in the same. It was cumbersome. There was lack of expertise in various centers. We've also tried. I think Dr. Podar will be able to give you a better perspective of this Ercp. It was deemed invasive, and finally, cannulation failure rates, they said, was about 13% here. MR cholangiography for biliary atresia, I don't know whether it's a very good modality or not. If you have a dilated system, then yes, that's the best, because you might be dealing with a choledochal cyst. So there's nothing there. But for biliary atresia per se, there is a study that has looked at it, and they have said that the complete visibility of the extrahepatic bile is only 60%. And possibly the reasons for the same that is there is that we are looking at a T2 weighted image, and a T2 weighted image really requires the liquid to flow. If it is an obstructed system and the liquid is not flowing in an atretic system, you're not going to pick up those signal intensities. So it's an absent bile flow in a typically non-dilated biliary system. That is why the performance is probably poor, and you should not be misled. Elastography is upcoming, and better performed than a grayscale ultrasound, they say, and patients with 30 days are better candidates because they have more of fibrosis, so you can pick these cases up better. Matrix metallopeptide 7, this is increasingly becoming popular. They are saying we can replace liver biopsy with the same, and it is probably even more sensitive than the GGT. This is a study that came in Journal of Pediatrics, very ambitious, and they've said that the MMP7 probably in the years to come can replace the biopsy, because both MMP7 and biopsy have an accuracy of 88 to 90%. There is a subsequent study now from Japan also, but I didn't quote that study. MicroRNA profiling biliary atresia, I am not qualified to talk about the same. I know very little, but every year there is a new microRNA that is coming out. Which one is the best? I don't know. It's still not clear. It's in evolution. So let us look at the diagnostics performance summary. MRCP is at 60% at best, ERCP is at 80%, ultrasound 85, histology at 90, and scintigraphy at 98. Gold standard is POC. POC stands tall, like Bahubali, nobody can, invincible. And in the race are this Ptcc and lab cholangiography, which is at 83 to 85, elastography, which is at about 85, and MMP7, which is upcoming, is probably at 88. But these are all new modalities. I don't know how much we should take it into the algorithms or not. It's important to remember that a sick neonatal cholestasis is not always a metabolic etiology. In fact, our experience, lots of our biliary atresias come in sick, and that is about 6% of all our biliary atresias. They come in sick, and in that scenario, it becomes a very difficult scenario because we wait, we are not sure, we want the stool color to change from pale to pigmented. You need repeated ultrasonography because of the sepsis, you can have a non-functioning gallbladder. So you're not knowing whether that gallbladder is really contractile or not. And HIDA scan can be used. We defer liver biopsy till the complications settle down. But time runs out for surgery in this particular sick biliary atresias. Inspissated bile duct syndrome is the setting of hemolysis with multiple blood transfusion. They have a stormy course, and they've had maybe some surgeries done and gone through a very bad time. And this is a group of 6 patients. I'm sorry, I didn't put the reference. This is a group of 6 patients who had inspissated bile duct syndrome. They had a technical success of cannulating this bile duct in only 6 of the patients. All had dilated duct with sludge. There was a non-excretory HIDA in most of them. And they left the catheter inside the gallbladder for about 26 days with multiple flushing. And in follow-up, almost all resolved except that one ended up as a choledochal cyst. So that means there is a gray zone here as well. Now, this is just for your knowledge, but I will tell you how genetics is helping a surgeon as well. It helps us more as a physician. The settings for genetics, which you might not come across, is a patient who's had pruritus steatoria, low GGT. And when I say low GGT, I mean low because 1/3 of biliary atresia, it has been shown to have normal GGT. If you have stigmata of metabolic liver disease, abnormal metabolic profile, or you have extrahepatic manifestations except biliary atresia splenic malformation, if you've had a neonatal liver failure, uncorrectable INR, early decompensation, ascites, you would refer this case obviously to the physician. And the crux here is to end up with a genetic diagnosis. What is available to us presently in India? A single confirmatory gene testing, that is, you know what the disease is, like galactosemia or tyrosinemia, and you just go ahead and test one particular gene of the same. So you can do it if the index is known, and you're going to do it in the SID. The second, which is much more popular, is the clinical exome sequencing. That means you take a certain phenotype, like pruritus, steatoria, dysmorphism, and you restrict to a panel of 20 to 30 common disorders. And then when you run out of both, then you ask for a whole exome sequencing where it is just shooting an arrow in the dark, where they test for a lot of diseases and you might end up with something. But there are chances that you may have variation of unknown significance in this particular disorder. This is something we reported. This is an HNF1 beta mutation. This is a child who has had SID deaths, and the first SID in this family was operated in PGI Chandigarh, and this was a type 3 biliary atresia. Who are we to question? And that case, the Cascipoton tracheostomy failed. So this particular disorder mimics very much like biliary atresia. You may have a POC that is showing a non-visualized system, and you end up doing Casci and it might not work out. So when the second SID came, we saw that there was dysmorphism, and when we sent the genetics, it turned out to be a HNF1 beta mutation. This may be familiar. They have syndromic faces, they have renal hypoplasia, and they may have maturity onset diabetes if they survive. This is also a very interesting case. This is a child operated here, And it was a POC that did not show the duct, and later in follow-up there is progressive pruritus, ichthyosis, dental anomalies, hair changes, and this child is having niche syndrome, which is neonatal ichthyosis, closing cholangitis, and hypotrichosis. So again, POC is not 100%. There are still fallacies with the POC. Here I will show you a very difficult case, a case of dilemma. This is a child with cholestasis from day 1, pale meconium, ultrasound showing triangular cord sign. There is no doubt this is going to be biliary atresia, and he was operated, found to have a type 3 biliary atresia. Discharge on day 15, everything good, successful portoenterostomy done here. 2 years down the line, he is anectric, but his GGT is rising, and here he is complaining of pruritus. Now, when he is complaining of pruritus, we know a certain very small group of patients of biliary atresia can have pruritus. So we tried to tell the patient that yes, it is possible that biliary atresia can have pruritus on follow-up. But that was not the problem. The problem is the mother is PhD in genetics, and she has done a thorough research. She is questioning the doctor and the surgeon here is Dr. Richa. And ma'am was 100% sure that this is a biliary atresia. We've 100% sure. But she is questioning, was it really biliary atresia? Did you operate on an allergy syndrome? And we are thinking, could the mother be right? How do we disprove? And here, whether a genetic study is logical or not. And worse, she's read this article where there is a Cascipoton in allergy syndrome, and where allergies has been found to have a worse outcome. So this is a very, very worried mother, and we have to desperately disprove. So we did, and there is some case report of an intrahepatic cholestasis PFIC type 3 also that's associated with biliary atresia. So finally, nothing doing, we had to ask for a clinical exome sequencing, and it was normal. So then she was convinced that this child is really biliary atresia who has a complication as pruritus in the follow-up. And how we managed is probably not a part of this talk today, but we didn't find any response with rifampicin, and it was potentially becoming hepatotoxic. Finally, we were thinking biliary diversion in this situation is not an option. So what do we do next? Will he head to a liver transplant, or shall we try new drugs? Patient has moved to Delhi, so I can't tell you much more about this. So finally, my algorithm, if you have a stool color, I'm not going to give much importance to the GGT. You do an ultrasound, there's a cyst at the porta, or it's an atretic GP, definitely POC, why not? If you have a good sized gallbladder, histology, if it is biliary atresia, again POC. If it is ambiguous, to the best of my understanding, it should be a POC, but people are moving through a different pathway where they do a HIDA scan maybe, and they do lap cholangiography or a Ptcc. If they find it obstructed, then only subject the patient to a POC. And if you have a patent system, obviously you're going to refer it to the physician. If you have a dilated system with a good gallbladder, you do an MRCP. If it's a choledochal cyst, again, the surgeon's choice. If it's a dilated system with a sludge and the setting is for inspissated bile duct syndrome, then again POC will be required, and you may need to flush the biliary system. So what is the physician's domain? What is the surgeon's domain? So surgeon's domain is where there is a persistently pale stool, urgently rule out biliary atresia and choledochal cyst. If everything is normal, refer the case to us. And for us, if you have a pale stool with any of these, family history and low GGT, pruritus, early decompensation, failure, neonatal liver failure, or if you have a pigmented stools, after multiple steps, we may end up with genetics, but there are some exceptions where if you have an improving LFT and it's an idiopathic neonatal hepatitis, you don't need it there. If you've diagnosed galactosemia with an enzyme assay, again, you don't need it there. Neonatal hemochromatosis, no role of genetics, and infectious diseases like HSV, and very, very rarely CMV. Thank you very much, and I'd like to thank the Department of Pediatric Surgery, Basant sir, Vijay sir, and Dr. Ankur. Thank you very much.
Thank you, Dr. Sarma. I think that was a very, very informative talk. And I'm sure, and you lived up to your promise by being a friend of the surgeons, because the surgeons have always believed that POC gives the best answers to all these problems. But having said that, no algorithm is 100% correct ever, regardless of what disease we are talking of. And that's true for biliary atresia as well. So at the end of the day, I think we need to look at it very objectively, define how common or uncommon are these various anecdotal diagnoses that you have illustrated, and also look at what is an acceptable risk or the possibility of having a patent duct on the POC in a suspected case of biliary atresia. Now, we don't have too much time, so there's a lot which can be talked about and discussed about. So I'm going to ask my colleagues on the dais, Dr. Gangopadhyay, Dr. Bajpai, Dr. Podar, if they have any short comments, and then maybe just one or two comments from the audience, because we are clearly running out of time. Thank you.
Thank you, Dr. Bhatnagar. Thank you, Dr. Sharma. Basically, a short comment because of the time. What we keep thinking is, as you started off saying, where to draw the line. Obviously, this is a big question which stares the pediatricians when you see a child and there is indirect hyperbilirubinemia, which is common. But now that the definition of direct hyperbilirubinemia is established now, what percentage of patients, Dr. Sharma, with direct hyperbilirubinemia belong to a group of medical conditions, especially they are amenable to medical treatment? Now, at the backdrop of this question lies that line to be drawn. Beyond the line is a big ditch. If we miss out on an perioperative cholangiogram and are amenable to surgical intervention condition like what we do for EHBA, we are likely to have some incremental benefit in terms of bile drainage. Now, these two questions are interrelated, and that's where at crossroads both of us are, the pediatrician and the pediatric surgeons. And the vast majority of conditions which are medical, do we have enough diagnostics available and also to come out with a diagnosis which can very clearly say, here is a condition which will be purely medical, which may have a good prognosis. By doing an intervention like POC, we are not likely to gain anything, very far and few. POC fails rarely. If it shows something, and if you have offered something, like you said about the Alagili syndrome, what is the prognosis of Alagili anyway? It is bound to go into liver failure. There is nothing available. But the mother could have been told, well, we have offered a chance. Otherwise, absolutely no chance is there. So I think we have to be pragmatic. We do face these scenarios in day-to-day life, but we are the ones who have to give a very clear chart to the families. And I would just put it as a comment rather than a prolonged dialogue on this. We can discuss it any other time. But since my residency days about 40 years ago, and today, this dilemma looks like going on and on. Despite the availability of perioperative cholangiogram, this should be lapped up. You should more frequently refer, I mean, this is my personal opinion, so that we at least rule out a rule in a condition. Thank you so much, sir.
I agree with you, sir, because POC was, is, and will remain the gold standard in diagnosing biliary atresia. Since it is a very important forum, we rely on the surgeon to manage this. You said and accuracy of scintigraphy is 98%. If you don't do liver biopsy, how do you make a diagnosis biliary atresia short of perioperative cholangiogram? Because most of the patient comes to us, even the surgeons send the patient to us for workup. They are not ready to do the POC directly.
Before Dr. Sharma says something, let me make a very short comment on that. Yes, the West believes that a liver biopsy should precede a POC. In our situation, I think it's slightly different, because in the West, if you send a tissue in the morning, by 4 o'clock in the afternoon, you'll get the report. Here, the pathologist will take several days to give you a report. And that's a loss of a huge amount of time. So that is something which we have to take into consideration when we talk about what should precede the liver biopsy or the POC. And as far as we surgeons are concerned, we can always do a liver biopsy at the time of the POC. If Dr. Sharma has to add something to that.
Yeah, I think I'm not a proponent of the scintigraphy, unlike many people. I don't think scintigraphy works if you have an obviously pale stool. So I would go through the liver biopsy pathway unless the ultrasound is directly showing that there's an atretic GB or a cyst at the porta. Scintigraphy has been over highlighted and also in the meta-analysis as 99% accuracy. That is because the largest chunk of what they were dealing with was a finally biliary atresia only. But if you give scintigraphy to a center like ours where 50-50, where we get 50% as biliary atresia and 50% as intrahepatic cholestasis, the HIDA scan really does not work so well in our scenario. So we in our department ask for HIDA scan only from a very small, to a very small group of patients where we are in ambiguity or the case is becoming ambiguous. That's it. We rely on the biopsy, but I understand that every center does not have a robust biopsy pathologist to report biliary atresia. So a lot of my friends who are in private practice, they say, I'm number one scared to do a biopsy, even after working here, because I can't take the load of having a complicated procedure, and know who's going to report my biopsy. So some of the practitioners in the periphery are going through the HIDA pathway, but I don't think that will give much benefit, because in an obviously pale stool, HIDA will not make it much more sense.
Hello. So only one comment, very nice presentation. When it is POC, lap and open, they should be grouped together rather than separately. So if lap fails for any reason, then we will go ahead and do open anyway. So POC, rather than putting lap separately and POC separately, I think POC has two parts, lap and open. If laparoscopy works good for the child, otherwise open.
So my preferred approach in such situations was that I mark out the incision for an open Kasai procedure if I am doing an open Kasai procedure, but do only a very small incision to just expose the gallbladder, do a POC, and if you find that dye is not going into the duodenum, you can extend the incision and go ahead for a Kasai. If you find that the dye is going into the duodenum through that very tiny incision, you can even take a biopsy if you want and close it, and the patient goes home in 48 hours time. And the advantage of that is also that you can use that little incision and that needle in the gallbladder to flush the extrahepatic biliary system with a little bit of saline. So that works beautifully in our hands.
Just 30 seconds if you allow me. One, I totally agree with you. When the patient has got pale stool, there's no point. If the bilirubin not going down, the pigment not going down, the dye is not going to go down. So no point doing it, wasting time. Two is, I appreciate that you put up that 2000 paper and the yellow alert thing. It all came up right here from SGPJ. I was very much part of it. But even after 22 years, even in major medical colleges in the capital of the country, the patient will be admitted with pediatric medicine for about 6 weeks at times. And the patient is already 4 months of age when they're referred for Kasai portal tracheostomy. One more thing is that we already talked about the histopathology, but one thing which none of you mentioned, and I thought I must bring it. In my experience, the intracholangiogram, I can't do it in more than about 2-3% patients. I mean, majority of the patients who come to my table do not have a gallbladder. It's always atretic gallbladder. So if I can't put in even a small needle in, how can I just go about it? So I don't know, intracholangiogram being told the gold standard, all right. But in my experience in the cohort, probably not more than 5%. Sure, I've seen anecdotal Algelis, 2, 3, 4 hyperplasias without syndromic in last 30 years I've been operating. But majority of them I can't do intracholangiogram also. Thank you so much.
I think in the interest of time, we'll end this talk and proceed to the next one. But before that, I'd like to give my final word Dr. Sareen. Yes, I mean, when we are talking of POC and we are giving a very tiny incision, we are looking at the gallbladder. You can do a POC only if there is a gallbladder. If you don't see a gallbladder, if the gallbladder is atretic, you just extend your incision and go ahead. It's as simple as that. So, the next talk, please.
Thank
Sir,
you so much, sir,
just
for the
last minute,
informative talk.
Just for one line. Dr. Sarin, I fully agree with you. All these studies which people are doing by puncturing the gallbladder, injecting air bubble, contrast, these are only those subset of patients where you can see the gallbladder. Now question as a surgeon, you substantiate how often we see the gallbladder in a biliary atresia patient. So we need to analyze the data in light of that. If you don't see gallbladder, forget about anything. This is biliary atresia. If you see gallbladder, then you can explore that is it really biliary atresia or not.
Thank you, sir. Next up, we have Professor Raju Redkar, sir, who is Senior Consultant Pediatric Surgeon, FRCS Pediatric Surgery, also an ex-consultant, King's College Hospital, London. Sir is currently practicing at different centers in Mumbai, which include Lilavati, HN Reliance Foundation, Apollo, and Regia Fortis Hospital. Sir is well known for his expertise in the field of pediatric hepatobiliary surgery. Sir will be sharing his experience on the topic, extent of total dissection in biliary atresia, current guidelines, and review of literature. Over to you, sir. Thank you.
Next, yeah. And pointer. Oh, thank you. Well, good morning, everyone. To the dignitaries on the dais, who are most of my, all of them are my teachers and colleagues. I thank the department for giving me this opportunity to present, and in particular, Dr. Basant Kumar and Dr. Vijay Upadhyay and Ankur. We've had most of the discussion in our previous talk and the subsequent debate. So with my experience for about 22 years or so, I would reiterate, Professor Bajpai, that you said that biliary atresia is a bad disease. It has an unpredictable outcome in my experience, and therefore this needs to be endorsed to the parents before we embark on treating it. Its incidence is about 1 in 14,000 population, and if untreated, then it leads to death by about 1.5 years. So we all know about the types of biliary atresia, the 1, 2, and 3, 2 and 2B. Clinically, since it's a state conference, I would like to endorse the window that I've drawn. So the earlier that the reference is made to a pediatric surgeon with a suspicion of biliary atresia, the better is the state of the liver that we find when we operate them. Investigations have been highlighted in the previous talk. The ultrasonography is noteworthy by picking up what is called as a triangular cord sign, and that helps us suspect patients with biliary atresia. We tend to rely on hepatobiliary scintigraphy at our center because of the liver biopsy inexperience that we have in the pathology department. So we rely on this. We make sure that there is non-excretion in 24 hours after adequate priming, and then post our children for a operative cholangiogram. Liver biopsies are not resorted to preoperatively in our center. MRCPs are rarely done, although there are some centers coming up with use of these investigations in biliary atresia, but there is no consistency with the results. So the topic today is how we manage, and especially the dissection at the porta. So in preoperative preparation, we do the blood works, we correct the abnormalities with regards to the coagulation profile and the with the platelet counts, and meticulously I stress on bowel preparation. So we use gut sterilization with oral antibiotics, whatever is available locally, and we use polyethylene glycol and even enemas sometimes for 2 or 3 days. So once this is done, we, as Dr. Bhatnagar had mentioned, that is my technique, that I mark out the incision. I take a small component of the incision to explore inside. I do not personally do laparoscopy. There are a lot of people doing it, and I will discuss that. And then cannulate the gallbladder and do a peroperative cholangiogram. If there are nice bile ducts seen like this, then we just call it quits, take a liver biopsy, come out with a drain, because sometimes we have had leakages from the site where we have punctured the biliary system. Now the role of laparoscopy. See, a lot of centers have been doing intraoperative cholangiography with laparoscopy, and they do liver biopsy at the same time. Personally, I don't do it. This is a talk where the department wants to give my experience. So I would relate more in terms of that. So technically, there are some centers even doing portoenterostomy. Okay. However, there comes with a difficulty in coagulation of the vessels from the portal vein to the fibrous plates. So their coagulation is used, and therefore, okay, it has been found with some long-term studies that the survival of the native liver with a laparoscopic Kasai is lesser than that with an open center. Portoduodenostomy is resorted to in laparoscopic procedures, and that has not been our standard, methodology of managing. We use a long loop Roux-en-Y portoduodenostomy. That's the standard Kasai procedure. And with regards to adhesive obstruction between laparoscopy and open, there is not much of a difference as per the literature review. So the surgical plan for the biliary atresia, we have had numbered about 180 as 1% series at our center. The intraoperative cholangiogram and proceed, and majority of them, I would say 90 to 95%, land up with a Kasai portoenterostomy in this type 3 biliary atresia. Wherever there is a patent bile duct, that is type 1, there we anastomose the bile duct to the Roux loop, and in case there is a cyst identified at the portal plate, then that cyst is excised completely and a Kasai portoenterostomy is done. So this has come, this technique was first described by Professor Morio Kasai from Sendai in 1959, and the technique that I have incorporated with my experience at King's is from Professor Ted Howard, who was like a father figure teaching me this technique. So in this technique, basically, we cut all the 3 ligaments that hold the liver, it's the falciform, the left triangular and the right trapecular, and the liver is brought out over the abdomen, upturning it on the inferior vena cava. So before that, the anesthetist has to be warned to take venous access either on the upper limbs or in the neck and not in the lower legs. Because when you get the liver out, there is a venous return problem, okay, because of the IVC getting kicked. So the anesthetist sometimes turns blue at this stage. So the liver, then the undersurface of the liver starts facing us, and we have access, very good access to dissecting the portal plate. So the arteries are identified and looped, and so the portal veins are identified and looped. Okay, and the whole thing is begun by taking the obliterated bile duct, resecting it and using it to retract. And then we come to the base of the arteries and the portal veins. Now here, where do we go, or how far do we go? We go until the second order of the hepatic artery and the portal vein is seen on both the right side and the left side. Sometimes on the left side, there is a bridge between segment 4 and segment 3 of the liver. So that has to be resected, and the rex recess, which is this, is accessed, as you can see it here, to do a wider extent of the portoenterostomy. Now, amongst the people who do biliary atresia work, there are people who believe in the depth of portal resection. So there are a minority of them who do a shallow transection, which is at this level. There are some who go into the liver and do a deep transection and try to identify the bile ductules actually. So I will refer to these modifications later. But what we follow, and which is the King's technique, is remain at the level of the glissans capsule, and that is what our current methodology is. So we go up to the second order bifurcations of the hepatic artery on the right and the left side, and likewise for the portal vein. Now, when the portal vein is dissected to its anterior and posterior branches inside the right side of the liver, the bile ducts, according to various model studies that have been done or 3D studies that have been done, the bile ducts are medial, or they are in between the two portal venous second order radicals. So it is believed that the bile ductular elements are there, and therefore wide dissection has to be done to encompass those within the rule loop anastomosis, and very little cautery is recommended. So I would say pressure works best to achieve hemostasis at this level. We have a special scissors called a Kasai portoenterostomy scissors, okay, which has an angular tip, and it is a spring scissors. So it works us for dissecting the undersurface of the porta flush with the glissans capsule without getting into the liver. Then, without the use of cautery, we do a wide portoenteral anastomosis, okay, with a single layer and absorbable suture materials. Tacking sutures are taken on the two sides, the left and the right, to hold the rule loop up and prevent it from falling down. A 40 centimeter rule loop is something that we have been using in most of our cases, and the idea here is a longer loop prevents lesser cholangitis. So this is how our end portoenterostomy looks. Noteworthy is the fact that we take a liver biopsy at the end of this procedure to kind of use it for our risk prediction for future outcomes, which one of our colleagues from Leelavati will be presenting tomorrow. So now the technical variants and the modifications, which I would like to resort to. Now, if there is a common hepatic duct patent, as you can see in this type of biliary atresia, then obviously we transect the duct, excise the obliterated remnants, and join a rule loop at the undersurface. However, the cystic type of biliary atresia is something that I have experienced bad outcomes. So if there is a cyst seen at the portal plate like that, sometimes this cyst can contain bile, and we become excited that there is now bile seen, so it would have good outcome. But my experience is quite contrary. Whenever I see a cyst at the porta, I feel that this is poor outcome. As you can see in this picture also, the liver looks very hopelessly cirrhotic. The cysts indicate bad outcome in my experience, and I'm a little unhappy if I find a cyst at the porta. Situs inversus. Now, situs inversus, worldwide they have said that situs inversus is poor outcome. We have somehow found that they are not so good in their, they are not so bad in their outcomes of biliary atresia. Polysplenia. Now, polysplenia, multiple spleens, we think, well, if one spleen is responsible for immunity, polysplenia is better. But no, that is wrong. The spleens keep fighting with each other. So such children with polysplenia tend to have immunologically deprived status. So they are a problem in terms of outcomes of biliary atresia in our experience. Sometimes we identify a pre-duodenal portal vein, as is seen here. Now, this is a technical challenge in doing a biliary atresia surgery. So what we tend to do in such cases is normally the rule loop, the C of the rule loop faces the right. But in patients where there are abnormalities of the portal vein, or there is a difficulty, or there is situs inversus, we reverse the rule loop. So the closed end of the rule loop is now facing my right lateral side. So it's a reverse rule loop. And the end of the loop that is closed, we use some metallic tacking elements. Now, why this is done? Because if there is a outflow problem, and we need to access the rule loops by interventional methods, then it is easily tackled by this method. You can puncture with a needle and access the rule loop if the reverse rule loop is technically done. Now, modifications of portoenterostomy. worldwide there have been a few modifications from the standard Kasai, modified Kasai's technique. First is Hashimoto's modification. This has come from Nagoya University of Japan. So what Hashimoto and his group did was he did extensive lateral dissection. So the portal vein was separated entirely into the liver on the right and the left side through the recess on the left side, and then they undercut the segment 4 of the liver by using Cusa knife. So they use Cusa to actually cut the Gleason's capsule. They, in their paper, mentioned that there is about 0.5 centimeters of bile ducts that they were seeing from the undersurface, and then anastomose a rule loop there. Okay, this is the modification that Hashimoto has done. Not many people follow this worldwide. Suzuki was from the same group who came out with the paper in 2010. Now, the Hashimoto did an extensive Cusa dissection. Suzuki restricted it to only segment 4. So he did not go extensively with the Cusa. He did only the portions that were relevant. And that is the Suzuki modification of the Kasai portoenterostomy. And the third modification was attempted by Ando, reported in Journal of Pediatric Surgery. Now, ligamentum venosum is something that connects the portal vein to the inferior vena cava. It is also called Arantes ligament. So, Ando described the modification in which he cut this ligamentum venosum. So what effectively he did was he separated the left portal vein completely, okay, and the right portal vein from the undersurface of the liver, so that the posterior aspect of the portal plate was exposed, and he extensively dissected that posterior part of the portal plate and anastomosed the rule loop, the posterior element, to the caudate loop. So this is Ando's modification. So these three are the modifications to the Kasai portoenterostomy at the portal level. Now there are a variety of modifications for the anti-reflex techniques. Now Nakajo tried a anti-reflex valve for 2 centimeters. Kasai did a modification of the Kasai was a double Ruama loop, which was brought out by Sawaguchi as an exterior loop. Some people tried a double barrel osteotomy. Now, an Ando put an ileocolic conduit. Now, all these are modifications with an attempt to reduce the incidences of cholangitis. However, with all these attempts, the cholangitis attempt was, episodes were not reduced. So the effective thing is that if bile drains well, then all the anti-reflux and enteric conduits are not necessary for preventing cholangitis. So it is not the ascent of the bacteria that causes the cholangitis, but it is the flushing action of the bile that is more important in reducing the cholangitis. So this is the long and short of what we do, outcome of all the research of that and the complications, the ascending cholangitis is common, about 40%. 40%. The commonest is Photopulmonary Hypertension. Almost 90 to 95% of these biliary patients, or even more, tend to have Photopulmonary Hypertension, and that has to be managed subsequently. We routinely do an endoscopy at the end of 1.5 years to check for the internal varices if there is no manifestation of Photopulmonary Hypertension. Hepatopulmonary syndrome is rarely seen. Intrahepatic biliary leaks or biliary diabetes are seen, and nutritional deficiencies are evident, which the medical science help us in managing patients. So complications because of the healing which is delayed in these children sometimes can be as grotesque like this with herniation to the brain side. So effectively, our results, which have been published in the Pediatrics, we have almost about 40% that series of 149 patients, about 42% non-dispute patients. They have about 20% all who are surviving with problems, but with their native level, and about 40% have been not successful in our management of Kasai. So those are referred ideally for transplantation. But the hospital where I did majority of my work, the patients were unaffording, so they not all of them. They had only a few of them to the transplant way. So we have managed them with whatever resources that we had to maintain their
lucid presentation, but because we are running short of time, so I would ask the chairperson as well as the delegates to ask few questions and precise questions. Dr. Shiksha, please.
Well presented, Rajiv. My question is, if somebody comes at the age of, or rather newborn with pale color stool, what is the earliest age when you will subject the patient for surgery?
See, very rarely they present as a newborn, but they present within the first month. I had quite a few references within the first month. See, if there is a suspicion of biliary atresia, then there is no point in delaying according to me. Because earlier you get at it, I find state of the liver when you operation on at the laparoscopic see is far better than what you see at the end of the day.
Yeah, so we have operated at the age of 15-20 days, but just want to know from the house, means you do whatever investigations, and we did not go, means we could have gone on 10th day also, but I was not sure.
So what is the justification in waiting?
I agree with you. I agree with you.
What is that Ted Howard has designed? My personal experience is that to get a very excellent post operation to the extent of but honestly by the I did that these patients for half of them later on develop and that was the thing because
Sir, yeah. Thank you, Raju. Nice presentation. Just I want to tell everyone, at least my junior colleague, that before 1991, we came to for hepatobiliary workshop at AIIMS, New Delhi. Before that time, there was no cutting of the left and right triangular ligament, and we were assisting from the head end. We were not able to see anything. But in that workshop, only we learned that we have to cut the both triangular ligament, and then it comes like a book on the anterior abdominal wall. This is the first thing. That is most important step in biliary atresia if you want to do the good surgery. You have already shown it. And second thing regarding the anti-reflex valve, which that 2 centimeter. Actually, we don't do any nipple-like valve anti-reflex valve. What we do when that Rowan while loop is going up and this is coming out, we just put 2-3 seromuscular switches here so that it becomes straight. So all the food will go down. It will not go up. That is the simple thing. 2-3 switches only, not nipple-like any anti-reflex. That's. Thank you very much.
First of all, I didn't have the chance to ask one comment to Redkar, and Dr. Ganguly, please allow me, was that the dissection which you do between the right and left branches of the artery and go deeper, as Dr. Bhatnagar also pointed out. So when you go, so what percentage of your patients you are able to retrieve the ducts, and between the two groups, younger and older patients, is there a difference that you are able to get it more in older patients despite late presenters? Because it's important. It gives a point that, as you said, that we don't get babies very early. And therefore, if we focus on dissection into the parenchyma more frequently, we are likely to get more ducts. Do you have that, the answer to that question? And as Dr. Bhatnagar pointed out, just like we do ureteroscopy, there is a very high incidence of failure because parenchyma grows. Liver can grow also and due to cause obstruction. Thus, QSA dissection comes into the framework. It's very important, actually. Please.
Yes.
Sorry, Doctor, I had just overbreached, but I was very.
Thank you very much. So, the answer to that question is in histopathologists. I am very meticulous in going to the histopathologist and studying the portal plate. It is marked and sent to the histopathologist. And then we have acquired a micrometer for measuring the bile ducts. Because on table, it is very rarely that you see the bile ducts. As Professor Bhatnagar was saying, you see the bile or the lymph containing the bile coming out, but very rarely you see the ducts. But when you go to the histopathologist, you will clearly see, we have classified them into three types: less than 100 microns, 100 to 250 microns, and more than 250 microns. So there are these three categories, and one of my colleagues is going to present our data on that. We have come out with a score there. The second point in histopathology that we see is whether, see, there are three types of biliary atresias. One where you see cyst macroscopically, one where you see angry biliary atresia, which means there is an inflammation there, and one where there is a burnt out. So if there is inflammation seen in the patients on histopathology with acute inflammatory markers, those are the ones that do well to post-operative steroids. This is all I was saying.
May I ask the hall, the audience here?
Yeah, but Rajiv, just one point I want to reiterate. The age of Kasai has now changed. The recent data says earlier is better, so 30 days should be the cutoff instead of going to the 60 days. No, this is just a comment. No rebuttal required.
One, I wanted this audience to applaud the teacher of teachers regarding biliary atresia. Varesh is right in front of us. I sat with Varesh to understand the depth and all that, and probably Richa was the one who had learned this from him, who eventually taught me, and whatever little doubts I had, I sat with Varesh for many hours to understand the nuisances. And thank you very much, Varesh.
We have actually breaching time. You can give him glorious comment in the oration. He is getting an oration, so I think no other word can parallel your comment. But anyway, you can let us have a scientific comment and we move on.
The scientific comment is one more thing which I wish to say is that for the patients who have got congenital biliary, sure, the days have come down to 30. But we haven't talked about the post-CMV, where the results come better even if you operate beyond 90 days for Kasai's. So, I mean, probably we need to kind of differentiate these two conditions, the one which is the patients born with biliary atresia and the ones which get infected with CMV and eventually have biliary atresia.
I think now we should stop this discussion and then proceed for the next speaker, Dr. Anshu Srivastava.
Thank you so much, sir. Now I would like to call upon Professor Anshu Srivastava, ma'am, who is a professor, Department of Pediatric Gastroenterology, SGPGI, Lucknow. Ma'am's key area of interest are inflammatory bowel disease, autoimmune liver disease, liver failure and its complications, cholestatic disorders. Ma'am is going to deliver a talk on post-Kasai issues in biliary atresia. Over to you, ma'am.
Second. Maybe. Next.
Thank you.
Thank you, Chairpersons. The topic which has been allocated to me is post-Kasai issues in biliary atresia. As we all know that biliary atresia is one of the commonest conditions or causes of neonatal cholestasis, but now we are basically recognizing multiple subtypes. One is the syndromic biliary atresia, which has got the basum malformation, and we need to know this because they are at a much higher risk of developing hepatopulmonary syndrome as compared to the common garden biliary atresia. Then we have the CMV associated biliary atresia, which has got a predominant role of inflammation, and now there is an upcoming role of treatment for the CMV and improving the results. Then we have a cystic biliary atresia, where if antenatal ultrasounds are done, it can be detected much earlier, and so these patients may have a better outcome because of the early age of detection and surgery offered. And then the isolated biliary atresia, which is by far the majority, but still a very heterogeneous group. Over the last 2 decades, at least in the Western world, the outcome of biliary atresia has improved, and with or without transplant, we have nearly about 75 to 80% 20-year survival. It is, as we all know, I think biliary atresia is a lifelong disease, and that's a very important thing when we counsel these patients that a Cascipoton is not going to cure the child. So the parents need to identify that. And all efforts, as we have discussed, is that our target is that we make an early diagnosis, do a very good surgery, so that we can have a successful Cascipoton. Because a successful Casci will change the outcome for the child. After the Cascipoton, which is the topic which I have to cover, is that we have to try to detect the complications early, offer prompt therapy for complications, maintain good nutrition, which I'll be covering in detail, and then timely consider for the liver transplant. And most of the patients, as in the next talk it would be discussed, would need a liver transplant either because a primary liver transplant because the child presented late, or after a Cascipoton, whether it is failed or successful. The failed ones would require it much earlier as compared to the successful one. So what are the main post-Cascipoton issues? One is cholangitis and intrahepatic bile aches, portal hypertension, pulmonary complications including hepatopulmonary, photopulmonary, cirrhotic cardiomyopathy, hepatic hydrothorax, issues related to nutrition and bone health, cognition, risk of hepatocellular carcinoma, development of various other complications of liver failure. And then obviously we need to prevent secondary insults by infections, by alcohol as they mature into adolescent and young adults. So what is the role of steroids? Can we improve the rates of Casci? Because we all know that our target is that we want to have a successful Cascipoton. So multiple studies have been done, and the meta-analysis of 7 studies, it basically showed that there is an increase of 10 to 15% extra clearance of jaundice in those infants who are operated before 70 days of age and those who have given a high dose of steroids. Now this extra dose, does it really translate, or extra clearance of jaundice, does this really translate into a better native liver survival? This is the data from the King's College, where they have shown that if you go even younger, as we have discussed, in those babies who are operated before 45 days of life and who are given a high dose of prednisolone, that's 5 milligram per kg, there the native liver survival has shown a significant improvement. So the younger the baby, the earlier the surgery, and we give a high dose steroid, now we are able to show that there may be an improvement with this high dose of steroids. Again, this is a study from China where they had 380 biliary atresia patients, and they showed that the 2-year native liver survival with high dose steroids was much higher as compared to the low dose steroid. But contrary to these 2 studies, in this 2021, this is a study from Singapore, where they showed that there is no difference in the rate of cholangitis or native liver survival, whether you give a low dose steroid or you give a high dose steroid. So I would say the jury is not out, but yes, there is a trend that in the babies where we are able to operate earlier, there may be a role of high dose steroids. It has been clearly shown that the age at Cascipoton, presence of fibrosis, liver stiffness measurement at 3 months, whether the baby had an episode of cholangitis within 3 months, and the jaundice clearance time. If you put these 5 factors in a nomogram, you can see what is the probability of native liver survival at 2 years. So these are the main risk factors which are going to predict the outcome, and all these of them would be known to us by 3 months of age, and we can very easily say whether this child is going to require or not require a liver transplant. Now, going to the first and most important complication is of cholangitis, which is seen roughly in about 50 to 90%. It's mostly in the first 2 years, and as we all know, we suspect it when there is fever, increase in jaundice, or the stools become pale, and there is signs of sepsis. What is recommended is that we have to try to prevent the early cholangitis, which is within the first month of life, because this has been shown to predict a prolonged jaundice clearance time. It increases the risk of recurrent cholangitis, and there is a very poor native liver survival. So and the second thing which increases the risk of cholangitis is when the babies develop intrahepatic cystic lesions post-Cascipoton. And it has been clearly shown that the earlier they develop, if they develop these cysts within 3 months, there is a much poorer native liver survival of 40% in comparison to those who are developing it 6 months after the potoenterostomy. So we need to monitor for these intrahepatic cystic lesions if we want to prognosticate or manage our patients better. Then, even in the long-term survivors, even in those patients who are living for more than 20 years with the native liver, it has been clearly shown that the patients who had late cholangitis required liver transplant much more often. So cholangitis is a very bad thing for these children with biliary atresia, and we need to make an effort to prevent or treat them early. So what can we do? We need to have a high index of suspicion in any febrile episode. Obviously, we'll need to treat it with IV fluids, antibiotics, antibiotic. There's a very small subgroup where in a very good braining anictic child, there is sudden onset of cholangitis. There may be a possibility of a rule loop obstruction. I think the people here are much more expert in looking at it as compared to me. And this is a very small group. There might be a role of a revision surgery. After the antibiotics, obviously, if the patient is going on with cholangitis, there is a role of ultrasound-guided drainage of abscesses and a PTCD for the bile lakes. And we should monitor for the intrahepatic cystic lesions at least within the 6 months after Casci, so as to predict the outcome. Now, is there any role of prophylactic antibiotics? Various people have used antibiotics like Septran, cephalosporin, quinolones, neomycin. But whom to treat? Should we treat only the ones who are having recurrent cholangitis, early cholangitis, or the ones with the bile lakes? Or should we treat all? There is no answer. How long should we treat? Should we treat it for 6 months, or should we treat it for 12 months, or should we treat it for 1 month? There is again no answer in the literature. The systemic review of 319 cases there and 1 randomized control trial showed contradictory results. But it has been shown that prophylactic antibiotic use is again associated with increased transplant-free survival. And most of the people believe that because cholangitis maximum episodes occur in 1 year, so if you are giving them antibiotics, it might be prudent to give it for a year. And definitely the babies who are developing early cholangitis or recurrent cholangitis or who are developing bile cysts, those patients definitely need prophylactic antibiotics. Now going on to portal hypertension. Portal hypertension is a complication which is present in the vast majority of children with Casci's potoenterostomy. Obviously, most of them have splenomegaly at diagnosis. In fact, 70% of them have high portal pressures even at the time of surgery. We recently had a patient whom we shifted for Casci potoenterostomy, and 2 days before the surgery, this child had a variceal bleed and was found to have grade 3 varices at 2 months of age. So it is a very common problem, and these patients can have ascites, variceal bleed, and higher risk of varices is there, and that also bleeding from the varices in patients who had failed Casci rather than successful. And again, portal hypertension in a large study has been shown increases the risk of developing cholangitis. So these 2 most important complications are interlinked with each other. Nearly 75% of the babies post Casci will develop varices. nearly 30% of them will bleed. And bleeding usually is beyond 6 to 9 months of age, but obviously some small subgroup can bleed earlier. And various methods have been used to non-invasively predict these varices, because we can't keep on doing endoscopies at 3 months, 6 months, 9 months. So platelet count, there are multiple formulae which have been used based on the platelet count, spleen size, albumin, and AST, which we all do routinely in our evaluation of these patients, to non-invasively predict the varices, and they have a nearly modest efficacy, about 80 to 70%, along with the measurement of the liver stiffness at various time points, whether it is at the time of 1 week after Cascipoton or 3 months, but these are useful to predict presence of high-grade varices, and they should be incorporated in our algorithm when we are following these patients. So management-wise, what we would suggest is that surveillance endoscopy can be done at 6 months in a patient who's having a failed Casci, around 6 to 9 months. In those who are successful, I would say around 1 to 1.5 years of age, and then they can be given treatment. Those who have got high-grade varices can be given prophylactic treatment. Variceal bleed has to be managed standard management, which we all do, along with antibiotics, that is endoscopic therapy. Endocytis obviously has to be managed, and splenic, if there is hypersplenism, then splenic embolization can be considered. Now, there are lots of pulmonary issues in patients with biliary atresia, and most important of them are hepatopulmonary syndrome, photopulmonary hypertension, and cirrhotic cardiomyopathy. Of roughly around 5 to 8% of biliary atresia patients also have coexisting congenital heart disease, which also needs to be tackled. So for the hepatopulmonary syndrome, the children may be asymptomatic, or they may have clubbing and cyanosis, so we should look for it when they are coming in follow-up. And a very simple test might be just to check their pulse ox saturation. If it is more than 96% and there's no clubbing or cyanosis, we can say with reasonable accuracy that our child does not have hepatopulmonary syndrome. If we are suspecting, it is seen in roughly about 4 to 64% patients of biliary atresia, much higher for some unknown reason in those children who have got the biliary atresia splenic malformation. And to diagnose, we have to do a blood gas followed by a saline agitated echocardiography, which will help us make the diagnosis. Why is it important? Because once the child has developed hepatopulmonary syndrome, you have to, for mandatory reasons, consider him for liver transplant. There is no other treatment for hepatopulmonary syndrome. The second complication is of portopulmonary hypertension, which is basically pulmonary hypertension in the presence of portal hypertension. These children may present to you with just exertional dyspnea, and that would be diagnosed by echocardiography, which shows that there is high portal artery pressure, and then you have to do a right heart catheterization. We can try medical management like sildenafil, epoprostenol, but these are all again not going to work wonders, and we have to offer early transplant provided the pulmonary artery pressures are within reasonable limits. If it goes beyond 40, 45, then even a transplant might be a contraindication. Hepatocellular carcinomas are seen in about 1% of children with biliary atresia, and they are many a times picked up in the explanted livers. Liver ultrasound and alpha-fetoprotein should be done every 6 months when we are following these patients. And sometimes the problem here might be that these patients have a lot of focal nodular hyperplasia, which may be misdiagnosed, and alpha-fetoprotein may be normal. Therefore, if there is any suspicious lesion and you have repeated an ultrasound and it's increasing in size, you should do a prompt evaluation with a CT angio, because that will pick up your Ptcc quickly. And again, because all patients have end-stage liver disease at the time these children are picked up, again, liver transplant is the only viable treatment if you're picking up Ptcc. Now, coming to nutrition, obviously that's the most important parameter, because either both the outcome of the child as such as well as the post-transplant outcome depends upon the nutrition. So we have to give them adequate calories because they are cholestatic. We give them medium chain triglyceride supplementation. We give them fat-soluble vitamins and calcium. Need to remember that metabolic bone disease causing fractures with minimal trauma is common in these patients, even if they are not jaundiced. And so there might be a recommendation to do a bone densitometry every 5 years and detect early Osteopenia. If a small subset develops pruritus, we manage them. The basin patients, definitely you have to make sure that they are getting the pneumococcus and meningococcus vaccines because they are immunocompromised and they have higher risk. And in any other child also, we would make an attempt to do a routine and extended vaccines for these patients. And we need to educate them as they are going towards puberty about avoiding alcohol, hepatotoxic drug, and IV drugs because they will increase the chances of getting further liver injury. So how do we do this post-Kasai screening? I would recommend that we do a liver function test, hemogram every 3 to 6 months. We assess for cholangitis. We do ultrasound for bile lakes. We do a screening endoscopy depending upon the success of Kasai at 12 months or 6 months earlier if the patient is not doing well. We offer prophylactic endotherapy. We screen for HPS by measuring the saturation every visit and ABG once a year. An alpha-fetoprotein and an ultrasound every 6 to 12 months. We monitor their growth and we do their vitamin D status and bone scan as and when required depending upon the clinical status. Now, after talking about what we need to do, what is the real world scenario? This is a recent study where they surveyed the European centers, including UK, who performed the Cascipoton enterostomy, and the jaundice clearance rates varied from 30% to more than 60%. And there was no consensus on what is a standard adjuvant drug treatment regimen that you will offer to the children once they have undergone a Cascipoton enterostomy. Steroids were given by 60% of the centers, but again, variable dose and duration, which could range from 4 weeks to 6 months, but on an average about 3 months. Only 20% would repeat a course of steroid with a bad cholangitis, but none were wanting to give repeated courses of steroids for treatment of cholangitis or refractory cholangitis. Perioperative antibiotics were given by all centers, and most of them favored piperacillin, tazobactam, and gentamicin for a variable period of 1 to 2 weeks. Prophylactic antibiotics were given by 70%, again, roughly around 6 months, but again, it varied from 1 month to a year, and Septron was used most often, followed by cephalosporins. UDCA was given by 100% of the centers, and few centers still continue to use phenobarb and cholestyramine. Testing for viral serology to detect the CMV positive group was done by majority, 70% of the centers, but only half of them believed in giving antiviral therapy to those who were CMV positive. None were using IVIG or any herbal or traditional Chinese medication. So to conclude, I would like to say that biliary atresia patients need lifelong monitoring on a regular basis with either I would say with a team of hepatologist and surgeon together. Clearance of jaundice is the objective metric to judge the efficacy of the Cascipoton enterostomy, and we all should make an effort to diagnose them as early as possible and offer surgery as early as possible, because that's the only factor. Early diagnosis and surgery by expert, which would improve the success of Cascipoton enterostomy, especially because failed Cascipoton enterostomy has a universally poor outcome. Complications like ascites, variceal bleed, and infection and cholangitis need prompt treatment. We use steroids, UDCA, and prophylactic antibiotics, but there's still no consensus on the duration. And early consideration for liver transplant will go a long way for improving the outcome. And we need more research and more randomized control trials so that we can say, okay, this is what works and this does not work to improve the outcome. Thank you very much.
So thank you, Anshu. That was a very informative talk, and I think it's very important to look after patients even after the Kasais. Two things emerge. One is after the Kasai, the bile is flowing into the intestines. A lot of problems are sorted out, particularly all the fat-soluble vitamins and things of that kind. The problem arises when bile is not flowing into the intestine. That is where all the nutritional problems happen, and that is where the patients become slightly poor risk patients even for liver transplantation. Sanjay will bear me out. So we did a lot of studies on that. Sailesh Solanki is here. He's published those papers. Apart from the nutrition and the fat-soluble vitamins, I think we also need to look at trace elements. We also need to look at micronutrients because these are very obviously deficient in patients where particularly the Kasai has failed. So that is something again, I think it is mandatory. Whoever is looking after the patient, whether it's the pediatric surgeon or whether it's the pediatric hepatologist, we have to keep those patients well prepared for a liver transplantation health-wise. The second thing is that we talked about the hepatopulmonary syndromes. You talked about the echo. There's a modification of the echo, and we've done a study on that. It's a very simple technique. You take 5 ml of saline in a syringe, shake it vigorously so that you produce micro bubbles in it. And before you do the echocardiogram, just inject it into the vein and then do the echo. The echo will pick up right to intrapulmonary, right to left shunting absolutely clearly. And even before the obvious manifestation of these hepatopulmonary symptoms, you can pick up intrapulmonary right to left shunting, and that is known to be a marker for putting a patient on the liver transplant list. So you can actually put a patient on the liver transplant list much before the patient starts deteriorating. Thank you.
Can I ask?
Can I just say, so this saline agitated echo is the standard method for diagnosing hepatopulmonary syndrome, and we look at the cycles at which it has appeared. If there's an intracardiac shunt, it will appear within the 3 cycles. If there's no and it is a pulmonary shunting, it will appear within the 3 to 6 cycles.
Dr. Anshu, first of all, Dr. Rita, please go ahead.
I enjoyed a lovely presentation, Dr. Anshu. One of the complications, or maybe I don't know whether it is sequelae that I notice, is a lot of patients who are operated or otherwise have itching as a problem. They spend sleepless nights itching themselves. Have you had this experience, one, and do you treat the itching by any methods?
Yeah, so itching obviously is because of the cholestasis. So, but for some, it would also depend upon if there is a very good bile drainage, the itching would be less. If it is a partially successful, the itching would be more. And we do treat them with the regular medications that we use for cholestatic itch. So we'll start with UDCA, rifampicin, cholestyramine, antihistaminic, sertraline, naloxone, and then obviously if it's not refractory, it is going towards refractory, then it will become an indication for a liver transplant also. So we go stepwise and we look at it. Apart from the conservative measures which work a lot, is that to avoid the dry skin, moisturize very well, because that helps a lot in the itching, and apart nail trimming and all those are like the non-medical things which we will advise the parents.
A quick comment, and maybe you can also chip in that we are all into a gray zone because there are many things which are still not settled. But you are mentioning about the study where long-term steroids are giving of 253 days, which is roughly about 8.5 months or so, and also a year of antibiotic. Now, and then you don't give it. Was it this time period was it by default, or is it a planned study, number one? Number two, what does it do? Does it maintain, by maintaining good flow for a period of time, as we know it's a progressive disease, does it arrest the process? And it's important because long antibiotic, prolonged antibiotics and choleretics like steroid may lead to antimicrobial resist, AMR kind of conditions, also fungal infections and all. But in a grim situation like biliary atresia, if you can establish bile flow, everything can be a good trade-off. So just your comment on this.
For the steroid trial, people have used it from 1 week to 3 months. And obviously, these are all patients where they have not gone and done histopathology to see what is the mechanism, but they have given the high dose steroid for 1 to 2 weeks, and then they have tapered it and got down to nil steroids by 3 months of age. As far as the antibiotics are concerned, there are studies where they have used antibiotics cyclical, like not just one antibiotic. So they'll give Ceftriaxone, then they'll give Cephalexin, then they'll give one more, then a gap of 1 week, and then. So that's what we say as cyclical antibiotics. There is a definite growing concern of developing resistant bugs, but again, no one has gone ahead and done the stool microbiota analysis to see whether they are developing resistant organisms or not. That kind of literature is not available. And that is the reason that there is no consensus whether you would give it for 1 month or you would give it for 1 year, and various centers are practicing their own policies in which they believe in.
So I think the most authoritative study on the use of steroids came from the King's College group. And I think they've looked at steroids from all angles, low dose, high dose, short period, long period. And I think the end result was that they have said that post-operative steroids do not help. And,
Sir, that is what the King's College group, especially the recent papers from Mark Davenport,
yeah.
all of them are saying that we use steroids and steroids have to be used. They have come up with a subgroup analysis that the younger patients who are operated at less than 70 days of life and the ones where you are giving high dose steroids, that is a subgroup which will benefit by giving steroids. And that is why if you read last 3 years, any papers which are coming out from the King's College group, they have given steroids in all their patients.
I'm glad you retorted to that, because there's always been a flip-flop as far as the use of steroids go.
Yeah.
So I don't think we still have a final word on
No, we don't have. That's what I told you, that there is no consensus on what to give. 60% of the European and the UK centers are giving steroids. The American people are not giving steroids because their study, which they did, the START trial, that showed that in follow-up, these patients who were given high-dose steroids had some growth failure in their weight, height, and head circumference Z scores. And so the Americans are not preferring steroids, the Europeans are preferring steroids. So the world is divided, and I think we have to pick and choose what we want to do. I can't say that because the literature is not suggesting in one direction.
So we have a prolonged discussion now. Anyway, the confusion is still existing whether you will give steroid or not. But recent literature, what Answers actually pointed out, that recent literature suggests steroids should be given to prolong the period by so that the delayed of transplantation is possible. Delayed transplantation give better result than early transplant. So that is the one of the things which is picked up in recent literature in 1920 onwards. So now let us conclude this session and we proceed on to next session. I will request Dr. Puja to cover this.
Thank you, ma'am, for walking us through the post-operative journey of Kasai patients. Now I would like to call upon Professor Sanjay Rao, sir, who is a senior consultant and head, Department of Pediatric Surgery, Narayana Health Hospitals, Bengaluru. Sir is a honorary secretary, Indian Association of Pediatric Surgery. Sir's key areas of interest are kidney and liver transplants in pediatrics, pediatric GI and hepatobiliary, pediatric urology, and solid tumors.
Dr. Sanjay is going to deliver on a talk which is most important in biliary atresia. We talk about the treatment of biliary atresia sequential surgery. First you do Kasai, and 75% of them ultimately will need a liver transplant. So we discuss about the Kasai. Now we are going to the second surgery, and the right person to speak about is Sanjay Rao, because he is deep into this transplant program. And you know, in the pediatric transplant, 50% are because of biliary atresia. Okay, Dr. Rao.
Good morning, Dr. Podar, other chairpersons on the dais, team from the UK, UP, IAPS. Thanks very much for having me here. It's my first visit to SGPGI, and it's a wonderful, wonderful facility you have. It's a pleasure. It's also fortuitous that today is 13th of August, and it's the Organ Donation Day, the World Organ Donation Day. And I think as surgeons, as physicians who look after children with chronic diseases, I think it becomes imperative that we are advocates for pediatric transplants, and we encourage organ donation across our society in whichever way, in whatever way that we can. So I think this is a very, very fortuitous day for giving this talk. So I will proceed to the next logical thing in biliary atresia, which is transplantation. A little bit of history, I think, is always useful to give perspective to what it is that we are doing. This is a beautiful book, and I think those of you who haven't read it, as a surgeon, even if it's not transplantation, it's just very, very motivating. I would recommend that you please read it. And the person who has done maximum for transplantation across the board, whether it is donor surgery, whether it is restriction surgery, whether it is organ retrieval, is this man, Thomas Starzl. And he reported the first organ transplant, the first liver transplant way back in 1963. And one of the children operated was a 3-year-old biliary atresia. Remember that this happened before the first Kasai report came. The first Kasai report came in 1968 with a 10-year follow-up. So 1967 was again a biliary atresia child when they had the first successful transplantation. So actually, transplantation for biliary atresia precedes Kasai in literature. Though obviously when Kasai reported, he already had 10 years of follow-up on his procedure. So over the next 3 decades, I think all these things have got refined. But as you can see from the previous discussions, a lot still needs to be addressed. In most countries today, or at least theoretically today, biliary atresia is not considered to be a fatal disease. The reality in our country is different. I will touch upon it towards the end of it. But in most developed societies, biliary atresia is no longer considered a fatal disease. Unfortunately, in our country, it's still very much a fatal disease. Now, let's go on from the Kasai. So, what is the native liver survival after biliary atresia? This was an old paper that came out way back in Lancet, and it says that if you transplant, you have about 80% survival. If you don't transplant, you only have about 50% native survival. This figure has moved up and down a few percentage points, but has really not changed dramatically. So a rule of thumb, about 50% of patients will survive long term with their native livers. They survive with native livers. They are not normal. So native liver survival is a euphemism. It is not that they are normal, but they survive as against those that are transplanted where there is a better survival. Okay. But definitely the photoenterostomy has improved survival because it has pushed mortality from where it used to happen in early infancy and childhood to much later where children can have other forms of treatment. All right. There is various pros and cons, various scores, various things that we have discussed over the morning about how to predict outcomes. To be fair, you cannot. There is only data that is available that came again way back in 2001 that if you operate early, more of them tend to survive on their native livers. If you operate late, less of them survive. This is a rule of thumb. It is not 100%. And we will address this when not to do Kasai a little later in the talk. So this is the only thing that we know for sure. Everything else is a little bit ifs and buts. So as far as possible, operate early. When you can safely get that kid in and out of a major operation. Don't take a newborn for Kasai procedure when you are not sure you can get that kid out of anesthesia and surgery, because the child might die of complications of the procedure rather than from the biliary atresia. So there has to be an optimal time, and that optimal time will vary, but definitely within the first 30 to 40 days, 45 days. So what happens to these patients who survive after Kasai photoenterostomy? As I said, the numbers vary. It is 60% somewhere, it is 70% somewhere, but they have significant morbidity. They are not normal. They have growth failure, they have symptomatic splenomegaly, they have portal hypertension, they are jaundiced, a lot of them have compensated cirrhosis. So they are getting on in life, but they are not normal and they continue to require medical attention. However, depending upon where you read, about 2/3 of patients or 70% of all biliary atresia patients will need a transplant when they are children in their pediatric age group, and the remaining maybe later on when they are young adults. However, what Kasai photoenterostomy has done, as I told you, has pushed that need for transplantation into older age groups and not when they are infants, when transplantation is more difficult, more challenging, and more difficult to manage. Therefore, Kasai today should be considered as a bridge to transplant rather than an end treatment by itself. Unfortunately, for a lot of patients in our country, that is all that we can have. So when we have to do it, we do it well, we try to optimize outcomes. How do we predict outcomes of Kasai? Again, there has been a lot of discussion. It's a very simple thing. Again, only the data that is hard and available is this. If you have a good POC at the end of 3 months, the chance of surviving on your own liver is about 85%. If your availability is more than 6 milligrams per deciliter at 3 months, the chance of survival on your liver is very low. Similarly, if you have cleared jaundice at 3 months, you have a good chance of maintaining your own liver for a long time. If you have not cleared jaundice by 3 months, very, very few people will survive their negative liver. So this is an easy rule of thumb. And from a practical point of view, it's easy to say that if you have done a Kasai today, at 3 months, if you have not cleared jaundice or the liver is high, this patient is unlikely to survive with negative liver. And you have to consider transplantation. That is all the message that I have to give. And I think from that point of view, this is a very important slide. Now, I will come back to this data a little later because I think it is illustrative of the point that I was trying to make. Today, and in most countries, in our cause of biliary. Right. So why the children with biliary atresia need liver transplantation? That will make it from the other way. There are a whole series of indications why they need. When you are down, in other words, you have done the Kasai has not worked well, then it is more likely that the indication for transplant would be persistent jaundice, would be recurrent cholangitis, or would be liver failure in younger children. As your Kasai works and if the child grows and becomes 5, 7, 8, 10 years, then the indication for transplantation might be gastroesophageal varices, resistant portal hypertension, severe hypersplenism. They become indications for transplantation in the older children. So as you can see, these are easier to manage than this and this. So the older your child gets, the better health he is in. So a well-done Kasai gives you that option. It gives you the option to push this into later childhood where the child is more robust and can withstand procedures in a better way. The other indications for transplantation, as I said, in our country, late diagnosis of biliary atresia is still a problem. I think Yogesh mentioned it. It is a problem. Despite whatever public education goes on, we still see significant number of patients coming late. That 100 days is a sort of, again, a rough figure. We will address that a little later. But when this child comes late, when you feel the liver, it is very hard. The patient has ascites, has evidence of portal hypertension. Then there is no point. This child has liver cirrhosis and portal hypertension, and Kasai is not going to fix that. All right. One of the other things that is useful is if you have a child coming with biliary atresia, child has got a prolonged INR, you are giving vitamin K, you give 3 doses, 5 doses, the coagulation does not get better. In other words, this child has no liver reserve. It's unlikely that this child will tolerate a Kasai procedure. You're likely to have high morbidity after these procedures. So these are probably children that you would think would require transplantation. Intractable pruritus, that was addressed a little earlier, is an indication, not common, but yes, it is possible. Hepatopulmonary syndrome, photopulmonary syndrome, all that has been discussed. Hepatic malignancy has been discussed, so we have gone over this already. Right, so you have done a Kasai today, and when do you decide that the Kasai has not worked and this child needs to go for transplantation? Because that becomes a very important question. Now, you might refer a patient to transplant unit if he has not had a Kasai, or you have explored the liver is cirrhotic, you have not proceeded. So there is no Kasai, they need to be referred at diagnosis. So you diagnose today, Kasai is not possible, refer to transplantation unit. You have done a Kasai, but there's an early post-operative failure. That means at the end of 3 months, your bilirubin is still high, the jaundice has not cleared, please refer to liver transplantation unit. If your Kasai has worked in the early years, follow up the patient very carefully as has been addressed. And if over time the patient develops decompensating liver disease, develops significant portal hypertension that is not easily controlled, develop significant nutritional deficiencies, develop things like hepatopulmonary syndrome, etc., it becomes an indication to refer. So at each stage, the indications change. All right. So, and that's how you decide which patient to refer on to transplant center. Please remember that referral to transplant center doesn't equate to transplant next day. It is just involving another team to optimize this child as we go forward. Generally speaking, across the board, this is a large Japanese cohort of almost 2,000 plus cases. The average age of operation is around 4 to 5 years of transplantation in their cohort. In our cohort, it's much younger. And it's potentially most children require transplantation in the first decade of life, a significant number in early infancy. In Japan, as I told you, their outcomes seem to be better generally, and those children come for transplants when they're a little older. Now, what happens when you send a patient to our unit or you send a patient to a transplant unit? What happens? We would recommend an early referral because it allows time to build rapport with the patient. These are all high-risk interventions and you need to build up a rapport. You can't get the patient today, operate tomorrow. You have to evaluate a donor and that takes time. Optimizing the child is extremely important. And despite whatever we say about nutritional rehabilitation, sarcopenia in these children at presentation is extremely high. It's extremely high. And in the community, these patients are not looked after, unfortunately. They are not looked after. They come to us in very poor shape. A lot of them have severe infections. They have cholangitis. They have bacterial peritonitis. So all these things have to be optimized. A lot of these children require an accelerated immunization protocol because you need to complete all alive vaccines before you transplant these children. You need time for evaluation. You need time for counseling. And most importantly, you need time to raise funds. So it's important that the referral be made early so that the transplant team then has time to build all this over the next few weeks or months and optimize the child's condition so that your outcomes are likely to be better. Now, I think this is important, and this goes on what previously was followed. The impact of sarcopenia in infants with liver transplantation, who come for liver transplantation, who have got biliary atresia. So it is extremely high. So when you have sarcopenia, they measured it by doing a CT scan and measuring the area of the psoas muscle. And when you have sarcopenia, your operating times are longer. You have a higher amount of blood loss. You have portal vein stenosis risk is high, bloodstream infection risks are high, and overall survival after transplantation is poorer when your child has sarcopenia. So I think as community doctors and as specialists sitting in institutions, we have to spread this message that these children have to be looked after. We should not treat them as a dead end case, because you don't know 5 years after the line, 5 years down the line, all governments might be sponsoring transplants. We do not know that. So our business is to keep them going until that point of time. So once they come to the transplant center, we select donors. In our setup, in most parts of Asia, about 90% of them are living donors. And I think biliary atresia patients are ideally suited, because they're ideally suited for a living donor left lateral segment, because the operation itself for the donor is of less extent. It's a smaller operation for the donor recovers faster, and it is optimal for the child. So this is, in our setup, this is the most common thing that we do. So a living donor left lateral segment. The other ones are available. So as I said, in our own experience, almost about 10% are disease donors, 90% are live donors, usually one of the parents. A little bit about the procedure. I will not go too much in detail, just about what is specific in biliary atresia as we go forward with transplantation. Anesthetic preparation, all of us are aware. We have discussed this in the past. You need good access. It's a long operation. You need invasive monitoring. Temperature regulation is very important, because the whole abdomen is lying open for hours together. There is a lot of fluid leaking here and there. So you have to maintain temperature. And once the patient gets hypothermic, they get acidotic. Once they get acidotic, their coagulation cycle goes off. Operating on them becomes very difficult. They get hypotensive. They don't respond to ionotropes. So managing them is very, very difficult if they get cold. So temperature regulation is extremely important. Point of care monitoring and testing is important. So today, if almost all tests can be done point of care. You don't need to send anything to the lab. All the required tests intra-op are done point of care. You must have adequate blood products. Now, the laparotomy, as far as possible, we will go in through the same incision that was made for the Kasai. If the child had a Kasai, often what happens is like what we discussed with pyloric stenosis, the scar climbs. Often the scar is at the subcostal area and you really cannot use it. You have to make another incision. But that again, it varies upon how the child is. This is the liver as how it looks. It is usually macronodular. It is very, very cirrhotic. There are a lot of bile lakes that are there here and there. The child has had previous Kasai, has had previous surgery. Sometimes they have had re-explorations. So the whole abdomen is stuck. They have portal hypertension. So each of the adhesion is vascular. So getting the explantation is a little difficult. So all these add up. So previous surgery, ascites, SBP, portal hypertension, they all make it a little more difficult as you go. Once the liver is mobilized, you can see the nice blood vessel. There is no biliary tree here because this is a child with biliary atresia. So here is the hepatic artery. Here is the portal vein. Then the liver is taken out. And once the liver is taken out, you have what is called an anapatic phase. That's the top IVC, bottom IVC. And then you have clamps on the portal vein and the hepatic artery. Now there is the whole circulation is clamped. Most of the children with biliary atresia have good portal hypertension, and because they have good portal hypertension, even if you clamp the IVC, nothing happens to their circulation because blood circulates through the collaterals and reaches the heart. So they tolerate this very well, as against those where we are doing it for metabolic disease where they have no portal hypertension. So in biliary atresia, this is really not too much of a problem of cross clamping. But ideally, you want to keep it as short as possible because blood is collecting in your infradiaphragmatic area. It is all becoming rich in acids and everything. So when you unclamp, all that acid and all that cold blood goes and hits the heart. So as far as possible, try to keep it as quick as short as possible. Meanwhile, the donor team is harvesting the organ. You do bench work, you prepare the organ, you perfuse it, you cool it down, you wash out all the blood, you do whatever venoplasties are required so that you can just go and put this liver into the patient. The liver is put in an orthotopic position, so it is put, the left lobe is put on the left side. If you're using right lobe, you put it on the right side under the diaphragm. So it's a very, very orthotopic kind of repair. So the process starts with IVC first. So usually what we try to do is a triangular anastomosis of the hepatic veins to the IVC on the anterior wall. You close off the native hepatic veins because often they are quite thin, often quite small because of the cirrhosis. So you do that first. You then do the portal vein. Now this is important because in portal vein, usually in biliary atresia, the portal vein is often very sclerotic because there is inflammation in the porta. and the portal vein is often very narrow. Often it is 2-3 millimeters in size. It is very, very thick walled, and you have a big discrepancy between the donor portal vein and the portal vein in the child. In addition, because they have a lot of portal hypertension, there is very little prograde flow towards the liver. So all the blood is going through collaterals. So when you put the liver and perfuse, no blood comes to the liver. So you need to optimize, you need to augment the portal flow to try and get more and more blood coming to perfuse the liver, because the two things, portal vein flow and hepatic artery flow, are important, because if they don't happen, then that graft dies. So it is important to do all this. So you do careful ligation of all collaterals. You do ligate the coronary vein, because often it's the major source of drainage. Sometimes you can even ligate the left renal vein, because in all your shunts, it's coming through splenic vein, left renal vein, IVC. So again, there is enough collaterals and all the blood starts to come back. So you need to do all that. You might need to do some venoplasty to try and get good portal flow. And this is by far the most important step, as far as I think at this stage, to get things going and have a successful outcome. Once this is done, the clamps are opened, the liver is perfused only with portal blood. You wait for the anesthetist to catch up, correct all the, the acid, correct the electrolyte disturbances, correct the bleeding, and wait for some time till things settle down. And once that happens, you have hemostasis. You then go ahead and do the artery. We call our microvascular colleague comes and does the artery for us, because we used to do the arteries earlier. We had an unacceptably high level of hepatic artery thrombosis. So we have now moved to microvascular anastomosis. They come and do it with 9/10 or nylon under microscope. And since then we have had, touch wood, not too many hepatic artery thrombosis problem. Here in the hepatic artery as well is usually very, very enlarged, because it is cirrhotic. There is no portal flow. Compensatory hepatic artery enlargement takes place. These patients often have high amounts of cholesterol, so they have plaques. So these arteries also are not normal. They are quite friable and they need careful handling. Once that is done, you do the biliary enteric anastomosis. This is standard. All of us are very familiar. The same type of anastomosis that you would do for a colorectal cyst, for example, multiple interrupted sutures onto the old pre-existing rule loop. Oftentimes the rule loop gets short because there is no bile flowing through it. So what you leave as 40 centimeters at the time of operation, when it comes for transplant, is hardly 10-15 centimeters. So sometimes it needs to be mobilized, sometimes it needs to be freed up, and the reloop needs to be modified before you can actually use it. Once you finish closure and you shift the patient, usually basically a lot of it is hemodynamic monitoring, fluid electrolyte monitoring, sepsis surveillance. But these are standard now, and most intensive care units are perfectly capable of looking after these children. Usually after a period of time, over a matter of 1 or 2 days, things start to settle down. If your liver is working, things get better and the child rapidly recovers. Usual ICU stay is about 7 to 10 days. Usual hospital stay all put together is about 4 to 6 weeks. So how is liver transplant in biliary atresia different than those for non-biliary atresia? Now this is our data. So as you can see, the patients who undergo transplantation for biliary atresia are much younger than those who undergo transplant for other indications. So they are much younger. Similarly, they are much smaller. So our average weight is only 8 kilograms, as against somebody who is much bigger. Similarly, most patients who have biliary atresia undergo living donor transplants in our hands, because that is by far the easiest to do, and you can do it when the baby needs it. Whereas most other diseases which are metabolic, the patient can afford to wait for a cadaveric graft, and some more cadaveric grafts can be used when you have metabolic diseases, when there is no urgency. All the other complications are more or less the same. So despite it being a more difficult operation and more technically challenging, outcomes are similar between the biliary atresia and non-biliary atresia group. Similar data has come from Korea. And similarly, when you transplant primarily and when you transplant after Cascipoton enterostomy, there is no difference. So by doing a Cascipoton enterostomy before, you are not in any way damaging the child's chances after a transplantation. So Casci is something that is advocated without too much doubt. Again here, the risk of complications are higher when you do a Casci and then patient has transplants, but overall outcome really it does not make any difference. They are all more or less same. So the having a Casci done before does not damage or influence the outcomes of liver transplantation. The same message is being conveyed here as well. Now, I will summarize by a few questions that we get asked repeatedly. The first question that we get asked is, I have this child. I feel the child is a little older. Should I do a Casci? Now, I think the answer to that question is a very, very forceful yes. You please attempt a Casci unless there are serious contraindications. If your diagnosis has changed from biliary atresia to cirrhosis with portal hypertension, Casci is not going to work. But if your diagnosis is still biliary atresia, please attempt a Casci. Even if the child is 70 days, 80 days, as far as you have it set up where you can look after these children. The last thing you want is to attempt a borderline Kasai and then lose the patient from surgical complications. That's not what you want. So how much risk you're willing to take will depend upon the institution that you're working in. But as far as possible, please perform a Kasai when it is indicated. Don't take somebody with cirrhotic liver, with ascites, portal hypertension for Kasai as an exercise. Chalo kuch nahi hai, chalo karo. Patient is going to die. That's not the right way to do it. And unfortunately, that is how it is. We trained in that background. Unfortunately, the first Kasai I did was in a grossly cirrhotic patient. So I think that's how it is, and I'm sure it continues. Why do I say that? Because it extends survival and pushes the need for transplantation into later childhood or young adulthood, where the child has a much better chance of receiving the transplant and surviving it successfully. The second part is having a Kasai does not influence the outcomes of liver transplantation. So the outcomes are as good. All right. So it is important because it does delay the need for transplantation when in older children. However, this is a theoretical concept in the assumption that most children will get a transplantation. In our country, unfortunately, that is not the case. Out of 78 children with biliary atresia over a 5-year period, ultimately, the only patients who survived were 20 plus 15, 35 plus 9, which is 44. So it's about 60%, of which some had transplant and some are native liver survivors. A lot of patients either died or were lost to follow-up, and this is an unfortunate reality in our practice. Despite having the technology, we are not able to offer it to more and more patients. So unless this becomes commonplace and every public institution does this on a regular basis, these numbers are not going to change. And I think that is the reason why I started by saying we must advocate for transplantation, we must advocate for organ donation. When not to proceed with Kasai, when the liver is cirrhotic, you know it is cirrhotic. Poor liver is and again, this is days, 60 days, 90 days, 100 days, age is just a number. So I think more important is this. If the liver is the liver that will recover, then please go ahead. If not, please not proceed. When do I refer a child for liver transplantation? I already alluded to this. Not to the Kasai, refer. If you do the Kasai at 3 months, your child has jaundice, is more than 2, refer. If your Kasai has what? Later on, the child has a problem. Cirrhosis, portal hypertension, chronic liver disease, hepatocellular syndrome. Keep it down. Therefore, they will send it back to you saying, no, we do not want to do it. All right. We must remember that when we keep talking about transplantation, pediatric recipients are special. They are different, and we have to factor in that in all our decision making, because we are giving this child lifelong burden of, they already have a lifelong burden of organ transplants and of multiple transplants, perhaps of organ failure. I think this was alluded to in the previous talk also. Once you have a chronic organ failure, it is with you for life. Whether you have a transplant, whether you don't have a transplant, you are a patient with an organ failure and your life has changed forever. So they already are carrying that burden. On top of that, we give them problems of immunosuppression. So that decision to transplant has to be very, very calculated, has to be very, very carefully done. Because immunosuppression, even today, has significant adverse effects. And you can imagine somebody's immune system we don't understand primarily. And from 6 months of age, 8 months of age, we start manipulating the immune system. We do not know what happens to these children going forward. A lot of them develop PTLD, they develop lymphoproliferative diseases, they develop metabolic syndromes, they develop renal dysfunction. So these are things that we have to be aware of. They have risks of infection, CMV, EBV, plus whatever other seasonal infections that all our children get living in a tropical country like ours. Significant number of them have developmental and psychological issues, and these need to be addressed as they grow older, especially during teenage. So this is a statement that is often repeated. Biliary atresia is now a treatable condition with up to 90% of infants expected to survive in centers offering sequential PE and liver transplantation. And this is a fact. The problem is the fact is not translated into practice, and it will remain like that as far as transplantation remains restricted to private institutions. It is only going to happen when it is taken up in a large enough format in public institutions where it is affordable, not only the transplant, but also care of these patients after transplantation, which actually is more challenging. The transplantation you can do, it's a one-time thing. So this is an important message. I will stop with this. This is Shreyas. Shreyas, we operated at about 65 days as biliary atresia. It worked partly at 2 years of age. He underwent transplant and he is now in engineering college and they do extremely well. He's not had one rejection, one cholangitis, one everything, but he is the exception. Otherwise, these children require a lot of work, but there is light at the end of the tunnel. So I'll stop here. Thank you very much.
So, Dr. Sanjay. Somebody who is doing it day in and day out would develop more insights than not. And therefore, some of the pearls which have spilled out.
One question which is hard to wonder and could be better than to see that you definitely reflect upon a situation in biliary atresia. We are not choosers. It's come to us. We know there are ones who do well and the ones who do not do well. And there will be some children who do well, they will be over 25% of that. As they grow up, and as you said strongly that as they grow up, they should earn that salary and they will be better candidates as far as technical part is concerned. There are many indications as they grow up and develop, which are a variation. Now, in terms of, I'll tell you my experience of patient treated for biliary atresia who came to the age of 2 adolescents and after that starting developing liver dysfunction. Almost all of them do. And therefore, would you like to draw a line? Consider decision. The care the child was not gone beyond a certain point where technicality will be taken care of. There won't be very minor microanastomosis, etc. Liver and vascularity will be handled very well now. Should be free and shifted to the left. And I'm correcting it to the situation which we finally threw up over the nation.
But better results in that group. We are likely to have more encouragement among youngsters to take up this, to do liver transplant, which is required more and more. And more it will be done, easier the techniques will become. As we have learned it through laparoscopy, starting with gallbladder, which was laparoscopy was difficult so many years ago. Now everybody wants to do it, easy, laps it up. From that angle, would you like to this philosophical question, which especially now wearing the hat of a national board and director, I want to really have your thoughts on it so that we can open up some doors for liver transplant training.
So when you say shift to left, you mean operate early? Is that what you're suggesting?
Beyond a point of older, when they become older and better candidates for technical part of the surgical intervention, instead of waiting forever will not help. They will all fall into the trap of liver transplant requirement. You should draw a line to do it regularly.
See, I think whatever it is, however good the transplantation is as a technique, it does carry a small but significant risk of mortality from the treatment itself. So today, the risk of mortality from liver transplantation in most centers is about 3 to 5%. So you have a 3 to 5% perioperative mortality. So that's a distinct possibility, and that unfortunately is difficult to predict. You think this child is so sick he will not make it, but he bounces back rapidly. You have somebody who's got metabolic disease, reasonably good health, and you think he will make it, but they suffer. They have a lot of difficulty. So at some point, we have to decide that the risk of the disease is worse than the risk of the transplantation. So where does the risk of the disease, which is from 3 to 5% operative mortality, when does the risk of disease become more than 3 to 5% or 10% or 15%? So there are scores we can use MELD scores, we can use PELD scores, we can use various things, but it will still be it is difficult at this point of time. I don't think there is data to objectify, because a lot of these things, for example, if we consider PELD score, MELD score, now they are only talking about liver reserve and liver disease. For example, somebody who has hepatopulmonary syndrome doesn't figure anywhere on that, but they might require transplantation for hepatopulmonary syndrome. So I think this will have to be something that goes on as time passes. The other challenge that we face here is that ours is predominantly a living donor program in Asia. In India, it's predominantly a living donor program. In the West, what happens is that because it is a cadaveric program, most of their transplants are cadavers. So they have fewer children cadaveric donors. So that's why when they say we push children towards being older when they have transplant, they have better access to cadaveric grafts. Whereas in our system, it's a little different. It is easier for the parent to donate when they are younger. When the baby is younger, the parent is younger, you require only left atrial segment.
If after 10-15 years, the parent also is another 15 years older, you require to take the right liver graft, the whole magnitude changes from the donor perspective. So these are challenges as well. And I think these are things that we will have to address as we go.
So, two aspects to this. One is the procedure of the country. We don't have category. The best where cadaveric donors are available fairly easily, they have now taken to splitting the liver. So one adult cadaveric donor, that liver will serve two patients, one adult and one child. The left lateral segment goes to the child and the right lobe goes to the adult. So that way, they have increased their the children with for cadaveric recipients, cadaveric donor recipients. The other aspect, which is again very relevant to our country, and you must understand this because there's a physiology behind it. Children who had a Kasai procedure done can present as an emergency. And that arises from acute hepatic necrosis. Now, this is something which is being seen and reported from the West. In fact, when I was at King's, I looked up their data and found it very interesting, and we published it. So what happens is that the liver, the cirrhotic liver, which appears to be compensated, is actually dependent on the hepatic arterial inflow, because the hepatic portal venous inflow is actually become centrifugal instead of being centripetal. So a situation arises where the child goes into sudden dehydration. In the West, a good summer day is one of the situations where it frequently happens. In India, an acute diarrheal episode can lead to the same kind of problem. So if you have a transient hypovolemia because of dehydration, the hepatic inflow through the arterial system will also suffer, and the child can decompensate into acute hepatic necrosis. Now, this is something which is relevant to both what Sanjay has been talking about and what Anshu has been talking about. We need to keep these children well hydrated, particularly during the episodes of diarrheal diseases. And secondly, the transplant surgeons have to be alert to this possibility, because some of them might present as an emergency for
I think splitting of liver is now happening on a fairly regular basis. So our transplant program, we split livers. So it's not frequent, but it does happen. So I think of our cohort, about 3 of them are split livers. It is interesting because in countries where split became mandatory, even today, for example, most places, the organ is allocated to an adult, and then the adult team decides whether that can be split. Now, when you do that, the number of splits are less. There was an area in Italy where they said the other way around. They said, unless you split, you cannot take. You justify why you are not splitting. So when they did that, the waiting period for a child waiting for liver transplantation, especially younger children, went down to 0. You would get a liver within 7 to 8 days. In America today, on the UNOS database, if you register a patient for liver, your waiting period is about 90 days. So here with this mandatory split, it came down to almost a week. So in which case, even acute failures, a lot of them, you were able to salvage with split livers. In our country, we are still a little away because most of our patients are obese, they have fatty livers, so there are a lot of other issues as well. But yes, splits is possible, and we have in our cohort as well about 3 of them who have had split livers.
I have one question to you. Is there any data available in your Indian centers doing the liver transplant? In other words, is there any registry for liver transplant in India?
There is no registry, but there are a lot of publications that has come from big units in Delhi, both the Medanta group and the group that is in which used to be in Apollo. There are lot of data available. There is also some pediatric data that is now coming out from Dr. Rela's group in Chennai. They have published their first biliary atresia 50 cases outcome. It came about a couple of years ago. So there are publications, but there is no registry, unfortunately. Yes, that's correct. That's correct. Yes, as I said, I think the referral to transplant center must not be made equal to transplant at that time. The referral to transplant center is more to do with optimization, with raising, so that once things are ready, because it's predominantly a live donor program. So you set up everything and then you transplant based on the child's medical requirement. Sometimes the transplant is done after a year after the child is referred, if the child is well compensated. So my the request is that I think our attitude towards biliary atresia and Kasai has to change. It has to be, we have to decide that yes, these are treatable. Maybe not today everybody has access. Maybe 10 years later people will have access. So let's keep kids going, till they have access, and which probably will happen in the times to come. Thank you.
Based on what kind of multiple states. We have Professor will speak in favor of the particular diagnosis.
No, you don't. Thank you, sir. We all love tug of war, and coming up will surely be a very lively session. A debate it is, and the topic is set right. The much argued topic from time immemorial, which doesn't yet have a clear consciousness. That is debate on hepaticoduodenostomy versus hepaticojejunostomy for bilioenteric anastomosis and choledochal cyst. Speakers for the same are two eminent pediatric surgeons, Professor Arvind Sinha sir, who will be speaking for hepaticoduodenostomy, and Dr. Rashik sir, who will be speaking for hepaticojejunostomy. Dr. Arvind Sinha sir is Professor and Head, Department of Pediatric Surgery, All India Institute of Medical Science, Jodhpur. Sir's key area of interest are robotic surgery and minimal invasive surgery. Sir has multiple publications and has authored several book chapters. Over to you, sir.
A very good morning to all of you. I think this is one of the burning topics of pediatric surgery, what to do, hepaticoduodenostomy versus Roux-en-Y hepaticojejunostomy as after choledochal cyst excision. So, and I mean, if you talk to people, they'll be self-righteous people talking very confidently that this is the only thing that we follow. I am no different. I also believe that hepaticoduodenostomy is the way to go, right? Hepaticojejunostomy, Roux-en-Y, has been the favored modality for reconstruction for decades. And however, hepaticoduodenostomy is coming into vogue, especially after laparoscopy has come in, right? So this is the type of reconstruction that we are debating. I am speaking on behalf of hepaticoduodenostomy, right? So I will discuss this topic under following headings: the physiology, the anatomy, the intraoperative ease that hepaticoduodenostomy gives us, early postoperative results, intermediate postoperative results, and why hepaticoduodenostomy is inelegant in my opinion, and they will summarize it, right? So we know this is the basic physiology that we see, right? And we know this hepaticoduodenostomy is as close to the normal physiological process that we can reconstruct to, right? So we know a pancreatic enzyme need to mix with bile, and this both mixing is required for proper digestion of fats, carbohydrates, and the hepaticojejunostomy teams basically treat duodenum like a conduit, right? That it believes is just there to pass the substance down to the jejunum, and it does not serve a purpose. However, bile and pancreatic juice works together to digest fat. And also coming on to the various anatomical factors, like Paneth cells are present in the duodenum, which actually have antimicrobial action, and that leads to one of the lowest concentration of microbial flora in both the stomach and the duodenum itself. And before anybody says that the duodenum, this difference of anatomy and physiology is theoretical, there are reports which say that Roux-en-Y can have impairment of fat metabolism and change of GI hormones may be there. And similarly, another study has quoted that increased maximal acid output may be seen after Roux-en-Y anastomosis, gastrin levels are increased, and a disturbance of fat and carbohydrate metabolism with high glucose and triglycerides may be seen after Roux-en-Y anastomosis. Then after covering intraoperative the anatomy and the physiology, let's go on to the intraoperative advantages of doing a hepaticoduodenoscopy. It's definitely easier to perform laparoscopically, can be performed entirely above the transverse colon, right? You don't need to go below the transverse colon, and therefore it reduces the risk of adhesive intestinal obstruction, and no disturbance in other quadrants are there. And we know that it can be done exclusively laparoscopically. Secondly, single anastomosis needs to be done as opposed to 3 anastomosis in a Roux-en-Y hepaticoduodenoscopy, and an easier learning curve is there. So the question I need to ask is, why punish yourself? If it is hepaticoduodenoscopy is simpler, why punish yourself by doing a Roux-en-Y? Right. So coming on to the early results, one of the good systematic reviews that came in 2021 with Gonzalez et al. This included 9 studies with 316 patients of hepaticoduodenoscopy and 246 patients with hepaticoduodenoscopy, and the operative time was found to be significantly lower. That is about 1.5 hours lower in favor of hepaticoduodenoscopy. Operative bleeding also about 50 ml less in favor of hepaticoduodenoscopy. Early post-operative results, time to normal diet generally is equal among both the groups. The length of hospital stay studies generally have shown a reduced length of hospital stay in patients undergoing hepaticoduodenoscopy, and the mean difference is about 2 days less, and that difference is significant. Post-operative bile leaks after both the types of procedure is similar in both techniques. However, study from Billiard, 8.5% incidence of biliary leak was seen in hepaticoduodenoscopy versus 2.8% in hepaticoduodenoscopy. Again, other post-operative complication, Jung et al. In 2019, in 54 patients, they said hepaticoduodenoscopy had a shorter operative time, less blood loss, shorter hospital stay, and they actually had a higher ICU stay for hepaticoduodenoscopy group. Then one of the important things that work in favor of hepaticoduodenoscopy is a lack of intestinal obstruction in the post-operative complications. There is an increased risk of adhesive intestinal obstruction following hepaticoduodenoscopy. Incidence in the systematic review and meta-analysis that we talked about was about 7.7%. Which is quite high. The Indian study quoted about 8.5% incidence of intestinal obstruction, and this is almost nil in cases following a hepaticoduodenoscopy. And hepaticoduodenoscopy is also associated with increased risk of complication due to Roux loop itself and anastomotic leak. Coming on to cholangitis, which is another feared complication after doing a hepaticoduodenoscopy. People have that apprehension. The systematic review showed us that only 9 out of 393 patients of hepaticoduodenoscopy had cholangitis, whereas it was similar, about 16 in 296 patients. The results are basically similar. However, it is tending in favor of hepaticoduodenoscopy. The Billiard study quoted a 11.4% incidence of cholangitis in hepaticoduodenoscopy and none in hepaticoduodenoscopy. So results are tending in favor of hepaticoduodenoscopy, though the results are not significant. Now, the big elephant in the room, what everyone talks about is biliary gastritis or gastritis following a hepaticoduodenoscopy, right? This or a duodenogastric reflux. Right, the systematic review found that the 15 patients out of 253 patients with hepaticoduodenoscopy had reflux. That is about 5.9% incidence. Another study in 2019 said that is 3 patients had gastritis, but all were due to H. pylori. Once they eradicated the H. pylori, the symptoms subsided. So theoretically, the closeness of hepaticoduodenostomy to the stomach makes reflux possible, but the clinical significance is not really very well enunciated or fleshed out. Most studies, what I looked into deeper, are flawed because they have not reported on symptomatology of gastritis, or they have very small sample size of 8 patients, 5 patients, or sometimes based only on investigation without taking into account symptomatology. Studies from Billiard said that no patient had reflux, and Lime et al. 2012, one of the largest studies of 400 patients of choroidal cysts, 8 out of 238 patients, that is 3.8% cases, had biliary gastritis, and these were seen only in early cases, which they operated. Once they modified the technique, these biliary gastritis reduced. Mukhopadhyay, another study, 3 out of 53 cases, which resolved on medications. And there were no reports of carcinoma due to cholangitis or gastritis. Anastomosis, what the Lee et al. Study suggested, anastomosis distal to the pylorus, at least 3 centimeters from the pylorus, will prevent, and a little more aggressive mobilization of the duodenum will prevent tension and prevent reflux. Stricture formation is another area where the studies have compared. The stricture rate seems to be similar with either of these procedures. Now, follow-up. Another advantage of doing a hepaticoduodenoscopy is easier post-operative endoscopic access for the anastomotic site for surveillance or intervention. Let's say stricture is there, you can dilate it, or if the stones are there, they can be removed by basketing, right? Whereas hepaticoduodenoscopy Roux-en-Y goes into a dead zone which cannot be accessed apart from a surgical technique. So hepaticoduodenoscopy, why is it inelegant? It's non-physiological with its attendant silent lifelong metabolic derangements and associated increased risk of anastomotic leak, complications of Roux-en-Y limb, and intestinal obstruction. Increased operative time is there, and length of hospital stay is also increased with hepaticoduodenoscopy, and it is technically difficult, especially after laparoscopy has come in. You have to have three phases of surgery in Roux-en-Y hepaticoduodenoscopy, and anastomotic sites are inaccessible to surveillance. And some studies have quoted that if all complications are taken into account, then there is a 3.6% higher chance of developing a complication with hepaticoduodenoscopy as opposed to hepaticoduodenoscopy. And other study has said that hepaticoduodenoscopy has superior short-term results, but the long-term results are equal to hepaticoduodenoscopy. So to conclude, hepaticoduodenoscopy is an effective and alternative to the conventional Roux-en-Y reconstruction and excision. It is not only effective alternative, it is more physiological, safer alternative. Biliary gastritis, I believe, is much ado about nothing, and proof of the pudding is in the eating. And if you look at the literature, more and more people are having the HD flavor, right, as opposed to HJ. And SD reconstruction is safe, feasible, with better short-term outcome and comparable long-term outcomes. Thank you.
Now we are going to have another person who is
Dr. Rashik Sir is the head department of surgery and senior pediatric surgeon at SRCC Children Hospital, Mumbai. Sir is a pioneer in minimal access pediatric surgery, pediatric oncosurgery, and pediatric urology. Sir has received multiple awards, delivered numerous guest lectures, published articles in peer-reviewed journals, national and international. Sir has a dedicated YouTube channel on pediatric minimal access surgery. Sir is a past president and honorary secretary of IAPS and Ptcc. Sir is a course director of Institute of Medical and Minimal Access Surgery Training Center, Mumbai. Thank you, sir.
Good afternoon. I think it's, yeah. Good afternoon, everybody. At the outset, I thank organizers for inviting me over here to participate in this interesting debate. So let's start. Arvind has presented well, and I'll see what we can do. Okay. Now, we will not go into the history, I think all of you know, but if we have to say, it started with laparoscopic cystectomy with hepatico-jejunostomy in 94, and then later on the hepatico-duodenostomy was started. There are advantages of laparoscopy surgery, same advantages are there. Now, drawback of hepatico-duodenostomy. Everything good Arvind has presented. The anastomotic leak. Why? Because the anastomosis at hepatico-duodenal site is under tension. Many times we want to go away from the pylorus. So the surgeon has that additional stress. The second problem is duodenogastric reflux, which can give rise to gastritis, esophagitis, cellular proliferation, and carcinoma. Then there is higher incidence of cholangitis due to reflux of the duodenal content into the bile duct, and which can lead to the stricture. Cholangiocarcinoma, stone formation. So all these are the problems with the hepatico-duodenostomy. Now, anastomotic leak. It can lead to peritonitis. We need to keep the patient fasting till it is healed. Often you have to put the patient on parenteral nutrition. It is stressful to the surgeon. Those who are doing hepatico-duodenostomy over here, and if it leaks, everyone knows it's stressful. When it will lead into peritonitis, you don't know. Sometimes the re-exploration is required with conversion to hepatico-jejunostomy. So salvage procedure for hepatico-duodenostomy is hepatico-jejunostomy. Then why only do it primarily when you know that that's the salvage? The anastomotic stricture, it is thought to be secondary to cholangitis, and cholangitis is secondary to reflux of duodenal contents into the bile ducts. And this is one of the large study where they presented about incidence of 12.5% at the age of, after 2 years, and it can even increase after that. Then very important is the duodenogastric reflux. There are huge articles, even adults and even in children, and we are trying to just ignore that when we are doing hepatico-duodenostomy. What it is, alkaline bile from duodenum refluxes into the stomach, and it leads to alkaline gastritis and esophagitis, which is resistant to even antacids and PPI. And this is one of the HIDA scan. If you see after hepatico-duodenostomy, how the hotspot has gone into the stomach. And now the another problem is, if you are doing early studies of HIDA or any other thing, you may not detect DGR, but as post-op period increases, something which is obtuse can become acute, and the chances of DGR will keep on increasing as you follow up the patient more and more. Complication and consequences of DGR, it creates irritation and inflammation of the gastric mucosa due to combination of hydrochloric acid. I want to tell a little bit about DGR because everybody needs to understand what exactly it is. With reflux of composition, which gives rise to extremely negative effect on the mucosa, also known as reflux gastritis, mixed gastritis, etc., and complications, gastroesophageal reflux disease, erosive gastritis, ulceration of the mucosa of the pyloric and antral part of the stomach, narrowing of the esophagus, and metaplasia of its mucosa with development of Barrett's esophagus, which increases the risk of development of the cancer, which can be in the stomach as well as esophagus. Now, the cancer is not going to happen in 1 year. It will happen after 20, 30, 40 years. So DGR today, we may say it is nothing is there. After 40 years, we may come to know that there are high chances of getting this kind of malignancy. These are the ways one can diagnose by doing HIDA, gastroscopy, and Bilitech device. So a lot of research has been done on this DGR, and the medical treatment is also been described, but often it does not work. And when it does not work, the medical treatment, there are the surgeries which are being advocated. So DGR you can't take lightly. There are duodenal switch operation, Roux-en-Y bypass, etc., etc. We'll go through some of the studies which are published. So this is one of the article comparing HJ versus HD. Very interesting. If you see the chances of mortality in hepaticoduodenostomy, the 2 patients died. I don't think any one of us wants to see the mortality. The one died because of cholangitis and another patient died of the anastomotic leak. Though there were anastomotic leak were there in 3 patients out of 68, one of them died. Then there are other complications which have been written, cholangitis, pancreatitis, etc. Ileus, obviously the ileus will be little more in HJ compared to HD, but if you can avoid the problem of DGR, I think it is worth having a couple of days of ileus. This is another paper which is reported by Hamada. Now they did 25 hepaticoduodenostomy. Of that, 8 patients lost to follow-up. The remaining 17 were studies. Now this is a long-term study after 10, 15, 20 years. And all of them had DGR. And 14 were symptomatic. Out of 17, 14 were symptomatic. 9 had severe. And 2 were already operated for stricture. And 7 other underwent revision by doing hepaticoduodenostomy. This is another paper which compared between HJ and HD, and the inference, the complication rate was quite high, 33%, and some of them needed revision. Now Liam, he has the largest experience. Arvind has already given the part of that, but what he is doing at present, he is doing single incision HJ, not HD. I could not get the study, but the personal communication, he has gone away from HD to HJ by doing single incision laparoscopically. The incidence of obstruction, post-op obstruction, if you are doing with laparoscopy either, you can reduce the chances of adhesive obstruction, even with HJ. And the second important part is that when you do study for DGR in first 1 or 2 years, it may come negative, but as the post-op period increases, and if you do DGR after study after 10, 15 years, it can be very high. And this is a paper which I have to say because it is from Lucknow, and they said that HJ is the gold standard. This is another paper from Bombay. Again, they had 1 patient which had a leak, needed re-exploration, and 2 patients had prolonged serous drainage, which we don't know whether it was anything with bile or not. So the anastomotic leaks are really a problem when you do HJ. Even HJ, when you do HJ, there can be anastomotic leak, but it is less stressful. It is a stressful, but less stressful. So drawback of hepaticoduodenostomy, as mentioned by Arvind also, it takes little longer time. I don't think 1 hour spending extra for 1 more anastomosis makes life any difficult. If I can save the misery of complication of HD, I think it is worth it. There are 2 anastomosis, and that's why it takes a little longer. There is higher incidence of post-op bowel obstruction, but that can be reduced if you do it laparoscopically. The only issue may be considered is that HJ is difficult to access like doing endoscopically. But if we do a meticulous wide anastomosis, chances of cholangitis stricture stone formation will be less. Thank you everybody.
Thank you, Dr. Shah, for your nice talk favoring hepaticoduodenostomy. Now we can have some question and comments because this is a debate, hepaticoduodenostomy, hepaticojejunostomy. Both of the speaker has given their view. So we need to draw a conclusion line. So,
thank you, Chairpersons. Nice points that you have listed out for hepaticoduodenostomy, Dr. Sir. One point I would like to rectify is the point that you highlighted in the intraoperative difficulty, where you have mentioned it as needing to be done in 3 phases, and there is one part extracorporeal. So it's not the case that we are doing it totally intracorporeally by using staplers. Even youngest we have done by 2 years, we have been able to do it. And the second point is that why hepaticojejunostomy or the traditional Roux-en-Y is, I would say, would stand the test of time, because even the transplant surgeons who are doing it, they are not opting for hepaticoduodenostomy. It's still the hepatico. So that probably endorses the reliability of hepaticojejunostomy, Roux-en-Y.
Yeah, I mean, doing it intraoperatively, the anastomosis obviously is another level of complexity.
Yeah.
Which,
yeah, I mean, I'm just adding on to that. I'm not saying there are clear-cut winners right now. Just to add on to the list.
Afternoon, everybody. Sir, like in between part, technicality while doing choledochal cyst excision and anastomosis, is there any kind of confluence, suppose wider than this diameter or that diameter, in which you prefer duodenostomy rather than jejunostomy? Because wider diameter, as some surgeons suggest, some seniors suggest, will lead to more of the reflux, or by more tension, which will favor us towards a jejunostomy rather than doing a duodenostomy. Are there some technical points in which, like, we can decide intraoperatively we should go for duodenostomy in this patient or jejunostomy in that? Take on from both of you, sir, regarding that.
I'll start off. Obviously, if the duodenum is coming under tension, that is not the right procedure. Hepaticoduodenostomy will not be the right procedure if the duodenum is under tension.
So how much cauterization you favor, like, to make it?
The literature suggests good complete cauterization so as to relieve all the tension which is possible, and that tends to reduce the biliary gastric reflex also and prevent any complications. 1 centimeter anastomosis, I think, is the general standard at which beyond which I think the complications of stricture and stenosis subsequently is safer. Your views.
I think broadly what Arvind says is right. You want to have wider anastomosis, as wide as possible, so you spatulate also. Only thing, how you do it. If the duct is a centimeter or so, you do interrupted sutures. If duct is larger than 1.5 centimeter, you put continuous sutures. That's the only difference.
So just a short comment. So as Rasik sir rightly pointed out, that I think more important than the long-term duodeноgastric reflex is the acute complication of leak. I'm talking about the leak. So in HJ, even if it leaks, you can feed the child and most of the leaks stop. But in HD, once it leaks, you are in a big mess. So I just want to ask Dr. Arvind that if the HD leaks, what is your approach? What do you do?
The salvage procedure for HD leak generally is a
hepatitis. Yeah, so you have to keep the child fasting, and it sometimes even worsens the, like you can wait for some time in HD if it leaks, but usually it does not stop.
I have done both HD and HJ, but after going through it, it appears that HJ is better. Now I also had a leak, couple of leak after laparoscopic hepaticoduodenostomy. We had put the patient on TPA. It took about 10 days to resolve in both the patients. But it is a stressful way, whatever we say. You don't know whether you will have to go in, and particularly being in a private, we are a little more answerable than governments. I mean, even in government, you are answerable, but there is a difference. There is a difference.
So we are also answerable, sir.
There is a difference. Whether we like it or not, there is a difference.
Yes. Sir, actually, in fact, just a point about government versus private. So HD, actually, you have to keep the patient a little longer in the hospital, because I have seen that most people who do HD will keep the child NPO for at least first 4 to 5 days. But like we do HJ routinely, whether we do lap or open or robotic, and we feed the child within 48 hours and child goes home on day 4 or day 5. So I think in private, HJ works better. That is a point in favor for private, because the child goes home faster, the cost of overall cost is less.
Private and public, just continue discussion.
Yeah. Okay.
Dr. Rao. Dr.
Yeah,
Rao.
can I?
I think I have a personal experience of one case. I think it resolved in about 7 to 8 days. It resolved on drainage, ultrasonographic drainage.
Just a query to both the participants, both the people who, Arvind and Rasik. What do you are you practicing what you preach, or your practice is a little different than what you are preaching? That's the first question. The second question, I think, is a lot is made out of this business of trying to access the anastomosis from below when you do hepatoduodenostomy. The few times we have tried, it is impossible. It is far easier to come from above in interventional radiology than trying to get a gastroenterologist to find that hole that is stenosed in the folds of duodenum. It doesn't work. I don't know. I mean, I probably defer to also the expertise of the gastroenterologist on the forum.
There was another point about accessing the jejunal loop. You can always leave an access loop which can attach to the anterior abdominal wall. I mean, you do an enterocyte anastomosis and not do an end-to-end anastomosis. Then it is very easy to access. That is a standard procedure for strictures.
I think we are 1.5 hours late. This is the first session. We are supposed to finish at 11. Now it is 12:30. We can keep on discussing because what I can recall, Dr. Arvind, during Dr. Arvind Sinha talk. Much of debate in it. Every prefers hepaticojejunostomy.
But we had a nice discussion on President,
Dr. Sarin.
2003, I was away, and one of my pool officer did hepaticojejunostomy, and through the window of the mesentery, the bowel herniated, and the patient died before I could reach Delhi. And that day I stopped doing HJ, and I've done HT now for almost 2 decades. Never had any problem, no leaks, never. Only one patient had abdominal pain for a little long, in which it was not debilitating pain, it was mild pain, but they used to come often. And without doing any studies, I offered them to revise, and they did hepaticojejunostomy. He still used to say that he's got issues, but I've never had any issues with HD all these years. And I do it all open, sorry.
Thank you very much. I think it was a good session. Dr. Mandelia, Dr. Upadhyay for putting up such a good session. Thank you. And all the speakers.
A heartfelt gratitude to all the speakers and chairpersons for a wonderful session. I now request Professor V. Bhatnagar sir to present a token of gratitude to Dr. Moinak Sain Sharma sir. I request Professor Gangopadhyay sir to present a token of gratitude to Professor Rajiv Redkar sir.
no problem. Whatever you said. Thank you.
Thank you, sir. I now request Professor Minu Bajpai, sir, to hand over token of gratitude to Professor Anshu Srivatsava, ma'am. Moinak, sir. Okay. Yes. Yeah. Dr. Moinak, sir, Shane Sharma, sir, will be taking on behalf of Anshu, ma'am. Sir, for Professor Sanjay Rao. I request Professor Sanjay Rao, sir, to kindly come on to the dais. Thank you, sir. Thank you, sir. I request Professor Ujjwal Podar, sir, to hand over token of gratitude to Professor Arvind Sinha, sir, and Dr. Rashik, sir. Professor Arvind Sinha, sir. Thank you, sir. Dr. Rashik, sir. I once again thank all the speakers. Now I request Padma Shri S.N. Kuril, sir, to hand over token of gratitude to Professor V. Bhatnagar, sir. I request Dr. Y.K. Sarin, sir, to please hand over the token of gratitude to Professor Gangopadhyay, sir. Sarin, sir, please. Sorry. I now request Professor Ram Samud, sir, to hand over token of gratitude to Professor Meenu Bajpai, sir. Okay. Okay, now I kindly request J.D. Rawat, sir, to hand over token of gratitude to Professor Meenu Bajpai, sir. I kindly request S. Chowdhury, sir, to hand over token of gratitude to Professor Ujjwal Podar, sir. Thank you, sirs.
So this concludes the session, and sorry for running really late. And we will have a very short 5-minute break, followed by inauguration, and we will have the oration before lunch, and the GI and Euro session will be after lunch. So we'll just reassemble after a quick tea break for the inauguration and oration. So just a break is enough.
Thank you so much.
Thank you, sir.
Thank you.
तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं
Thank you, sir. I now request Professor Basant Kumar, sir, to welcome the gathering.
Thank you, Pratibha. It's indeed a very great privilege for me to welcome such a great stalwart of pediatric surgeon in this hall. Honorable Chief Guest, my mentor, Professor Rajkumar sir, Head of Department Neurosurgery. Honorable President, Indian Association of Pediatric Surgeons, Professor Yogesh Kumar Sareen sir. Honorary Secretary Sanjay Rao sir, IPS, and my colleague Ankur. I welcome you all. Along with that, sorry, I am little bit frightened in front of my senior. Along with all the dignitary, my respected teachers, seniors, invited faculty, speakers, resident, and colleague. I welcome you all on this occasion of 5th annual Uttar Pradesh Uttarakhand chapter of Indian Association of Pediatric Surgeons in my institute. I hoping for excellent talk and gesture academic learning. You have already seen in first session, and it will continue till tomorrow. I welcome you all to enjoy Lucknow visit, not only this academic, but along with it, you can enjoy Lucknowi cuisines, chickens, tundi kebab also. Heartily, I welcome you all. Thank you.
Thank you, sir. I now request our Honorary Secretary IAPS, Dr. Sanjay Rao, sir, to share your words of wisdom with the delegates.
Thank you. I will share words, wisdom or not, I don't know. Thank you very much. I think it's heartening that there are 2 visits to UP in a matter of a couple of months, and both have been excellent opportunities for discussion, for meeting. The infrastructure, everything has been really, really nice. We enjoyed our visit to Varanasi for the PESI, and this as well coming close to its heels. So thank you very much. And it's nice to see a very vibrant association with all these meetings and everything. So it's been a pleasure. Thank you very much and all the best.
Thank you for the kind words, sir. I now request our Honorary President, IAPS, Professor Yogesh Sarin, sir, to kindly address the gathering.
Dr. Rajkumar, sir, the chief guest. I can identify at least 3 presidents, past presidents of IAPS sitting in a row, in the first row. So many other stalwarts sitting on the left. And I do remember few whom I would have loved to see today, but they're probably not on the chairs. And to top that all is Dr. Richa Lal. I had the opportunity to work with her. She was my pool officer way back in 1998, and I learned a lot from her, and I wish she was here. She was always part of faculty in my pediatric surgery update. She never said no. I wish she was here. I'm also missing Dr. A.K. Waklu, Dr. Ashish Waklu, Dr. Chuvani Gopal, and also less talked about, but there is another D.K. Gupta ji who used to work in BHU, and I happened to work with him in CMC Ludhiana. Absolute gentleman. It's a great honor to be here today. I missed, of course, I've been to SGPGI many times before. And I understand that this UP UK chapter had been almost a decade old now, but because of the COVID, this is only the 5th meeting they're having. And they've promised that they will make a big thing, and it has already got proved in the very first session. Very exciting session. And my own student, Arvind, made me proud. Thank you so much, Arvind. With these words, I acknowledge your hospitality, and Basant, you have been a great friend all these years. Thank you so much.
Thank you for the beautiful words, sir. I now request our chief guest, Professor Rajkumar, sir, to kindly address the gathering.
Well, good afternoon to all of you. Dignitaries on dais, vividly known President, Professor Yogesh Sarin, Professor Sanjay Rao, Secretary IAP, and the helmsman of today. So it's very pretty and growing in very prolific manner in SDPGI. That is none other than Professor Basant Kumar. I hope you must be enjoying his hospitality and deliberations. Organizing Secretary, Professor Ankur, and I can see at the dais very senior people, senior to me even. I can see Professor Meenu Bajpayee, Professor S.N. Kuril, Professor Ram Samuj, who had been 2 years senior to me at GSVM Medical College. And there are several other senior people I can see. I may not recall the name because the recall is one of the most difficult tasks at a time, because brain has its own process of concentrating, focusing, collecting and recalling the memory. Anyway, so I don't know how much time do I have to say something in this August gathering. But why I understand that it seems to be a new society, because it is only 4th or 5th meeting. And in 5th meeting, I can see the kind of glow, young people, a young scientist. The scientists say that one who stops learning, he and she grows older. Be it age 20, be it age 80. So one who stops learning, he is old. And who keeps on learning, he is always young. Be he or she 20 or be he or she 80. So it's a process of learning. And learning is something which comes by these conferences. Learning and acquiring the wisdom, these are, to have a knowledge is something different. To develop a wisdom is absolutely different paradigm. You know, today, in the age of internet, when everything is available, other day I was sitting in OPD and I asked one of my assistant professor to know the dose, pediatric dose in particular, for one newly designed anti-epileptic drug. He immediately opened his palm down. This is how the things have become. So I don't know where we are going with the addition of net, with the addition of knowledge, with the addition of so many sites, with the addition of Wikipedia. It seems that the entire world and education has come in hands. But then I can say, my dear friends, that the knowledge is knowledge. It can never be a wisdom. And wisdom is something different. Wisdom is different from knowledge. We know that tomato is a fruit. This is knowledge. But we do not put in fruit salad, that is the wisdom. This is a very funny example of, say, about the wisdom as knowledge. But this is how it is done. Well, as far as the surgery is concerned, pediatric super specialty surgery is something different. But as far as the surgical specialties are concerned, we had been known in our country had been known for the surgical specialties, say, even before 2900 years and 3000 years back. It is the period of King Harshvardhana, and it is the period of Ajatasattu, who was the king of Magad. You must be knowing that Magad once upon a time was ruled by very powerful, emphatic and most energetic kings of our country, and the country grew in prolific manner during the regime of King Asoka. Our boundaries were endless, and during that time the surgical specialties also grew up in our country. You might not be knowing, but today I will like to apprise you that that was the time when world did not know about the end of neurosurgery. Neurosurgery, as you know, I consider neurosurgery, heart surgery and pediatric surgery, these are the most difficult specialties, probably super specialties, because operating in a brain stem of a small little child is absolutely different in comparison to once you operate on the brain stem of a fully grown adult. Because the size is small, the structures are small, the structures are not well developed, morbid anatomy is there, and to identify the morbid anatomy is much difficult task for the surgeons as far as the surgery is concerned. But what I was going to tell about the period, say 6th century BC, when there was a surgeon, you might have heard it, please listen it, you may enjoy it later on. There was a surgeon named as Kumar Bhaksha, Jivaka Kumar Bhaksha. Jivak was a surgeon. You know, to my surprise, and I wrote a paper on this, it is available on the net because I have interest in Indian history, particularly in medical history. So I realized the time when people did not know as to what craniotomy is, how the surgery is performed. A merchant visited to Kumar Bhaksha, and he had headache for 7 years. Kumar Bhaksha examined this patient, and he found that there is something in brain. You know, that was the period when there was no CT available, no MRI available. Today, everything has been pushed to the corner with the addition of recent investigations. The clinical science has been pushed to the corners. People don't examine, people don't have patients to examine the patient to elicit the signs. And Kumar Baksha in 6th century BC detected and diagnosed that there is something wrong in the brain. And he detected that probably worms has infested in the brain. And Kumar Baksha, to your surprise, to my surprise, to the world surprise, to the everybody's surprise, performed a surgery in that patient. And he took out the two living worms from the brain. You think about the period when there were no antibiotics available. When barely there were 71 surgical instruments available in India. And India was the leading country. There was nowhere else, not America, it is US and blah, blah, blah. There was nothing, nowhere they were standing. At that time, Jivaka Kumar Baksha, a royal physician, a pioneer surgeon, a royal physician of 2 or 3 kings, including Ajasatru and I think king of Madhya Pradesh part, I don't know wo kya hai jahan, very popular place, I am forgetting the name. So this man performed the surgery and he acquired his training. During those days, the training, medical training was offered in duration of 16 years. It was from very beginning, not after intermediate or so. So 16 years training, Kumar Baksha could perform in 7 years. That was our country. Our country gave not only plastic surgery, our country gave so many things to this world. And it was not confined only to, say, neurosurgery. 11 types of surgeries were performed during that period. And King Bimbisar himself, do you know the King Bimbisar was a very renowned king of that time. He ruled country in a vivid manner and he held very big name on the earth of India. And he was suffering from the fistula pheno. And he was so ashamed because the blood staining had been there in his clothes, on the chair. So he stopped chairing the sessions with the public, with his ministers. Ultimately, Kumar Baksha was invited and he examined him and he diagnosed without investigation the fistula in the nose. And it operated successfully. The king Bimsar became like a das. It is written in the text. And mind it, these texts are not written in the way today they are written in journals. These are the anecdotal examples which have been taken from the treaties written by different Buddhist monks. So our country has always been rich in heritage. Our surgery, 11 types of the surgeries have been described in past. Think about 7th century BC, when there was no antibiotics, no instruments, no equipments, no gadget, no modern microscope, no tools for the diagnosis. At that time, it was the education, it was the clinical examination, it was the clinical history, it was the evaluation of the patient based on which the diagnoses were made, and surgery was also performed not only in earnest, but here also where billions and trillions of neurons are residing in our mind. And you know, the brain is one of the most complex organs, most difficult to understood with, and most energy consuming, more perplexing, most of the 20% requiring 20% of the output, cardiac output. It is one of the most indigenous organ probably to operate with, was so much difficult, but yet it was done on the earth of India. And so we had been the father in surgical fields also. It is different that today we have grown to the level of modernity. And of course, now we are taking the things from the Western world. Yet there are so many things which need to be done on the earth of our country. There are so many things to be shared with as far as the knowledge is concerned. Knowledge, in the words of Bacon was a philosopher. Knowledge is a power. Knowledge is a energy. Knowledge is a freedom. Knowledge is a wisdom. Knowledge is something without which neither we can survive nor the society can survive. And the conferences are the mode and ways of education. Education is such a powerful tool for enhancing one's knowledge, creating a wisdom. Should I stop? I think Basant wants me to stop. And I know I am a bad master. When I start speaking, it becomes difficult for me to stop. So if Basant wants anyway, so I will like to stop it here. But education is a continuous program. And with this, I think I just wish to convey that most of us, because the medicine is art, it is not a trade. Medicine is a calling, it's not a business, where the interaction of heart and mind is most important, and faith is something which is probably most required thing among the patients and colleagues in order to grow up. One medical scientist said that medicine is my legal wife and literature is my mistress. If I get tired with one, I pass night with other. I am not suggesting that you should pass your night with others, but at least as far as the medicine is concerned and literature is concerned, I think we should again render our mind's mentation and neurons against to the literature and studies in order to grow in prolific manner. And I think, as Basant has hinted, thank you very much to tolerate me for these many minutes, and thanks Basant for giving me this opportunity to again see the faces which were lying in some sorts of mind of mine, other than the growing and budding pediatric surgeons. Thank you very much.
Thank you so much, sir, for the rich words. We shall surely keep our learning going. I now request Dr. Ankur Mandelia, sir, to propose a vote of thanks.
Thank you. It's my proud privilege as the organizing secretary to propose the vote of thanks. At the outset, I would like to thank Professor Rajkumar sir for sharing his words of wisdom and about ancient Indian medical history. Very enlightening, sir. Thank you very much. And I'd like to thank Professor Basant, Professor Vijay, and the entire organizing team for working together for the last few months to make this event reality and a success. And without all our staff, all residents, all supporting staff, this event would not have been possible. So a big thank you to all of you. I would also like to thank all the media partners, the audiovisual team, the telemedicine people, our sponsors, also all the delegates and faculty, the stalwarts, who's who of pediatric surgery is here right in this hall. So thank you, sirs, for sparing your valuable time and coming to Lucknow to this institute and sharing your valuable talks with the audience and enlightening them. Thank you very much. Thank you. So this concludes the inauguration, and we'll straight away go to the oration as we are running a little behind time. Thank you again for participating in the this people. Follow slide कौन सी है? Please settle down. Please settle down at the back. Yeah. So we move on to the showstopper event of this meeting, which is the SOPA Waklu oration. This is a prestigious oration of the Uttar Pradesh Uttarakhand chapter of Indian Association of Pediatric Surgeons. It is in the name of two stalwarts and doyens of pediatric surgery from Uttar Pradesh, Professor Harishankar Osopa and Professor Avtar Kishan Waklu. The first oration was given in 2013 by Professor D.K. Gupta. It was conceived, I believe, as an idea by Professor Kuril and Professor Panjwani in a meeting in 2013. The second oration was given by Professor Mohan Abraham, and the third was given by Professor Kuril. This year's, the 2022 oration goes to Professor V. Bhatnagar. And to chair the oration, I will like to invite on stage. Unfortunately, Professor Waklu was supposed to join us, but due to personal commitments, he has not been able to join us. So first I invite Professor S.N. Kuril, Padma Shri awardee and a professor of pediatric surgery and ex-head of the department from KGMU Lucknow. Welcome, sir. Also, Professor Y.K. Sareen, who is our president of the Indian Association of Pediatric Surgery and director, professor and head of pediatric surgery at Lady Harding. Also, Professor Sanjay Rao, who is the secretary Indian Association of Pediatric Surgery and senior consultant at Head Narayana Health. Welcome, sir. It's a proud moment for me to introduce Professor Bhatnagar, who has been a teacher and mentor to me and who has an immense role to play in my professional growth, the growth of the Department of Pediatric Surgery at SGPGI right from its inception. Professor Bhatnagar joined AIIMS Delhi in 1971 as an undergraduate. Following MBBS in 1975, he did MS in General Surgery in 1979 and MCH in Pediatric Surgery in 1983. In 1984, he joined faculty as assistant professor and finally superannuated in 2018 as head of the Department of Pediatric Surgery at AIIMS after serving for 38 years. During his stay at AIIMS, he not only mastered the art and science of pediatric surgery, but also trained many pediatric surgeons who practice pediatric surgery the way it should be practiced, not only in India, but also around the world. His academic achievements include more than 100 research papers, more than 500 paper presentations, 350 publications in peer-reviewed journals, 35 book chapters, 300 guest lectures. In addition, he has performed more than 30 live operative demonstrations in institutes around India and also abroad. He was a senior Commonwealth Fellow during 1993-94 and worked in King's College Hospital, London, and acquired advanced surgical skills in hepatobiliary surgery and liver transplantation. He has received the prestigious IAPS UC Chakravarti Award, the Dr. M.S. Ramakrishnan Oration, the T. Dorairajan Gold Medal, Dr. R.K. Gandhi Gold Medal, and also delivered the Dylan Oration for the Tamil Nadu and Pondicherry chapter of pediatric surgery. Following superannuation from AIIMS, Sir was working with Shada University as Dean Research of the Medical Wing and as Professor of Pediatric Surgery. Currently, he is working as Professor in Pediatric Surgery and in charge of the PG education at the Employees State Insurance Medical College and Hospital, Faridabad, Haryana. I welcome you, sir, to deliver this oration. इसी से फ्लाइट चेंज हो गया आपकी इससे नहीं होगी उससे भी हो जाएगी
Thank you, Ankur, for those kind words. It is indeed an honor for me to deliver the Asopa Vakshu creation in the 5th annual conference of the Uttar Pradesh Uttarakhand chapter of Indian Association of Pediatric Surgeons. I have chosen the theme of choledochal cyst for this oration, and the emphasis is, metaphorically of course, on the roads less traveled. And I'll keep elaborating on this to tell you exactly what I mean by it. Before I actually start the oration, I have to pay my respects to the two greats on whose name this oration has been instituted. Professor Hari Shankar Asopa actually needs no introduction, at least in the field of pediatric surgery in Uttar Pradesh, in India, and even in the world. His achievements have been tremendous. He comes from an era from when things were actually quite basic, but he has achieved so many distinctions and accolades. I won't read out all of these, but to me, the most significant contribution of Dr. Asopa has been the techniques of surgery for hypospadias. And this has transformed the surgical treatment of hypospadias in many dimensions, not just in India, but across the world, to the extent that his techniques have been practiced by other people in their names as well. And some of his modifications have also been adapted across the world for people to follow. Professor Vakhlu, again, is a world-renowned personality, very popular in UP and in India. He has been instrumental in setup of pediatric surgery in not only in the state of UP, but particularly in the city of Lucknow, where he has created the Department of Pediatric Surgery and nurtured it till he superannuated, and now it is one of the leading centers of pediatric surgery in India. So I doff my hat to these two greats, and I thank the UP and UK chapter of the Indian Association of Pediatric Surgeons to give me this opportunity to speak under the names. So before we actually venture out onto the roads less traveled, we need to know where we stand. And therefore, I give a very brief review of what is known about choledochal cyst. I'm sure all of you know it in this audience, but just a little recap, particularly for the postgraduates and the younger generations, so that when we talk about the roads less traveled, you will have an exact idea of what we're trying to talk. So choledochal cyst, as we all know, is a rare anomaly. Oriental races are more prone to develop. In infancy, it can be confused with biliary atresia. Females are more often affected. The lesion, why it happens, has been studied, and a lot of facts which are known about it, but a lot of it is still very unclear. It may be also associated with biliary atresia, and we have seen 3 cases of biliary atresia, not the classical type of biliary atresia, but atresia of the extrahepatic bile ducts and the coexistence of a choledochal cyst. Now, this is separate from the bile lakes that we very often see in biliary atresia. This is a choledochal cyst which is proximal to the atresia of the common bile duct. We all know the clinical presentation, 3 main ways in which it presents: the mass, pain, jaundice. And now, of course, we have a 4th dimension, the antenatal diagnosis. The clinical presentation, as we know, and a lot of people have now come out with their publications, we actually lost the race to Professor Roy Chaudhary. He was from India, I think, the first to mention the differences between the under 1 year people with choledochal cyst and the older children. So there are significant differences in their presentation. We know of the complications and of the effects of the choledochal cyst on the liver, on the gallbladder, on the extrahepatic bile ducts, and in the pancreas as well. I will be speaking mainly on my experience from the period of 1983 to 2018. During this period, we've seen more than 100 cases of choledochal cyst. I have categorized their presentations and their features under the category of less than 1 year and more than 1 year. And as you can see, the differences as mentioned in the literature, we have also seen the same. The choledochal cysts have been classified. There are lots of classifications available. The most commonly followed one is the modified Todani's classification, which lists 5 different types of choledochal cysts. Carolius disease is also many a times referred to as a variant of choledochal cyst. But now there is a lot of literature available which says that possibly Carolius disease is a disease entity by itself and it should not be confused with choledochal cyst, but that is something which is different. Now, the surgery for choledochal cyst is quite standard. We have different methods of treatment for different phases of a choledochal cyst. The most definitive treatment, of course, is excision of the choledochal cyst and drainage of the bile into the intestines. Now, whether you do it by a hepaticoduodenostomy or a hepaticojejunostomy, we heard that lovely debate in the morning, but it is a debate, and it continues as a debate, and I think it will continue as a debate for some more time till we have definite answers. My practice has always been excision of the cyst and Roux-en-Y hepaticojejunostomy, and I have never had any troubles with it, and I never felt the need or the reason to change my techniques. Complications, of course, the main complications like cholangitis, pancreatitis, portal hypertension, malignancy, these are common to most of the hepatobiliary disease states, and that are also seen in choledochal cysts. So the thing is now, what we're talking about, what we metaphorically mean by roads less traveled, is essentially that you think out of the box, you get ideas, and you try and follow those ideas. And this is exactly what I mean by the roads less traveled. So we've looked at various features of choledochal cyst, and we have tried to address some of those issues. And these are some of the things that I'm going to talk about, like what happens to the liver in choledochal cyst. If there are liver changes with a choledochal cyst, what happens to them after the choledochal cyst has been treated? Does the quality of bile differ in the choledochal cyst as compared to a normal individual or other disease states? Does the pressure inside the choledochal cyst matter? And if it matters, how does it matter? We all know that the choledochopancreatic junction has many variations, and some of them which are listed as abnormal are frequently seen with choledochal cyst, and what happens to in that situation. Portal hypertension is mentioned as part of most hepatobiliary disease states, but in choledochal cyst it is presumed. There are reports, there have been, in fact, when I talk about it, I'll talk in a little more detail about the others' experience and our experience. So we'll take these issues one by one. When we looked at all these various factors, we did a number of studies. I think there are 14 or 15 studies, and most of them have been published. And what I'm going to talk to you about
is published data. So we begin with what happens to the liver in choledochal cyst. I mean, most of us, we operate on a choledochal cyst. The liver may or may not look absolutely normal. If the liver does not look normal, we generally end up taking a biopsy. Most of us would not take a biopsy if the liver looks normal. So in this study, which we did right in the beginning, when we started looking at different aspects of choledochal cyst, we took a liver biopsy. In most of these cases, we dug out the literature and we looked at the cases in which we had taken a liver biopsy. And surprisingly, even though the surface of the liver may have looked normal, we found that that the liver histologically had abnormalities. And this is what made us think as to what kind of abnormalities are there in the liver which is associated with the choledochal cyst. We looked at it in greater details, and this preliminary study told us that liver changes secondary to choledochal cyst are significant and almost universal. In the younger children, the smallest of the children, that is less than 1 year olds, these changes in the liver can actually progress to cirrhosis rather rapidly. And if a liver has cirrhosis, what does it mean? Does it mean that we have delayed the diagnosis, or does it mean that it's a severe disease in early presenters? So with this background, we looked at what happens to these liver changes in the post-operative period. So this study, again, we did over a period of time. We looked at the data in 46 patients as a prospective study. And we included children who are less than 12 years of age, but were diagnosed as choledochal cyst. We excluded children with previous surgery or who are associated with other hepatobiliary states. And the factors which we looked at were cholestasis, hepatocellular damage, parenchymal inflammation, bile duct proliferation, bile duct inflammation, central venous distension, and portal fibrosis. Now, these are standard classifications of the various changes with the respective grades, and we try to correlate our findings with these existing grading systems. The important thing to note here is that in the methodology, I mean, what pertains to for this particular talk is that we did a liver biopsy at the time of surgery, and we repeated a liver biopsy 6 months after the surgery to look at what happened to the liver 6 months after surgery. So in the preoperative liver biopsy, we found changes in all the livers. I mean, there was not one of these livers in these 46 patients which was absolutely normal. And these are some of the illustrative slides of what we saw in hepatocellular damage, in bile duct inflammation, cholestasis, which was seen as bile lakes, and portal fibrosis, which was seen as these yellow, the blue structures. So we tried to correlate these symptoms, and we found that in the children who were less than 1 year of age, hepatocellular damage and portal fibrosis were predominant. Children who had associated portal hypertension, hepatocellular damage, portal fibrosis, bile duct inflammation, and cholestasis were predominant. In children who manifested with cholangitis, cholestasis, bile duct proliferation, and bile duct inflammation were predominant. And similarly, there were predominant features with hepatomegaly, patients who presented with lump and or jaundice, and those who had an abnormal pancreaticobiliary junction. So we found that in the post-operative period, when we looked at the biopsies, we found reversal of these liver changes in a large number of patients. And as you can see, that the features in the liver which responded the maximum to operative surgery for choledochal cyst, hepatocellular damage, parenchymal inflammation, cholestasis, bile duct proliferation, portal fibrosis, and central venous distension were some of the features which showed significant improvement in the post-operative period. And therefore, what we concluded from the study was that the choledochal cyst is not just a disease of the bile duct, it is also a disease of the liver. And complications like cholangitis and portal hypertension increase the severity of liver damage. Infants with choledochal cyst have higher liver damage and merit early intervention. This was something which seemed obvious, but I mean, this is something which she proved categorically on its own merit. The pathological changes in the liver are quite similar to those which are seen in extrahepatic biliary atresia, at least in the early phases, but they differ in severity and mark the words that these are reversible after surgery, unlike biliary atresia, where most of the liver changes do not reverse even after successful Kasai procedure. So the next question was the bile which is contained in the choledochal cyst. So under normal circumstances, where the extrahepatic biliary tree is normal, the bile is produced in the liver, gets stored in the gallbladder, and is transmitted into the duodenum via the common bile duct, and that is where it acts in the process of digestion of what we eat. So this is, we picked it up from the literature. This is the normal composition of bile in terms of pH, sodium, potassium, calcium, bicarbonate, and various other factors. So when we look at the bile which was taken from the choledochal cyst itself, not from the gallbladder, but from the choledochal cyst, we found that there were definite changes as compared to what the normal bile is. And therefore, these abnormalities, we were actually at a loss to explain as to how these abnormalities can be explained. But when we look at the various factors, and then we also tried to correlate the abnormalities in bile with whether the intrahepatic bile ducts were dilated or not dilated, we found that the pH, amylase, lipase, calcium, these were significantly different as compared to normal bile, although other factors were also abnormal in comparison to the normal constituents of bile. And the only thing which we could understand from this was that we did not look at it, but from what we can understand is that there is a backflow of pancreatic fluid into the extrahepatic biliary ductal system, and some of these aspects of the bile composition can be explained on that. For example, normal bile would not have any amylase or lipase. So if you're finding amylase and lipase in the bile from the choledochal cyst, it means that the pancreatic juice is going across into the choledochal cyst via an abnormal pancreaticobiliary junction. This may have its own implications. And I guess, and I would like some of the younger people in this audience to take up these issues further and look at the various correlations which can be drawn from it. Now, it is a common observation when you are operating on a choledochal cyst. When you open the abdomen, you find it in different sizes. When you touch it, feel it, you find some of them are tense, some of them are not so tense. So obviously these things express the intrahepatic pressures within the choledochal cyst. Now, what does that imply? So we did this study and we measured the pressure inside the choledochal cyst by putting a wide bore needle, making sure that there is no spillage of bile across. We connected it to a pressure transducer and we measured the intracholedochal cyst pressure in millimeters of mercury, and we found that almost all the choledochal cysts had changes of pressure. And therefore we tried to see what it would mean. So when you look at some of the choledochal cysts, the pressure inside was very high. Some of them did not have a very high pressure. So we arbitrarily divided them into low pressure and high pressure systems. And we found that larger cysts tend to have lower intracholedochal cyst pressure. Long common channels tended to have a higher intracystic pressures. And abnormalities of the of the wall of the cyst was associated with lower intrahepatic pressures, intercystic pressures. When we looked at these pressures and tried to correlate it with the bile composition, we found that in situations where the bile had more lipase or amylase, these are the situations where the cyst pressure was high. So what we concluded from this study is that whether the intracystic pressure has an effect on the various nearby structures, or whether it is a reflection of the quality of bile or a reflection on the status of the wall of the cyst. Difficult to say at this moment, but I guess, again, more work would illustrate it further. The important issue here is that high pressure systems were smaller in size. There were more severe back pressure changes. And this could again be because of the high pressure inside the system, the back pressure changes. But the low pressure cysts were larger in size. Possibly the wall was more pliable and therefore the size was bigger, and the bigger size dissipated the intracystic pressures. There were higher levels of amylase and lipase in these cysts, and there were more severe changes in the cyst wall, which again could mean that these kind of cyst walls were more akin to something like what we see in an adynamic bladder, which is large but has a lower pressure inside. Now, the polylocal pancreatic junction, I mean, it's been a topic of discussion for years now, for decades now. And everyone talks about an abnormality of the pancreatico-biliary junction in association with the choledochal cyst. So when you look at the abnormalities of the pancreatico-biliary junction, you find that they are described into three kinds, which is normal, less than 1 centimeter, more than 1 centimeter. And there are various ways in which people have classified the abnormal junctions. We did the study. Unfortunately, we did not publish it. But in the beginning, we used to do an operative cholangiogram before the MRI became available. And we used to do the operative cholangiogram through the gallbladder, and we used to document the pancreatico-biliary junction. But after that, once the MRI became available, we used the MRI to focus on the pancreatico-biliary junction, and we could get almost identically accurate results as compared to the operative cholangiogram. So we found that if there was an abnormal pancreatico-biliary junction, there was a strong correlation with severe grades of all parenchymal injury parameters, which basically meant hepatobiliary damage, parenchymal inflammation, and portal fibrosis, but not with any bile duct parameters like the bile duct inflammation and proliferation. Those without any abnormalities had significantly more cholestasis, indicating that the mechanism of liver injury with the abnormalities of the junction is not because of bile flow obstruction, but because of other factors. And the children with abnormality in the bile duct junction and the choledochal cyst, they demonstrate greater liver injury, even more than ductular injury, and thus require aggressive and early treatment of the choledochal cyst to prevent irreversible liver injury and fibrosis. And that is why I think the time has now come that we should focus on the pancreatico-biliary junction as well, and try and evaluate it before we set out to operate the choledochal cyst itself. So, portal hypertension. Now again, portal hypertension is something which has been discussed very often in association with hepatobiliary disease states. We also studied it in choledochal cyst, and the impetus actually came from a paper which was published in PGI Chandigarh, from PGI Chandigarh, and they made a correlation between portal hypertension and choledochal cyst. We carried that something of that kind of a study a little further. We used more objective parameters, and this is what we did. So in 20 patients, we recorded the portal pressures by measuring through a transducer, a pressure transducer, by cannulating one of the omental veins. But we realized that we will not be able to measure the portal pressure in the post-operative period. So we also did blood levels of nitric oxide, and we have done a lot of work on blood levels of nitric oxide in various hepatobiliary states. Most of it is published, and we found that the changes in portal pressure are closely followed and almost identically followed by blood levels of the nitric oxide. And therefore, the blood levels of nitric oxide are a very accurate reflection of the portal pressures. And so in this study, in the post-operative period, we used the nitric oxide blood levels to compare it with the pre-operative nitric oxide blood levels as a reflection of portal pressure. So again here, because we did not have any set criteria, we arbitrarily divided portal pressure into less than 14 millimeters of mercury versus more than 14 millimeters of mercury, and we tried to correlate it with several things, and the histological liver parameters were one of them. The only thing which correlated well with this was the bile duct proliferation, but the rest of it, the portal pressures did not have any effect on the portal hypertension. Similarly, when we looked at the nitric oxide blood levels, we found again that bile duct proliferation was the only thing which had a significant correlation, and therefore we were quite satisfied that the nitric oxide blood levels and the portal pressures have a good correlation. So when we looked at the portal pressures, preoperatively, blood pressure, portal pressures or the nitric oxide levels, whichever you may choose, there is a significant difference between the preoperative and the postoperative portal pressures. Similarly, for the blood levels of nitric oxide, there was a significant correlation between the preoperative and the postoperative parameters, and we saw that there was a significant drop in the portal hypertension in the postoperative period. So a lack of correlation with histological features and a significant drop in the portal pressures postoperatively tells us something which is very important. It tells us that despite liver changes, the portal pressures are high not because of the changes in the liver histology, but there are other factors which increase the portal pressures. Could possibly be the pressure from the choledochal cyst itself on the portal vein, which lead to higher portal pressures. And once the choledochal cyst has been removed, the portal pressures tend to reverse and become almost normal. So this was a very important feature, and I think in the overall prognosis of children treated with choledochal cyst can have a good bearing. So this is where I end. And like I said, when I talked about the roads less traveled, so if you are here, this is where you stand, and you take a road and you continue doing whatever you've been doing, or you take another road, think out of the box, look at aspects which have not been studied, and see that the implications of those factors with the overall prognosis of biliary atresia. This is something which will enlighten you, and possibly in the days to come, this little darkness which you see under the lamp, you'll be able to illuminate that further. I show this picture of folded hands for two reasons. One is to thank all of you for listening to me patiently, and also as a request to future generations of pediatric surgeons to continue working on the unknown, the untraveled roads and factors which have not been studied So you actually have to sit calmly, spend a few minutes with yourself, ask yourselves questions. The more questions you ask yourself, the more ideas you'll get to study, and the more knowledge you'll be able to spread and enlighten yourself and the others. Thank you very much.
Thank you, sir. Since it is customary not to have questions at the end of oration, but I'll state that it's an excellent oration delivered by a surgeon par excellence, an academician par excellence, and a person with integrity and humanity. And since I was trained under you, so it is more matter of privilege and honor for me to chair this session. And once you are delivering the oration, sir, it's really pleasure to chair this session and hear.
Thank you for your kind words.
Yeah, I will just reiterate what Dr. Kuril says. I think this is, I think I have mentioned this to you before. I think you are an embodiment of a surgeon scientist, and they are a disappearing breed. I'm also guilty because that's not something we give too much thought about. And I think this oration should probably be a stimulus for all of us and younger people to try and get the scientist part of it also into our thinking and discipline. So thank you very much.
Thank you very much, sir, for that enlightening talk. And now we will present the oration, a Sopa Vaklu oration. I'll request all the chairpersons to come and present the oration to Professor Bhatnagar.
Ankur, I just wish to make a statement before we assemble there. In our mythology, we have heard about eklavya. And I have never worked with Hardy Hendren, but I used to consider myself his disciple Eklavya. And when I met Boston, he was already 84. It was a matter of major. And today, while I was listening to this talk and going back in my, so I realized that maybe I was Eklavya to Viresh also. So Viresh, I hope you wouldn't mind accepting me as your disciple and keep going, doing the good work that you've been doing now. I heard you are in ESI Faridabad. We need to learn a lot from you. Thank you.
Where you are.
Come.
So that concludes the pre-lunch session. And thank you all for staying beyond usual lunch hours. Now we'll break for lunch. And we'll have a 30-minute lunch as we are running late. And we'll start the GI session at 2:30 p.m. So please assemble in the hall at 2:30 p.m. Thank you very much. People who are watching the live. Right.
यही डायरेक्ट करवा दे पेन ड्राइव से। सर कौन से ये अच्छा सर ऊपर बंद करिए क्रॉस करिए पूरा क्रॉस करिए यहाँ से पूरा क्रॉस करिए लैपटॉप से करिए कैसे कनेक्ट करोगे वो तो 4 बजे का चाबी है ना तो कर देंगे वो देखो सर आप कर देखिए तो देखा पेन ड्राइव इनका सब प्रॉब्लम ये हो रही है वही सेशन मुझे चेयर भी करना है उसी में प्रेस भी करना है दूसरे का ये मुझे बड़ी दिक्कत हो गई है कॉन्फ्रेंस के लिए ये इसमें मैं आपको पहले से लैपटॉप दे दूंगा हाँ आप कर देना ऊपर ये उसके नीचे इसमें से वीडियो वीडियो नहीं वीडियो मुश्किल चलेगा क्योंकि इतना उसका सपोर्टिंग फाइल नहीं है इसमें जीरो कीमत नहीं है इसके लिए
इसमें स्क्रीन स्लाइड शो करिए।
बताएगा सर वीडियो में।
हाँ हो गया ये
चल।
तो बस अब लोडेड है ना।
चल रहा है। एक का लैपटॉप करना है भाई भैया, बस एक सर का लैपटॉप करना।
क्या दिक्कत है? नहीं इसमें
जो पुराना वाला जो इससे सबका पहले वाला ये सबसे ऊपर ये वाले पीपीटी ना। हाँ ये इसी में ये सब इनकी
ये सब नहीं चलेगा।
बहुत देर कर रहा है, उठा रहा है अभी, उठाएगा वहां से।
अरे यार एक लोग तो फाइल बहुत टाइम लगेगा और कोई ना करना प्रेजेंटेशन
सब बंद कर दी।
ये है फाइल।
नहीं मैं वो नहीं कह रहा हूँ, ये तो फाइल है, पीपीटी का है, वो सॉरी वीडियोस का है। ये तो है वीडियो से है सर, वीडियो
एक में
ये सब यही वीडियो।
हमें इस पे एक बार क्लिक कर दो जरा, मैं एक बार वीडियो चेक कर लूं, बस इसको फुल करो जरा, इसको तो ये क्या कर दिया ये आप करिए।
ये नया टेप लगाओ, इससे नहीं रुकेगा। प्लास्टिक है ना वो, ऊपर से चिपकाओ। ठीक है नहीं ठीक तिरछा आ रहा है इस पे। ऐसे मोटा है मेरे वो है।
ठीक है आप सीधा हो गया
लेकिन कट रहा है।
अरे कट
चल भाई।
कटेगा नहीं, व्यू ऐसा ही है।
अब देखो अब देखो भाई देखो लड़ो।
अबे लगाओ ना क्या अरे उधर
अरे वो जरूरी है यार।
ये वाला
हाँ
ये किसका है?
सबका है।
रुको
रुको रुको चल रहा चल, हमें चल रुको भाई।
साथ में चलेंगे क्या अलग अलग करो?
वो कहाँ बैक करो, मी मैच करो।
इसके बाद बार
ये हटाओ, ये फाइनल प्रेजेंटेशन हटाओ, ये भी हटाओ। ये ओरेशन खत्म हो गया अब तो। अब ये है ना
इनका ये है पीपीटी, यही चटनी इसी में पीपीटी होता है।
पीपीटी तो ये खुली हुई है, ये हटाओ ये हटाओ। अरे हटा मिनिमाइज कर। अरे बहुत देर लगेगा सर ये उठाने में।
जबरदस्त बंद नहीं होता क्या?
अरे दूसरे पर करेगा सारे। लोकल डेस्कटॉप में कहाँ पड़ा है? तो सही है। अरे ये प्रेजेंटेशन डेस्कटॉप में मैंने कह रहा हूँ यहाँ डालो। डालते चाहिए। रुको
बहुत अच्छा जीबी है
तो क्या हो गया? तो उनके लैपटॉप पेन ड्राइव में तो है। बैक बैक करो ना,
बैक करके यहीं से कॉपी कर लीजिए ना।
नहीं टाइम लगेगा।
एक मिनट ये ना
टाइम लगेगा भाई, ऊपर वहां से उठाएगा। वहां से उठाएगा तो टाइम लगेगा। मैं उनकी पेन ड्राइव से मांग रहा था, मैंने कहा कि यहाँ कॉपी कर दो और यहाँ से चलाओ उसको।
नहीं चल रहा
अरे चलेगा।
चेक कर चुके हैं, पेन ड्राइव से भी चेक किए थे। आप जो सोच रहे हैं एडिटिंग करो, हमें भी ऐसा नहीं किया, पेन ड्राइव से भी चेक किया था डायरेक्ट, नहीं चल रहा। वीडियो शेयर करना होगा, शेयर वीडियो ऑडियो दोनों।
चल म्यूजिक बंद हो गया क्या?
बंद कर दिया। चल लैपटॉप लग जाएगा।
चलने चलने दो, चला दो। अरे चला दो ऑडियो
चला दो नहीं जाओ। अरे ऑडियो अभी कहाँ है? ये 10 मिनट मैं कह रहा हूँ ऑडियो चला दो ना। अरे उसका लैपटॉप कहाँ है? डाल दिया उसका अभी। चेक तो कर सकते ना इस समय।
अरे सामान वामान रखे ना। मैं वही तो कर रहा हूँ अभी। किसमें है? खोलिए। ऑन्कोलॉजी। हाँ खोलिए। राजेश ऊपर वाला। हाँ मैं यही तुमसे कहा था कि उनकी भैया आप pendrive से देखिए करिए।
अरे भाई बहुत टाइम लगेगा।
अरे आएगा आएगा 24 मिनट लगेगा। ज्यादा मिनट नहीं लगेगा। वीडियो टाइम लगेगा।
डेस्कटॉप से अगर के हटा के ना कहीं और कॉपी क्लोज है ना अभी डेस्कटॉप बोल लगेगा। देख लेना हमको ना बताओ समझ में आ जाएगा।
डेस्कटॉप में आ जाएगा। डेस्कटॉप पे चल जाएगा।
चलाओगे अभी पता चलेगा।
टेस्ट करके देखिए। नेक्स्ट मुझे 4 बजे सेशन है ना। उसके बाद बता दें।
नहीं कह रहा हूँ।
अरे को कॉपी हो रहा है ना। ये हो गया ना। ये
हो गया।
पहले वाली स्लाइड
ये भी हो गया।
पहले की स्लाइड ही है।
नहीं सर लंच हुआ।
लंच हुआ सर।
ये हो
नहीं
गया।
आप मुझे तो खत्म कराते हैं कोई दिक्कत
ये हो गया।
आप कहिए तो बंद करते हैं पूरा। नहीं तुम क्या काम करो।
अब इनका है।
दिन भर कहीं खाली घूमते हैं तो वो भी बंद करिए इसका यही हाल तो सर जिस दिन बीमार साहब छुट्टी पे होते हैं इनको उसका आज बंद करा देते हैं आज कुछ ना अभी छुट्टी पे है बिजी करेंगे यार हम लोग ये कर रहा हूं
रख दे भैया
नहीं
जिसका भी हो।
संदीप भी पॉजिटिव हो गया हो ही गया तो दिल्ली गए हैं उसके बाद तो मेरी मुलाकात है क्यों रोज तुम उससे तो रहते व्हाट्सएप पे आ जाता कभी व्हाट्सएप पे आ सकता है लोग बहुत क्लोज होते हैं व्हाट्सएप कहाँ ये बात पाएंगे मतलब लोग जो है गुड मॉर्निंग करते हैं बेटा उनको गुड मॉर्निंग मिला यार तो आज मेरी मान लेंगे बिना कंप्यूटर के बिना व्हाट्सएप के रूम रूम पर काम
चल हेलो हेलो।
छोटे की जान पिजड़े तो ये वो पिजड़ा ही मॉर्निंग सर अरे यही
कागज कहाँ है?
अगर तुम्हें रखे रहते।
अरे इतना लेके हमसे मार आइए
ये कर देते हैं।
अच्छा इसमें थोड़ा बता दो यार वो कैसे लगा है। पहले तो यहीं से हम लोग उंगली करके कर लेते थे।
नहीं सर यही करना पड़ेगा अभी भी यही करना
उंगली यही करेंगे। वीडियो नहीं रखे हैं यार। वीडियो में अक्सर रोना होता है ना कि उसके लिए बड़ा मेंटली प्रिपेयर होना पड़ता है। वो किस उस पर बना है।
कौन सा
पीजीआई फाइनल खोलो ऊपर है सबसे ऊपर है। हाँ नाम जीआई सर्जरी नाम। का काम और कर दीजिए। एक बोतल पानी रख दीजिए यार। जरूरत पड़े तो आदमी पी तो ले। अब वो मांगेगा कहाँ। हमेशा रखा के नहीं बेटा ये एटिकेट में होता है। पानी ना आप साइड में रख दो ठीक है ना। जिसको लेना होगा ले लेता है। अब मांगे बीच में तो अच्छा नहीं लगता। मांगते इसलिए नहीं। डॉक्टर जेडी रावत ये देखो ना पर उसमें होगा। इसमें लाइट कहाँ जल रही है? 6 लाइट ये हमारा देखना किस पोजीशन पर है। ये चार्ट में कौन से पोजीशन पर देखना। लास्ट होगा सेशन। हाँ जीआई सेशन खोलिए यही है। तो सबसे ऊपर तो उनका है। राय सर का सबसे ऊपर ले जाओ बेटा।
देखिए सर आपको खोलने
हाँ पहले खोल लो।
यार बहुत बुरा है सिस्टम ये।
हाँ अभी तो वो हो रहा था। ये काफी हो रही है ना। हाँ ठीक है, हाँ ठीक है, हाँ यही है। ले लिए हम।
ठीक है ना, मिलना करें।
हाँ हाँ, अच्छा अब इसमें बताइए कि
अभी नहीं ना, मिलना करें।
हाँ मिल ये बेटा बताओ कि इसमें ये सिस्टम
हम
सब
ये नेक्स्ट करने का बस।
नेक्स्ट कौन सा लेंगे? ये लेंगे, इधर लेंगे या इधर लेंगे, चाहे जो चाहे इधर का कर लीजिए, ठीक है। और ठीक है, बस ये हो गया। माइक आपकी है, ये पानी आपने रख दिया, और ये है ही है। नहीं तो इससे हम लोग वो भी तो कर लेते हैं, माउस से कर लेंगे, ठीक है, क्योंकि वो ना उल्टा मुंह पड़ता है ना उधर देखने को।
हाँ नेक्स्ट
ये शायद अभी देने के लिए रखे हैं, अब कर दें, अब तो नहीं सर। ये सब इनॉग्रेशन में होता है, उसी टाइम से डांस पर बैठाते हैं जिसको बढ़िया चल रहा था,
किसका चला है?
पानी रखवा दें।
अमित
अमित भी
नहीं चल रहा है?
नहीं
नहीं
सुनो, उसको बीएलसी में, इस वीडियो को बीएलसी में प्ले करो। तो राइट क्लिक करो ना, हटाओ इसको,
है हटा दूं?
अरे वीडियो हटा
कर दिया। अब ये भी तो पता है वीडियो कहाँ है। हाँ चाचा पता है। ये लूं वीएलसी का लूं, ये लो बताओ। छोटा लेता हूँ ना ये।
अपग्रेडेड मीडिया है।
12 MB की है यार, कहाँ बड़ी है उसे, और तो 2-2 MB की है। ये 12 MB की है। अमित तुम लोग हुआ हो ना, तुम लोग 4 में नहीं जा पाएंगे फिर। आज साथ जाएंगे हम,
साथ देंगे ना
इनको ले जाएंगे।
हम संदीप आ जाए। चलिए संदीप
चल छोटे बात करो।
चल गया। क्या इनका पहले क्या करना है? इनको हटा दो यार, ये यहाँ से हटा दो। अच्छा इनका वो लगा दे।
अरे ये तो बहुत
जब भी आ जाएंगे ना इसको वेट मैं तुम्हें दिखा दूंगी।
कहते हैं ये तो पता है। हाँ वो वही बता रहा हूँ।
इसके बाद ही
ये पूरा 60% फोटो दिखा दिया हो गया। नहीं ये के बारे में डिटेल बताओगे तो गया। फोटो दिखा दो। It's your presence of mind is needed. हर चीज में नहीं बता पाएंगे। थोड़ा सा शॉर्ट बताओ और जल्दी से शुरू करवा दो। ठीक है हम जहाँ कौन कौन वो है नहीं प्रोग्राम मेरे पास लंच से पहले वाला प्रोग्राम प्रोफेसर आदि रसिक साहब देवेंद्र को आर के टंडन साहब हैं रसिक साहब देवेंद्र यादव विवेक मनचंदा और सर को बुला लेना सुबह सी को
तो स्पीकर है सर फर्स्ट
स्पीकर वही रसिक साहब आ गए देवेंद्र यादव
वो बोल देंगे आर करने से कुड नॉट मेक इट सर बस ठीक है बैठे नहीं सर कुड नॉट मेक इट
कौन सा
आर करने से कुड नॉट मेक इट टू
नहीं
प्रायर कमिटमेंट और किसी को बैठ टीम को भी ठीक है सर
उसके बाद संदीप अग्रवाल नहीं यहाँ पे है नहीं ना वो they are not here रसिक साहब आ गए
सर
एंड दूसरा संदीप अग्रवाल सबको चेयर नहीं दे रहे हैं
पहले कर चुके
संदीप अग्रवाल का इसमें प्रेजेंटेशन नहीं है
नहीं इसमें नहीं है सर
तो राम समूह साहब को और
राम समूह सर का है सर
उनको संदीप अग्रवाल और रसिक साहब को बुला हाँ और जब बाकी लोग आएंगे तो उनको बुला ठीक है नाम
We are starting.
Welcome back, dignitaries and delegates. After the lunch, let's continue our session with plethora of talk on GI surgery.
To chair the session, we have experienced eminent pediatric surgeon. First, I'd like to call on Dr. Resection, sir, Head and Senior Consultant, Department of Pediatric Surgery, SRCC Children's Hospital, Mumbai. Next, I'd like to call on Dr. Sandeep Agarwala, sir, Professor and Head, Department of Pediatric Surgery, All India Institute of Medical Sciences, Lucknow. We welcome all you to the dais, sir. First off, we have Professor S. Roy Chaudhary, sir. Sir is Professor and former Head, Department of Pediatric Surgery, Lady Hardinge Medical College and Kalavati Saran Hospital, New Delhi. Sir has more than 100 publications, received multiple awards, including Dr. K.C. Basu Malik and Research Days Award, and also received Karl Storch Visiting Professor Travel Fellowship, and has been a member of and reviewer of various prestigious national and international journals. Sir will be giving talk on the management of cloaca and pouch colon in girls.
Respected chairpersons, ladies and gentlemen, it's indeed a special honor for me being invited in this prestigious meeting. Thanks to Dr. Vasan, Dr. Ankur and the team. They have done very hard work and chosen faculty from different parts to talk on different diseases. So my topic given is cloaca and congenital pouch colon in girls. The reason these two topics are clubbed because we see a lot of similarities and dissimilarities in the presentation, in the management of these two conditions. And we all know that this congenital pouch colon is prevalent in North India. So most of pediatric surgical centers do see a large number of patients of congenital pouch colon. Cloaca is, of course, one of the varieties of anorectal malformation which is seen in every high volume center. So I thought I would take this opportunity to share with you some of the similarities and dissimilarities we see in these two conditions, to outline their differences which may have implication in their diagnosis and planning management. At the same time, I would also like to highlight some of the challenges in the management faced in these two difficult malformations and the results obtained post-surgery. This is very familiar to all pediatric surgeons. The three cavities opening into one is the cloaca, which could be having a long common channel or a short common channel. Of course, the longer the common channel, the difficult the problems are, and more difficult the management and poor the outcome. To complicate the issue, if you see the picture on the other side, there are double vagina on two sides and a very long common channel. So what it means that there could be associated other genitourinary malformations, especially in the form of double vagina and a very long common channel. This is a hand-drawn picture of a congenital pouch colon, maybe type 2, where the cecum and appendix, following that there is a large pouch, and the termination of the pouch varies. It could terminate anywhere from the high in the urethra or somewhere in the vestibule, either high vestibular or low vestibular. But one thing is constant is that the rectal termination is always in the midline. In this particular picture, if you notice that there are hemivaginae, there are two of them on two sides, which is a constant feature in all patients of pouch colon, as opposed to cloaca. In cloaca, some percentage of them would have double vagina, but in congenital pouch colon in girls, they all have double vagina. So it almost looks like the similar picture which I showed earlier, except the additional large pouch here, which is the terminal part of the colon. Some people call them as pouch colon with cloaca. So we thought that we need to define those nomenclature more clearly because there are distinct differences. To show this picture again, this is an operative picture of congenital pouch colon in a girl, a large pouch and right and left hemiuteri on two sides, and the pouch going down in the pelvis. As I said, either opening in the high in the urethra or somewhere in the vestibule, generally in the intervaginal septum. And in pouch colon, the double vagina, if you look at them, they are like pulled down very low in the perineum. This is again a difference from cloaca, where majority of them end up very high. So this is the internal anatomy. To continue with the same discussion of the internal anatomy, as I said, that even if there is a long common channel, this is a cloaca where the vagina ends up, whereas in a congenital pouch colon, these are drawn very low in the perineum. So let us extrapolate that to external anatomy, what we see. So this is a classical description of a small looking genitalia in an infant with a single perineal opening, diagnosis of cloaca. Whereas this genitalia, infant genitalia, almost looks normal, except slight wide posterior margin of the vestibule. And on retraction, some of them would have very different appearances. This is one of the appearances which has been described as clover leaf. I believe it's Professor Sareen who described it. So in outpatient, when we see such a patient of anorectal malformation, it is imperative to have a good look at the external genitalia in a baby, infant. However, it may not be easy to appreciate all the different structures in the outpatient. It's not easy. Sometimes it is better seen when we see them under anesthesia in the operation theater. However, this appearance of kind of indrawn and retracted, and if you further see inside, you might be able to see double vagina on two sides and a thick intervaginal septum. Few more pictures. Slightly older children, they may present late congenital pouch colon because all these patients may have a fistula of the lower end of the bowel terminating in the vestibule. So they would be decompressing. So they may have a late presentation. But this is a very characteristic finding of congenital pouch colon in girls. What you see are two vaginae on two sides, lateral, urethral opening in the center, and a vestibular fistula, the terminal part of the rectum opening in the intervaginal septum. And interestingly, they are anterior. They're almost by the level of the vagina, but always in the midline. The vagina are on two sides. This fistula can have a slightly higher opening in the vestibule. So this is called low and this is called high vestibular fistula. But again, double vagina, urethra, and a vestibular fistula. And if you find this anatomy in your outpatient department or even under anesthesia, this is surely to be a pouch colon and not a cloaca. And look at the vaginal opening. They are very low in the perineum. To show you a few more pictures, again, similar finding, two vaginae on lateral side, central fistula, and the urethral opening. So this is a distal urethral fistula termination of the end of the bowel. So to summarize, if we look at the external genitalia of these girls, then we find that there may be essentially normal appearance. There may be wide posterior margin of the vestibule, and there are several appearances as I described: clover leaf, single perineal opening, initial appearance. Then on retraction, you could see the opening of septate vagina, urethra, with or without a fistular termination of the bowel. And as I said, under anesthesia, one can appreciate these changes better. The vagina are always double, and there could be septate vagina. So, in a true sense, they are not persistent cloaca, but they are just associated changes with congenital pouch colon. Vaginal openings are low, and the fistula never opens in the vagina, but they open either in the urethra or in the vestibule. To continue with the same, the colonic fistula can terminate distal in the urethra, high in the vestibule, low in the vestibule. Additionally, the changes in the urethra and bladder are very significant because that can lead to urinary incontinence. They have short, wide urethra, deficient bladder neck, poorly developed trigone, and laterally placed ureteric orifice, and a small capacity bladder. So this is an additional finding we have found in large number of patients of congenital pouch colon. These all culminate into urinary incontinence because of a small bladder, short, wide bladder neck. Just to take you through few case scenarios, I mean, this is the child born with anorectal malformation, had a colostomy in the newborn period, presented to us at around 1.5 to 2 years of age with a palpable bladder, distended palpable bladder, difficult to void urine, and there's some labial swelling. And this child on endoscopy, what we found that she had double vagina and urethral opening, and this labial swelling was nothing but urinary extravasation into one of the labia minora. This was the cologram of that child, which showed that urinary extravasation, and this is the termination of the colon. This was actually a case of cloaca with double vagina, slightly high cloaca, and similar kind of picture which I was showing you earlier. So in planning management of such patients, whether we should go through perineum or we should go through abdomen, should we have an open approach, laparoscopic approach? So I'll take you through some of those approaches later on. Coming on to those investigations for these cloaca patients, we all know that the two imaging are very important. One is a distal cologram or a genitogram, where one can see those three structures, urethra, vagina, and the bladder and the rectum, and the length of the common channel, which determines the kind of surgery one would contemplate to do. And recently I was going through literature where they described a 3D construction of these structures, where one can exactly see where the rectum is terminating, where the common channel is starting, what is the length of the common channel. As regards management of cloaca, we take cloaca first. We all know that Pena described the posterior sagittal anorecto-urethrovaginoplasty approach, which revolutionized the management and made it simpler for people to understand. However, there were lots of problems with that, especially separating the urethra from the vagina because they share a common wall. So later on, he changed to PSARP with total urogenital mobilization, or TUM. This was in an attempt to avoid urethrovaginal separation and thus avoiding injury to both vagina and urethra. Then there could be a more additional abdominal approach required. There could be a laparoscopic approach required. So I will take you through which procedure is appropriate for which situation. One recent realization is, in infant, if you are trying to separate a cloaca, it may be worthwhile to do only the anorectoplasty and leave the urogenital separation for future, provided they are not causing any difficulties. This was found to be associated with less damage, therefore less structural abnormality in the future, and less need for urinary drainage procedures. In cloaca patients, in addition to the genitourinary problem, they often have urethral obstruction leading to obstructive uropathy, which often requires management in the form of either a CIC or a mitrofenol. And we all know that an obstructed vagina needs to be drained first to overcome the urinary obstruction. So as regards the PSARP versus abdominal approach, our standard guideline PC line is a good guideline. If we see the rectum terminating above the PC line, we know that we may have to add an abdominal approach. Vis-a-vis, if the rectum terminates below, then it could be managed by the perineal approach only. Taking another case scenario, typical cloaca, as I said that genitourethroscopy is an essential part of planning management because one need to know the length of the common channel, the length of urethra, vagina and rectum available. So this is the Pena's early operation where we attempted separation of all three structures through the PSARP. The rectum is first separated, then the vagina is lifted from the urethra, and then little bit of common channel is left with the urethra. So this is the standard PSARP UVP. And the modification of that is a TUM, where after lifting the rectum, the urethra and vagina are mobilized in a single tube without attempting to separate the two structures and therefore avoiding damage to both these structures. So we all know that this TUM requires a little bit of anterior pelvic dissection. They need to cut the pubourethral ligaments and go up close to the blood and neck area. Very high dissection may be associated with pelvic nerve damage and may have fear of incontinence. Sometimes during this mobilization, we may find a septate vagina and it could be dealt with at the same time. So some of the appearances immediate post-op following a combination of PSARP and TUM. PSARP for rectum and TUM for urethra and vagina. This is one of our recent patient, suspected cloaca versus pouch colon doubt. So child initially had a colostomy. All of them we would cite a colostomy to start with, and then do a distal cologram to see what the terminal end of the bowel looks like and where it ends. Looks fairly high, though I do not have a true lateral view, but this was ending high up in the pelvis. So we decided that we need to give an abdominal approach, but we did a genitourethroscopy and found that this child also had a double vagina. The rectum was opening fairly high, about 3-4 centimeters above the perineum. So as regards the approach in this particular patient, we did an abdominal opening and found there was a long fistula of the terminal bowel. So we divided the fistula and put the bowel through. Interestingly, we left the vagina and the common channel as it is for future, because this vagina was opening almost 0.5 to 1 centimeter close to the perineum. They were non-obstructed. So we thought we would not try to do any separation, and we'll try that someday later. So what decides the management between the two things are two lengths. One is the length of the urethra and the length of the common channel. So these two can be assessed in cystoscopy. What is spoken is, if this length is more than 3 centimeters and this is less than 1.5 centimeters, then you have a problem. And if this is more than 1.5 centimeters, the urethral length, then the chance of continence is very good. So based on that, the current management of cloaca are these 3 steps, that in low cloacas, common channel length shorter than 1 centimeter, one can just simply manage by PSARP. One can leave the urethra with a little bit of hypospadias of urethra. If the common channel is more than 3 centimeter, urethral length 1.5 centimeter, then the combination of PSARP and TUM, as I have shown in some pictures, works. Problem is the long common channel and the short urethra, where one need to do further for especially vaginal replacement and bowel pull through. And these days, even the laparoscopic and MIS can be applied for pelvic mobilization. And those with more than 5 centimeter, of course, definitely will require future vaginal replacement. As regards the results, with the common channel less than 3 centimeter, they have a good chance of having spontaneous voiding. But the common channel more than 3 centimeter, the chance of spontaneous voiding for cloaca patients are less, and a large number of them would require some kind of a urinary drainage procedure. I think I've spoken already on PSARP plus TUM. Coming to pouch colon management, in GIST, almost similar line of management. The first stage, a stoma is sited. In the second stage, we disconnect the fistula, do a tapering and then a pull through. And the third stage, stoma closure. Now, looking at this particular picture of a pouch colon, it struck to me that it's all on the lateral side with a straight medial wall and almost looks like a diverticulum. So if you straighten it, it just looks like a large diverticulum on the lateral side. However, the main vessel goes on the lateral side and supplies from the lateral to medial side. So in managing this pouch, there are various ways and various techniques of tapering. What I have done in few patients are I have divided the pouch in this straight line, and this made into two things. And the straight part was left with the anorectum after fistula disconnection and pull down. And this diverticulum part could be excised or could be retained. Why retained? Because we know that in some of the girls, you may need to do a bladder augmentation in future because of their small volume bladder. And you do not have enough bowel to do that because they are already having short colon. So that's just a thought. And we have done a few patients. We have left few of these pouches intact with a little stoma for cleaning the mucus. In one patient whom I did that about 15 years ago, came back for a bladder reconstructive surgery. She was incontinent, and we decided to do bladder closure, bladder neck closure, and Mitrofenov. And there I can show you, this is the tapered pouch, which looked good vascular, having some good peristalsis, and she was managing the bowel very well. Fortunately, we found an appendix on her. So we did a bladder augmentation with Mitrofenov and closed the bladder neck. Coming to urinary management, so cloaca, as I said, they usually have obstructive urethra, so they require some kind of a drainage procedure. Whereas pouch colon, they have a wide bladder neck and they have urinary incontinence, so they require slightly different management, either bladder neck tightening or bladder augmentation. And of late, we realized that total incontinence can only be treated by complete bladder outlet closure, augmentation, and catheterizable stoma. Just to show a small bladder and a wide bladder neck, cystoscopy of a pouch colon showing wide open bladder neck, small volume bladder, low urethra. So even difficult to manage by bladder neck tightening. This is one rare case where I augmented the bladder with a retained colonic pouch about 10 years after I preserved it. It worked quite well, but I do not have a long-term follow-up on this patient yet. And this is the latest patient, which I said, she's 26 years old. She has done MSc master degree. She wanted to be totally dry, so we closed off her bladder neck, put a patch of muscle in between, and did a bladder augmentation and a stoma. I think I largely discussed about the bladder management. Just to come to the management of so-called persistent cloaca part of congenital pouch colon, I would again reiterate that there is no cloacal element here. So they do not require any TUM or PSARP. All one need to do is probably just cut the intervaginal septum from below and make a wide introitus and leave a little hypospadias urethra. They do not require bladder vaginal pull down or vaginal replacement. So to summarize the difference between the two, as I said, that pouch colon always has double vagina, but some of the cloacas can have. Pouch colon, they never require vaginal reconstructive procedure, but you have to always approach pouch colon bowel from abdomen to handle the pouch. And there is a high incidence of urinary incontinence in pouch colon as opposed to urethral obstruction in cloaca patients. Complete excision of pouch and pull through is a bad idea. We have given it up because our patients used to have like a perineal ileostomy, very poor management, whereas tapering and pull through gives more favorable results. So the take home message would be that one need to be aware about the different clinical anatomy, their presentation and variations. In pouch colon, one need to preserve the colon for optimal continence and quality of life. They all require stage surgery, which may require an additional abdominal laparoscopic approach. For cloaca, one could delay the vaginal urogenital sinus separation and vaginal replacement until puberty. And in female patients of pouch colon, peri-puberty, there would be challenges with urinary incontinence, whereas in cloaca, they have problem of obstructive uropathy. My acknowledgement to all my team members, especially Professor Rajiv Chadda, who has been working a very long time on these topics, and he always helps me understanding the anatomy. Thank you so much. Some of them, the older ones were not, but some of the recent ones are. Yeah, Apple actually.
Correcting in the OPD and then proceed accordingly. What mistake is usually made is people writing rectovestibular fistula with double vagina. In North India, if you be careful, you go in to do a primary PSARP for rectovestibular fistula with double vagina, you'll end up with a problem because it's a pouch colon. So, proper radiological evaluation. One important aspect as
Yeah, sure. That's what I said, that imaging is very important. And we rely on both the things. I mean, once a colostomy is cited, especially we prefer sigmoid colostomy. We don't do transverse colostomy. So one could do a very good genitogram from a distal cologram through the sigmoid colostomy to see the tubes. You can add it up with a genitogram, which also gives some idea. You need all, the lateral view and the oblique view to see that. But ultimately, it is the cystourethropy in the endoscopy, which exactly tells you where the bladder neck is, what is the length of the urethra, what is the length of the common channel, where the rectum opens. One can even do catheterization and find them. So a combination of both is essentially required to understand the whole anatomy. And if you have a 3D reconstruction, probably it will be the best.
Just to comment, I was once sharing a stage with Sudipta Sen in a symposium. I learned that he has always preserved the pouch after tapering it and put it as stoma. And he has used it not only for augmenting the bladder, but he has also used it for substituting the vagina. So that was a learning experience for me as well. And I think it's a wonderful idea.
Sir, can I just comment one on that? So as I said that if you have a true pouch colon, we haven't needed to substitute any vagina because the vagina we always found very low. It is only true cloaca where the vagina ends very high. In the pouch, for some reason, the Mullerian structures are dragged down very close to the perineum, and the openings are virtually seen right there on retraction.
Yeah. So once in a while you do come across vaginal
Sure, I
atresia
understand that it's a
associated with
useful
that.
tissue for replacement.
Yeah.
Any other question, or we go to the next? Rajiv?
I have one little comment there. Because Rajiv had given a classification of pouch colon and female subjects. And, although I agree with you that the vagina pulled down very low, but they are still having kind of few millimeter common channel. So that it really doesn't look absolutely like a normal
recessed appearance. That is what
yeah,
we call.
it's kind of receded appearance. So which is pretty acceptable to most of the girls.
But they don't have any obstruction. They're drained freely, and if you divide the intervaginal septum, probably you could give a relatively good perineum. That's how we are probably acceptable. Probably.
Yeah. When you said tum, did you really mean tum or did you mean pum?
Well, that difference is kind of not very clear. I mean, some people say you cut the ligament and go above, it is tum, and you stay below the ligament, it is pum. Essentially, that one should not go above the blood and neck area.
Yeah, that's what I meant. That usually you will stay down and will not reach up to the blood and neck. So I would prefer to call pum what you mentioned as tum in your
sense, because if it is more than 3 centimeter common channel, one should not attempt pum or tum anything.
Yeah, agreed. Agreed.
Yes.
Patient, one of them I'm facing right now, where I can't open the abdomen because it's going to have two result transfer and Deodorant. Has anyone in the audience had an opportunity to replace vagina from any extra abdomen?
Well, the standard replacement of vagina, as we have learned and we have been practicing, are either ileum or colon, or in double vagina switch operation, where you take one half of that and pull it down. But
Rajiv, I've done local skin flaps, even from the buttock. I can't tell you the age, but it was definitely not very early in life. It must, I mean, I can't tell you the exact age, must be say 6 to 8 years or something like that. So.
Menstrual problems. But what about the sexual satisfaction? Why should it be like that sexual can be given by the
Devendra, I'm in total disagreement, and I have done at least
2 dozens or more bowel vaginoplasty and MRKH patient. Very unfortunately, very recently, when these kids have grown up now, there was some rudimentary uterine elements which we had not picked up in early imaging or even doing laparotomies, which are creating problems. And I have been finding this gynecologist very, very uncooperative, whether it's from my institutions and from other institutions, to help us doing that. I did try once to attach that bowel vaginoplasty you've done to the uterus. It did work and drained the menstrual fluid for about 2-3 months. Again, it got stenosed. So eventually we had to do hysterectomy for that patient.
So that is why this recommendation is leave those genitourinary reconstruction post-pubertal. Don't try pre-pubertal, because you are never sure which structure is going to develop how and what is going to start what. But peri-pubertal, you will be better informed, and you don't know what it is. If you have uterus, if you have a proximal vagina which would distend, that would guide you what to do. And this is what that paper from Billiard which I quoted is very significant contribution. That do the rectal part, leave that part for around puberty and post-puberty.
Thank you, Subhashish. We will invite next speaker.
Thank you.
For the next talk, we invite Professor Ganguly. Our primary is
I invite Professor Ganguly sir. Sir is ex-professor and HOD, Department of Pediatric Surgery, Institute of Medical Sciences, BHU. Sir's key area of interest is neonatal surgery and anorectal malformation. Sir has published more than 250 papers, written 4 books, and has more than 20 chapters in the book. Sir will be giving talk on primary PSARP without covering stoma for ARM, its indication and experience.
Good afternoon, everybody. Respected Chairperson, ladies and gentlemen. First of all, I want to thank our organizer, particularly Dr. Vasan, Dr. Vijay, and Dr. Ankur, for giving me the opportunity to share my experience of rectal malformation, single stage versus stage procedure. So my talk of today is primary PSRP without primary PSRP or abdominal PSRP without covering stoma. In cases of rectal malformation, my experience over more than 3.5 decades. So just like the quest for Holy Grail, my quest was to completely continent child with normal bowel function after completion of surgical procedure. Though I have achieved a lot, but still it is continuing. I want to hand over my battle to my future younger generation to continue it, so that it will become more and more modified and sophisticated. Now, controversy, when I joined in the Department of Pediatric Surgery in 1980, there are no controversy. All the patients were having high and intermediate ARM is being tackled by 3-stage procedure. Yes. Am I audible now?
Yes, sir.
Okay, I have lifted the mic. It was a bit low. Anyway, so that controversy was not there. The 3-stage procedure was being done earlier, but subsequently I started feeling a lot about this 3-stage procedure because of the lots of problem crept up after 5 years or 10 years. So I started deciding whether I can you give the volume to? Okay. So I want to share my experience and controversies of single stage versus multi-stage procedure. So while dealing with a neonatal ARM, 2 questions come in your mind. Number 1, whether there is any life-threatening associated malformation which requires immediate attention before you venture for
surgery for anatomical malformation. Now, next question is, if there is any need for colostomy. If not, then why not manage by single stage? So that is my experience of in 3 stage. First, earlier part from 80 to 88, I used to have, though most of the people used to have do it by abdominoperineal pull through or sacroperineal or combined abdominal sacroperineal pull through based on Stephen's concept of pivotal swing. So after the 88, after attending the first PSRP workshop of Mr. Alberto Pina, I started doing the 3-stage procedure of PSRP, covered by colostomy and then colostomy closure. But from 95 onwards, I started doing single-stage procedures in newborns without any protective colostomy. Why I have switched on? Question may be asked, why I have switched on for single stage instead of staging procedure? Why I should bother for those headache for running in the middle hours of night, doing the surgery or stabilize the patient so that we can manage it in the morning hours. So this is because I have seen that high morbidity, poor compliances. After having 10 years follow-up, more than 38-40% lost in the follow-up. So by that, I started thinking that with colostomy, some of the patients came at adolescent age group for doing the second surgery. So that thing stimulated me to do it single stage. Another important thing in poor patients, cost of 3 admission, 3 operation is much more. Whereas if it can be done in neonatal period, at least that cost has been 1/3. Psychological impacts not only to the parent but also the patient is there, and poor cosmesis because of the 3 scar in the abdomen, 2 scar in the abdomen and 1 in the perineum. So then I compared this stage procedure with that of single stage procedure in my own cases. This is a historical control because stages procedure had been done earlier from 80 to 94, and the subsequent primary operation is being done single stage operation 95 to 2012. So here you can see that first number of cases of 673, but follow-up after 3 to 14 years, it becomes 200. So those patients are lost in follow-up. So I started writing letter to them, and some of them then turn up with the colostomy, and the colon is disused, narrow, not developed properly. So then I decided that I will go for primary single-stage procedure. But primary single-stage procedure should combine either PSRP only or PSRP at abdominal pull-through. And some cases I have tried to establish which is better by abdominoperineal pull-through. Now, after assessing the continence of the 2 groups, I have seen that you can see in the first side is staged procedure where 42% or 44% good continence is there, whereas it is around about 70% in cases of primary single-stage procedure. Next important question comes, it is again another controversy in that era, that whether distal part of the fistula region totally preserved or not. So initially, a proponent of those said that it is ectopic enough, it should be preserved, so that continence result will be better. So, but I started thinking that this anywhere there is a abnormal thing, it has to be excised and pulled by normal things. That is my philosophy. So I started studying this distal part by excising the distal part and adjacent tissue from proximal part to see the structural changes in these 2 parts. So histologically, the distal part is having lots of thinning out of the wall as well as inflammatory eosinophilic cellular infiltration along with disorganized muscle in the distal part. So if you pull it, it will not have the proper sensation, proper function, proper contraction. So better, whereas the proximal part on the right hand side, you can see the more or less organized circular layer. So I prefer to excise the distal part, but still I want to make it scientifically proved. So I have studied the motility of those proximal and distal portion of the adjacent fistula region, and it has been observed that histamine-induced contraction in the proximal segment is adequate enough, whereas that of distal segment is not negligible. Same thing happens with inhibition of the contraction by acetylcholine, which is much more easily inhibited by distal segment, whereas it is not at all mobilized by the proximal segment. Here it is distal segment where the relaxation is not there. So, in other words, the distal part of the fistula region or adjacent to that, if you pull it out, it is functionally abnormal, structurally abnormal. So, with this study, I can say that I have at least been able to convince people that based on scientific proof that distal part should be excised and pulled it by the normal body. Now, next stage question is why single stage procedure should be performed at newborn? Why not delayed? Delayed means you have to do a colostomy and then do it. But disadvantage of delaying is you are delaying the development of the part. So, the first sensation of cortical stimulation for rectal distension develops in the first year of life. And if it is not stimulated by distension of the rectum, by mobility of the rectum, by peristalsis of the sigmoid colon rectum, the sensation will not be adequate enough to establish good continence or good function, bowel function. Another further disadvantages are dissection of the is easier in the newborn. All of you have experienced that any tissue dissection in newborn is much more easier than that of subsequent period. No need of tapering here. It can be immediately placed inside the funnel, and it eliminates the urinary tract contamination at birth and maintain the urinary tract continuity at birth. So this I have during doing the surgery, I have started modifying the techniques. So initially I used to do the classical Pinna's operation by opening the pouch and then doing the dissection, but it is loaded with meconium. It stains the area and it is very difficult to dissect, and every time you have to wash it out, clean it out, and only. So then I thought that in a esophageal pouch, if you proximal pouch, you dissect higher up, then it go down, it is become easier because there is no attachment between the two. Here also, if you go higher up, the pouch becomes free. So from there you start dissecting down, and then you can approach the fistula and you can close it in between ligatures. So that way you are avoiding contamination by meconium and blurring of your field of vision. So this is the procedure, immobilized and then normally placed. Another modification I have done for female venorectal malformation newborn, because in newborn, if you cut the fourchette, open the vestibule, then subsequently I have seen that while healing process goes on, the fistular region and the vagina opening becomes, vestibular region and the vagina opening becomes small. Whereas if you dissect while doing an incision, just stop before the posterior fossette and then dissect the rectal pouch from the vagina and flushly ligate it close to the vestibule or vagina. Here in the left hand side, you can see intermittent ligature is being put and it is being divided. Then you pull the bowel, it becomes more cosmetic results and good looking perineum, good looking vestibule. I mean, at times when they grow up, then you cannot imagine that normal vestibule appearance is there, which is at times missing in if you open the posterior fossette. Now pouch colon, again I have studied pouch colon. There are lots of papers and other things are there, but my saying is pouch colon is abnormal. That's why it has to be excised. But it can be used for some other purpose, well and good. But as such, it has no normal proper structure in it. But if it is total pouch colon, then what Dr. Raichaudhuri was showing, that there is a lot of diarrhea in the initial part if you do an anal pull through, ileal pull through. But if you want to construct a tube, it should not be more than 3 to 5 centimeters in newborn, because the coloplastic tube grows with the growth of the child. So earlier I used to make 10 centimeter and it grows up to 28 centimeter in adolescent. So then lots of pouchitis, tesis and intermittent enterocolitis just takes place. So in order to avoid that, if you at all you want to make a spout, tuboplasty with the pouch, it should not be more than 3 to 5 centimeter. Okay, then pull it down. Now this has also been published as single stage procedure for all variants of pouch colon. There is no need of doing any colostomy or diversion, which can be managed by either primary abdominoperineal pull through or abdominal PSRP, whichever you prefer. Abdominal PSRP needs to change of position, whereas abdominoperineal pull through doesn't require that. Again, I assess the continence in these two groups. Again, you can see the 43% is good continence in single stage, whereas 26% in good continence of stage procedure. Histopathology of again, this is disorganized muscle and focal area of erosion, hypertrophy of the muscularis mucosa, chronic inflammatory cellular infiltration, hemorrhage, in the submucosal level, and constriction band, which I have found in uniquely in this pouch colon in the circular layer, multiple constriction band. That may be the reason for stasis of the fecal contents in the pouch colon if you pull it down by making a tubuloplasty. I have studied the functional outcome also by, again, same way of contraction, and it has been seen that pouch colon is having no spontaneous contraction and hardly it moves with the stimulation of the histamine. That is chemically evoked potential is very less, negligible. So all this suggests that pouch colon should be excised as much as possible. But if you want to at least reconstruct the tube, that should be smaller enough so that it grows in length with the growth of the child and growth of the intestines. Now, there are some contraindications. You cannot say all the patients I will operate for single stage. There are some contraindications like any other procedure. If there is severe life-threatening congenital malformation, then better to do stage procedure. Similarly, sepsis, severe sepsis, or NEC with perforation. Bowel perforation has already taken place. So already peritonitis is there. There is no point of doing. You have to survive the baby and then do the procedure whatever you want. Another is extreme prematurity. If their motility is so low, if you do a pull through, then there will be stasis. Again, there will be a lot of problem. And common cloaca, as Dr. Chaudhary has pointed out, there is always performed by diversion colostomy followed by the procedure. Now, in these cases, follow-up is very important. So follow-up, we are familiar with the different scoring system, which is clinical follow-up. But I used to do Kelly scoring for follow-up, and that I am familiar, so I followed it for the continence assessment. But I have seen that with this follow-up, it is a personal observation. We have to document it. So I started doing MRI in these cases. And that is called combined MRI and clinical follow-up by scoring. What are the parameters observed in MRI? Levator muscle, its development on both sides. Then anorectal angle, which is whether it is obtuse, acute, or straight. Now, rectal diameter, rectal wall thickness. These are very two important problems because the diameter is more than 4 centimeter and thickness is too much more than 1 centimeter. Then you are managing a difficult case where you have to do drainage procedure and you have to do further redo surgery. Centrally located rectum, it is very important. Sometimes in a newborn, particularly in an institution where some of the residents are operating, you are observing. And during that time, you may have a phone call in an emergency meeting or something that you may not be continuously monitoring it. So that time you may see that some of the cases are rectum is pulled out eccentrically. So those patients are the ideal for redo surgery. External sphincter development, which is very important for continence. If the external sphincter is well developed, then continence will be much more better. And tethered cord, there are lots of controversy whether all tethered cord needs surgery or not. So it is tethered cord blanket statement cannot be needs to be tethered until unless there is neurological deficit. Now I combined my ARM case follow-up cases with clinical scoring in the bottom of it and that of muscle development by MRI. So you can see here also in stage procedure and single stage procedure, just like clinical scoring, here the muscle development, levator hammock, then external sphincter and purerectal sling, all are far better developed. So 3+, 2+ means good, 1+ means fair, and minus is poor. So all are better developed if you do a single stage procedure, which gives the stimulus for development of this muscle because they are just like a Jamie, you are working to develop your muscle. Here, if you pull the bowel, again, they are exercising, so they develop much more better. And if you do a diversion colostomy, they remain disused, so their growth potential become less. So this is another logic which I want to express in front of you. Now, I started assessing 3 variants of primary single stage procedure. One is PSRP through or abdominal PSRP, another is abdominoperineal pull through. So again, by clinical scoring and MRI. With both combined data, I have concluded that PSRP or abdominal PSRP over abdominoperineal pull through is better in terms of muscle development, in terms of continence, in rectovulvar prosthetic or rectourethral fistula. Whereas that of rectovaginal fistula, all 3 approaches are having more or identical continent or muscle development. Now, there are some future scope of further evaluation, because parents often ask about impact of the surgery in the long life of the child about continence of stool. So the present counseling done by any eminent pediatric surgeon is imprecise and based on his personal experience and professional opinion. So that cannot be foolproof in the court of law, as well as foolproof, that cannot be justice to the parents also. So anatomical features should be identified by either neonatal preoperative MRI, preferably CT or MRI, whichever you want, so that you can have anatomical features identification before surgery in the newborn period, including type of MRM, degree of sacral development, and the features of spinal cord, whether the spinal cord is fully developed or there is some abnormality in the spinal cord. Thereby, all these features subsequently implicate the continence results of these children. So, but all these anomalies frequently occur simultaneously. So, relative predictive value of each is cannot be assessed right now. So, there should be some more study in the form of a EMG study, in the form of a rectal pressure manometry in the postoperative period. Thereby, you can incorporate more. I have told that contraction of the bowel may be stimulated by drugs. The drugs can be selected, drugs can be given for achieving better continence. So that is the future study. I left it for the newer generation. Furthermore, most previous studies or most counseling scoring systems are for continence are not used as a standardized manner. That's why I have told I do Pelly scoring, somebody does taken back scoring, somebody does whatever he wants, PSR, PINA scoring, whatever it is. But there should be now rational, individual, generalized scoring, including incorporating the MRI findings along with the clinical findings. If it is incorporated in a large scale, data will be collected, then we will feel again further support of why primary PSRP should be done, because it develops the muscle much more faster, much more better than comparison of staged procedure. So controversy of single stage versus stage procedure, I think with my presentation, with my documentation, I am able to now that with the new development of imaging, neonatal care facilities, single stage APR is feasible, safe modalities of treatment in these anomalies. So still, I want to conclude my talk with a famous saying of Sir Albert Einstein, that learn from yesterday, live for today, hope for future. So future is with the younger generation, and never stop questioning by yourself. If you are not asking question on yourself, you won't be able to generate your thought process for future modification of your techniques or whatever you want to justify your techniques. Thank you very much for patience hearing.
Thank you, Professor Ganguly, for this beautiful lecture on his vast experience of neonatal malformation. I think nobody will have such a vast experience. So since we are running short of time, I'll invite one or two questions from the audience.
Sir, thank you very much for a nice presentation. One query, sir, how clinically you are deciding that this much distal segment of the colon, that fistula should be excised, number one. Number two, whether you are using the muscle stimulator at the time of identifying that muscle complex or not.
Okay, first part of the question is how much you have to exercise. If you feel the distal part, you will feel the difference. Like a pyeloplasty, when you open the ureter, if you feel it or if you slit it open, you can see the wall thickness and luminal narrowing. That is easiest way to calculate, assess the distal part which has to be excised. So it is on an average 1 to 1.5 centimeter. But if you feel that is becoming muscle, you have to feel the muscle layer above and that area. If it is similar, then you can pull it out. If it is thinner, then excise that part. And second question is
muscle
stimulus. Initially, at the initial part of my study work, I used to use the muscle stimulus. But subsequently, I have seen that if you do too much cases, then you will realize that you can see everything. The vertical fibers, then parasagittal fibers, as well as the levator muscle. But if you want to stimulus, obviously, I don't say that don't do it. For a beginner, even I used to say that It is a learning curve. Don't do the primary PSRP or primary abdominoperineal pull through at the first one. Just like laparoscopy, here also you have to gain a learning curve. So initially you do the colostomy and try to do the surgery as early as possible, within 2 weeks, 3 weeks, 4 weeks. And then subsequently you will be able to, after gaining some experience, then you will be able to identify. And never use cautery too much. That is my main motto of presenting it. I hardly use cautery in these cases, except the active bleeding point only, and that too bipolar cautery. Don't burn the muscle. If you burn the muscle, it will lead to fibrosis, and in long run, it will not function properly.
Dr. Gurmapade, how do you decide whether you would do a patient PCRP or would you add the abdominal element to it?
Actually, based on my, nowadays we are having infracoccygeal ultrasonography, which shows the fistula level. If the fistula level is in the urethra, then it is better to do PSRP. If the fistula level is in the vesicle or bladder neck area, then you have to combine abdominal PSRP. But I always prefer to do the PSRP first, so that I can see the pouch or not. If not, or if it is just being, I don't pull it down. I put a tube, close the perineum, PSRP area, and then do the abdominal mobilization, and through the tube I bring it down. So that way I never, you should not manipulate the pouch, bringing it down, or dissect the pouch too much to bringing it down. Thereby you are losing the vascularity. So that way you have to assess during surgery, and preferably first do the PSRP if you want to combine. If it any doubt, any failure, put a tube and close it. Don't try to fiddle with the pouch. It will tear off, longitudinal tear. You will get a good tube, but it is only mucosal tube which comes out down. So I had, I don't want to name a person. I was that day Bengali New Year celebration party in the evening, and that time the resident was on third year, so he wants to be competent enough. So he started doing it, and then while pulling down, he pulled down the bowel, but he was having some confusion. So he rang me up. I immediately reached that area and saw he has pulled out the mucosa tube. Serosa and muscle is lying higher up. So I have to open the abdomen and pull the normal bowel, discarding the mucosa tube. So never try to pull anything by holding the instrument. I hardly use the instrument, put a stay suture and hold the pouch with finger. Thumb and index finger is the best way to palpate it. Thereby you will not tear off the serosa or muscle.
We'll allow 2 more questions, one by Dr. Bajpayee and one by Dr. Sanjay.
So I just a point of technique, sir. First of all, we have moved away, some of us, from PSRP because we believe that posterior sagittal dissection per se leads to neural innervation damage, de-innervation, more than if you do abdominal perineal. So in abdominal perineal, since you have concurred that the fistula is abnormal, that has to be removed. So through abdominal perineal in newborn, the pelvis is very shallow, and therefore even if the fistula is low down in the urethra, we are able to see it and dissect it away from the urethra, and we put a catheter, we can know where the urethra is under vision, we can remove it, then we hang the bowel down. So with the use of muscle stimulator, we in the newborn in the lithotomy position, we stimulate the sphincter, we dilate it, we don't cut just like you have recommended, we don't use cautery, etc. We simply split it up, and with the back cock, we pull it down and hang it. So the damage which happens through posterior sagittal approach of denervation in that area, there are a lot of patients develop urinary incontinence, despite the fact that sacrums are normal. So which led us to believe, and if you look at some of the long-term, some of Horst Schneider's paper where he had looked at all the techniques over the years, Rintala's paper where he had followed up by ASRP comparison, PSRP, he said that PSRP leads to denervation. So abdominal perineal, removal of the fistula as the point which Dr. Diledhar had asked, and as Yogesh also asked, that how do you decide which way to go? So I am doing in all cases, we can access the fistula, we can hang it down, and then we trim it away after 10 days without a colostomy. You are doing without a colostomy, but a primary suturing to the inner body, isn't it? Yes. So that's another point which, but I'm a little hesitant because I feel that will lead to actually in the sort of contamination of the wound. Dr. Sanjay, please.
Before that, I want to comment on your, because if you are meticulously doing the dissection, and if you are not stretching the heart, another thing I used to do is I never put the mastoid retractor forcibly. Only at the lateral part of the dissection or pulling down, I put it gently. Rest of the thing I used to do is serious stay suture. One the skin, then put a gauze piece, and artery forceps there. So it remains hanging with the weight of the artery forceps. Second layer, the parasagittal fibers, again put a stay and gauge piece with the artery forceps. Thereby you have got adequate retraction. And then if you dissect the area, it is easier to dissect without damaging the muscle there. And number two thing, what you have told is right, but hanging of a mucosal tube, that patient needs to be stay in the hospital.
Yes.
Otherwise, in our place, within 2, 3 days, 4 days, they are exhausted of their money. Then rest of the male member ran away. Only female member, mother is staying. So it is a very difficult procedure to convince them and stay and all these things. So it is another alternative, no doubt. So, but whatever you will, but my contention is that never use too much diathermy and never use forceps to hold the pouch. Put a stay suture, hold the stay suture and with the pouch itself, and then do the dental dissection. Gradually, a pouch will be in your 2 fingers. So your finger, left hand finger should be, so a surgeon should have both the fingers, both the hands working simultaneously. If it is not, then it will be difficult. Anyway, neonatal surgery. Anyway, thank you.
Yeah, thank you. I think it's an enormous experience you have, and thanks for sharing. Couple of questions I had. One was about, you mentioned MRI as one of the diagnostic tools. So do you actually do them preoperatively in some cases in that age group when they are a couple of days old? That's question number one.
Yes.
And secondly, in children who come with a good amount of distension and what techniques would you use to still go ahead primarily?
Okay. If first question is whether we are doing MRI, because we have a good radiological team. I have all of them are my students because I have a long association in the institute. So whatever I suggest them, they try to help me out. And we used to have the newborn the morning hours to do the MRI, and the evening hours we operate it, so that we get the report, and I sit with them in the consult to see what are the things muscle there, so that you have a vivid idea about what you want to see and what you want to know, and so that I can also counsel the parent. That's why it is very difficult in a poor muscle group. If you want to counsel them, okay, I will see it, but that is not feasible nowadays. You have to convince them that whether continuous result will be good or bad. That has to be properly assessed by doing the MRI. Earlier we used to do CT scan, but CT scan has a lot of radiation exposure. So I switched on to MRI. Another, if you have any doubt or any problem, if you cannot get the MRI that day, so you can ask the radiologist to do a high resolution probe, transperineal ultrasound, where infracoccygeal, that is just below the coccyx. That way you can demonstrate the muscle and you can see the fistula, whether fistula is in the urethra, whether fistula is in the bladder. So thereby you plan the surgery accordingly. Thank you very much, Dr.
So now I invite the next speaker of this session, Professor Ram Samuj, for his talk on transanal endorectal pull-through.
Professor Ram Samuj sir is professor and head Department of Pediatric Surgery from prestigious PGI Chandigarh. Sir's key area of interest is Hirschsprung disease. Sir is fellow Royal College of Surgeons, Ireland, Dublin, has more than 170 papers publication, has multiple chapters in various books, and has been more than 35 years of teaching experience. Please welcome, sir.
सर्वर उठा हम लोग वहां डाल दें पीछे। वीडियो है सर। नहीं डाउनलोड है सर, डाउनलोड किए थे सर। किसमें? उसका पहले खोल ब्रेक ब्रेक होगा ना। सर नेक्स्ट करना है, नेक्स्ट करना है। चलो
Good afternoon, chairpersons and fellow delegates. Greetings from PGI Chandigarh. I am thankful to Professor Vasant Kumar, Dr. Ankur Mandalia, and Dr. Vijay Upadhyay, along with other members of the organizing committee, for inviting me to deliver this talk here in UP UK Iapscon 2022. I have been associated with PGI MER Chandigarh since January 1986, when I joined as a junior resident in Department of General Surgery, and after completing my MS and MCH from same institute, I joined as a faculty and then rose to the rank of professor and head Department of Pediatric Surgery. This is Advanced Pediatric Center building in PGI MER, which is 250 bedded tertiary care hospital catering to the people of Chandigarh, Punjab, Haryana, Himachal Pradesh, J&K, western part of UP and Rajasthan, apart from referral from all over the country. The Department of Pediatric Surgery was established at PGI by Professor Iqbal Chand Pathak after his return from London. First MCH course was started in 1968, and since then there is no looking back. We have trained around 170 trainees till now in last 54 years, and the sheer volume of patients coming to PGI are testimonial to the legacy of Professor I.C. Pathak, and he is presently 98 years old, healthy, mentally active, and guiding light for the future generations. We are the busiest center in India, operating more than 300 tracheal fistula and more than 200 ARM per year in our institute. This photograph shows all 4 heads of the Department of Pediatric Surgery at PGI Chandigarh. This was taken during one of the Teachers' Day celebration when all professor was junior colleague is Professor I.C. Pathak. After that, Professor Somen Kumar Mitra was HOD, and then Professor Kiran Rao and it's myself. We all know this famous Danish gentleman Harald Hirschsprung, after who this disease is named, and he presented 4 neonates, and all 4 neonates died due to constipation, and he attributed this to dilatation and hypertrophy of the colon. Before 1948, there was no treatment for this disease at all, and all patients died. Even the stalwarts of pediatric surgery like Latz and Gross did not think that time that there could be any remedy for this condition in future. This gentleman, Orvar Svensson of Swedish origin, is the first one in 1948 performed one operation which changed the way we now looked at Hirschsprung disease. That procedure is known as Svensson's procedure. He has a long life of 103 years, and he witnessed the advent of antisepsis by Lister to the starting of robotic surgery. In 1947, he did first manometry and showed that was active contractions in the proximal colon, whereas distal wall don't have any contraction. Zulzer and Whitehouse, they were both pathologists, and they were the one who described the presence of ganglion cells, which form the embryological basis of Hirschsprung disease per se. Hirschsprung disease is a heterogeneous disease with wide spectrum and varied presentation. Neonatal presentation of Hirschsprung disease is different from those in the older children, and functional constipation should be differentiated from the constipation due to Hirschsprung disease by careful history and physical examination added with radiological investigations. And the length of aganglionic bowel can be from the ultra short segment to short segment, which is the most common, then long segment, and rare cases total colonic agangliosis, and even rare total intestinal agangliosis can be there. The basic surgical principle in Hirschsprung disease is to remove the aganglionic bowel and anastomose the proximal ganglionic bowel to the anal canal without disturbing any anal sphincter function. And in and so various surgical procedures were developed to achieve this target. Like this is Swenson procedure, then Duhamel procedure, then this is Saube. All these procedures achieve the same basic principle. So that was taught to us by Professor K.K. Verma also long back in 90s when he was visiting professor and presenting papers in Iapscon, that you practice any one of these methods, whether you practice Swenson, whether you practice Duhamel or Saube, you practice this one procedure and your result will be much better. So one has to be trained in one particular procedure. Don't go on one procedure, then after 6 months another procedure, then you try another procedure. In emergency situations, you have to deal with enterocolitis, perforation, and non-decompressing bowels, which require resuscitation in the form of intravenous fluids, IV antibiotics covering anaerobes also, rectal washouts, and if fails, then you have to go for stoma. We are doing Hartmann procedure in our babies. And definitive surgery can be done later on. We manage our patients of Hirschsprung disease based on this algorithm. If a suspected Hirschsprung patient comes, if it is a neonate, then we have to resuscitate. When it becomes stable, then we go for barium enema. If unstable, then laparotomy, not decompressing. If transient zone is not seen on laparotomy, then go for high divided sigmoid colostomy and prosection or biopsies. If transient zone is seen, then we go for Hartmann procedure. Similarly, in older children, when presented with chronic constipation, we have to rule out the thyroid disorders and functional constipation. And we subject these babies to barium enema. If it is a conclusive and this is a short segment Hirschsprung, we go for straight to TPT. If it is not short segment, then we have to go for Hartmann procedure. And depending upon the distal end of histopathology, if ganglion cells are absent, we modify to Duhamel pull-through. Here, if barium enema is inconclusive, we go for full thickness rectal biopsy. If ganglion cells are absent, we go for modified Duhamel pull-through. And if ganglion cells are present, then again we have to reverse the Hartmann procedure. Here, when I am talking about thyroid disorders, Professor Subhas Dalal was there. Actually, he was my examiner in MCH pediatric surgery also in 1991. So when he came to PGI during one of the talk, he just told us that, see, even if you go for thyroid function test and it comes out normal, so there may be subclinical hypothyroidism may be there. So you start low dose of thyroxine in these children and they usually improve. I have tried in few patients and it works well. But now with this era of evidence-based medicine, we cannot try without any proof of that. So this was by Professor Subhas Dalal. So we tried and it was working well. Our departmental data shows that we have operated around 1,300 cases of Herpes disease. Initially, we were doing both Duhamel, Swenson, Sobe, because Professor Mitra sometimes used to do Swenson, sometimes Sobe. Professor Kelan Rao used to do Duhamel. So I have seen all those things, and then we primarily now doing Duhamels, modified Duhamel, and in selected cases where the patient is good body weight, decompressing, short segment Herpes, then we go for single stage transient pull-through. Our results have improved considerably during these years because of refinement in pediatric anesthesia and post-operative care. And there is a great improvement in the pathological diagnosis of Herpes disease also. We have a good collaboration with our pathologist for frozen section and paraffin sections. Sometimes, rarely, we see 1 to 2 cases of total colonic agangnosis per year, which we manage differently. In my personal experience, I have operated around 436 patients since I joined as a faculty in 1992. And out of that, I did only 85 cases TEPT. In 2002, I performed the first transaxillary endotracheal pull-through in a 21-day-old baby. And this was publicized by various leading newspapers. And after that, the parents started demanding for this single-stage stoma-less, scar-less surgery. But it was not possible to offer all of them this surgery because of the strict inclusion criteria for single-stage transaxillary endotracheal pull-through. How this idea came for single-stage TEPT? This came from the fact that rectum has propensity to prolapse, and in extreme prolapse, the entire rectum can come out of the anal canal. As you see sometimes in ileocolic interception, same thing comes here. So surgeon uses this prolapsing ability to eviscerate and resect it via the transanal route. For primary pull-through, child should be in good general condition with no evidence of enterocolitis. The colon should be non-dilated, and the most important, there should be availability of good pathologists with frozen section facilities. And it is only indicated in short segment Herpes disease. In our center, we usually prepare the bowel by 1 day prior to surgery by total gut irrigation using normal saline at the rate of 25 ml per kg per hour for usually 4 hours or until the effluent is clear. And we inform the frozen section team 1 day prior to surgery. This is one of the barium in a picture. This baby was 10 days old. I operated in AIMS Rishikesh, this child. This I am showing this barium enema because this is a classical barium enema, though books write that barium enema is not conclusive Herpes disease in neonatal period. But you can see that, and we are doing in neonatal period in our center also, but this is one of the picture of barium enema showing classical Herpes disease. See here, initially, we used to use ring retector, then multiple seal suture to evert the anal canal. But with Starlone detector, it is less time consuming. You can put these hooks and it gives good exposure for your surgery. This is the operative photograph showing constricted segment, then transient zone, then dilated segment. And this is the completion of coloanal anastomosis. Here I will show you very brief video. This is a incision given about 0.5 to 1 centimeter above the dentate line. And here is this mixture should be just below the mucosa so that you can see this silver color sign, because here you can see the silver, this one, and then you cut circumferentially all over from 6 o'clock to 12 o'clock, then again come to 6 o'clock. And you have to take multiple 40 or 50 silk sutures on the proximal mucosa. And then these all sutures should be hold together for uniform, see here for uniform traction on the bowel. And then you go on separating the intramucosal plane. And once you get the submucosal plane, then dissection becomes very easy, and with peanut, see, you can separate it very nicely. See. And once you see the rectal cuff, see, there is a rectal cuff, then you incise it and take one marking suture so that while mobilizing, you may not twist the bowel, so that at final anastomosis, it will be in correct alignment. And after this, you just take frozen section biopsies at 4 places, send to histopathologist, and then ask the pathologist to inform you the proximal most frozen section, whether ganglion cells are present or absent. Meanwhile, you have to wait, and once you get the information within 15-20 minutes, then you go on proceeding with coloanal anastomosis. Multiple 5-0 Wycliffe sutures are used. Here the video is not very clear, but within few seconds it becomes very clear. So multiple sutures are taken from the mucosa and then from the ganglionic bowels. So we can skip this video now. This is the specimen showing how we have taken this frozen section biopsies from 4 points. And this is the picture showing frozen section biopsy report showing the proximal one being the ganglion cells absent and distal being the ganglion cells present. In post-operative care, we usually remove anal pack after 24 hours and feeds are started on 3rd post-operative day, and usually we don't do routine anal dilatation unless in post-operative period we see any narrowing on distal examination. However, patients are instructed to see for perianal skin excoriation, which usually lasts for 2 to 3 months because of the frequent stooling pattern, and to recognize the symptoms and signs of post-operative enterocolitis. The advantage of single-stage TPT is that there will be no scar in abdomen or perineum, no stoma and its related complications, less pain, shorter time to recovery, shorter hospital stay leading to less separation from the parents, and less mental trauma to parents because of the total gut irrigation which you are giving on one day only through rice tube. Otherwise, every day you have to give rectal washout. So mother and father have to catch the hands and foot, and then nursing personnel will give the washouts. It is cost effective also, and it avoids multiple admissions and anesthesia. Most common complications of perianal excoriation, apart from that, enterocolitis, wound infection, persistent constipation. In literature, there is a 6% incidence of enterocolitis and 4% incidence of stricture. Now coming to the controversies in TPT, should the pathological transition zone be determined before beginning anal resection? We usually don't do it, but however, literature describes that small umbilical incision or laparoscopy can be done and take preliminary biopsy before proceeding for this. How high above dentate line should the dissection start? It should be low enough so that there is no significant residual aganglionic segment that may result in persistent constipation, and it should be high enough above the dentate line so that normal sensation is not interfered. I usually do it above 0.5 to 1 centimeter above dentate line, depending upon the age of the patient. How much of the ganglionic ball should be resected? It should be resected above the level of transition. We usually resect 5 to 7 centimeters above the transition zone because we think that dilated ball does not have normal motility and transition zone is not symmetric around the circumference of the colon. Few years back, we did a study in our department and we correlated the intraoperative findings of transition zone with contrast enema findings and then post-operative and then frozen section and paraffin section. And we found that in 67% of the cases, the contrast enema was positive and the level of transition zone on contrast enema matched well with the intraoperative level of transition zone and confirmed level on frozen section followed by paraffin section. In 33% of the patient, equivocal contrast findings were found, which were subjected to full thickness rectal biopsy. However, after full thickness rectal biopsy, when you go for definitive pull through, there will be significant problem during dissection, and it takes more operative time and more blood loss will be there. This is one of the scoring system we developed depending on the frequency of defecation, stool consistency, soiling, urgency period, and need of diapers. Our about 94% of patients had good quality of score, and only around 3.75 had poor quality of score. Only one patient needed conversion to colostomy because of the leak and later on stage procedures. 3 patients developed stricture at anastomosis, which responded very well to regular dilatation programs. Our long-term results are that there is a good continence and stooling pattern in all the children. Now coming to the choice of procedures, it depends upon the surgeon's expertise, availability of experienced pathologists, that is one of the important factors, then level of transition zone on contrast enema, presence or absence of contraindications. Now I want to end my talk with a small note by Orvar Svensson that resection of the aganglionic colon is a difficult operation. Yet, if a well-trained surgeon has an opportunity to observe the technical details of the operation and then practice it, good results can be obtained. This is one of my patient who responded to the Ghanti Bajao Corona Bhagao during the first pandemic. So he was doing the same thing and he sent me this video. I am thankful to all these my children and parents who have given me opportunity to serve them. And all these children are doing very well socially and academically. Some are in medical school, some are in engineering college. So I am really thankful to all of them. And next, I want to invite all of you to City Beautiful on 10th and 11th September. And early bird registration has extended till 20th August for all of you. And on 9th, the one day prior to this conference, there will be third Professor I.C. Pathak oration between 4 to 5 p.m. So I request all of you to attend that oration. Thank you very much for your patience hearing and giving me this opportunity to share my experience.
So you essentially have done endorectal Suave's pull through.
Yes.
So have you ever divided the muscle cuff posteriorly?
Yes, yes. Sorry, I forgot because I escaped that my video. You have to divide because if in that video it is shown that you divide the cuff posteriorly so that it will not cause any obstructive effect.
So what is the upper limit?
What?
What's the upper limit till you divide?
Till from where you can just feel and cut it.
Okay.
Because it is blind. So you have to just feel it and then cut it.
Oh,
Once it opens, then there will not be any constriction at all.
Have you ever done Swenson's the endorectal pull through?
I have seen once Professor Wakalu came to PG and then he demonstrated well like that. But I have not done. I have done only modified Duhamel and TPG, that's all.
And
because you go outside the mucosa. You go outside the muscle by mistake.
And the youngest child you've done this procedure?
10 days. This is actually, it was done at the AIMS Rishikesh by mistake.
So this is my most favorite way of doing things also, but I've never divided the muscular cuff. So a lot of people question me all the time. That's why I asked the question.
No, it has to be divided. I was divided because I learned from in 94, some workshop was there in Coimbatore by Coran and some Hashimoto disease workshop was there. It was demonstrated there.
Confirmation of the Hashimoto disease at the 10 days.
What? कहाँ पे? अच्छा, वहां से बोल रहे हो यार. अच्छा, thank you. Okay, Vivek. No, we usually send this frozen section and we usually get the report. Then maybe within 2-3 days this comes. But we have not found any discrepancy between the two. Because we wait till the result comes for frozen section. But if they show that ganglion cells absent, then we have to go up. Okay.
So we have histopathological.
No, we are not doing any. We are relying only on barium enema. That's what I told, that it has 100% cases in match with the transition zone. That's why we are not doing any pre-op rectal biopsy or nothing else.
If you do the rectal biopsy, then the dissection becomes very difficult.
Very difficult.
So I think you're relying upon barium enema alone, not even anorectal manometry.
No.
That's you have already said, so we accept that. What are the problems? If you have faced any problems or not? Most people who did transanal, including Coran, they abandoned the procedure after some time. I did 19 consecutive cases, and just about the time I was realizing some problems, Coran wrote a paper saying that it stretches the muscle to such an extent that it may later on lead to micro damages to the muscles, etc. So I was also very reluctant to go ahead. But since you have been doing it and you have got a long series now, I think please enlighten us on that.
No, I did not find any problem with this transanal pull through. Because see, if child is eyes is smaller, the dissection is very easy. Because oldest patient I did he was 7 years old, 7 or 9 years old from Srinagar. But he is totally all right. He doesn't come for follow-up, not even once. But when we talk to them, they say that this is perfect. Why there is any need to come to Chandigarh? So that was the 7 or 9 years old child, and the smallest being the trainer. But I did not find. But that's what I am telling. Do whatever procedure you want to do, but practice that one. And another thing that I like that Pina's advice, that you should enjoy the surgery, whatever you do. Either you do Swabel, either you do Duhamel, either you do Sensen. Whatever you do, do it lovingly, do enjoy it.
गाना ना लगा देते पीछे क्या? गाना ना लगा देते हो पीछे enjoy कैसे?
So, Sir Ramsamaj, I enjoyed your presentation, but I just have one huge concern in the back of my mind. What are the chances of your diagnosis being wrong based on barium enema in newborns?
अभी तो नहीं.
नहीं, doubt होने से नहीं करना है.
And if the diagnosis goes wrong, then what happens?
अगर आपका classical हो नहीं है, then you have to go for rectal biopsy. अगर उस पे classical transition zone है.
Suppose your diagnosis goes wrong at surgery and they say that ganglion cells everywhere, then how do you support it?
You tell me any other condition where you will see on contrast.
Wrong barium enema. Somebody pushed it contrast at a force and got a dilated bowel. That's the common thing happen.
Force it here, so then you will not find concentrated zone down also.
You may.
No.
So there are fallacies of
I can understand.
Barium enema is 100%
institute, I have not. In our institute, I have not found any barium enema where I missed the diagnosis. You can ask your daughter.
As a teacher, we are responsible for teaching and passing all these messages to our, next generation.
See,
to learn.
yeah,
We are
yeah.
sort of teach them that
You are right.
like this, and they like.
Yeah, you are right.
You
are right.
We can discuss it later.
That if it is clear cut or clinical and barium, we could proceed.
Clinical
if
also.
it is not clear cut or clinical,
Then you go for
That's what it is.
Thank you, sir.
अरे लग गई चोट बेचारे के चलो
Resection is so much more difficult nowadays.
Dr. Ashutosh Pandey, sir, is senior consultant pediatric surgeon in Vivekanand Polyclinic, Lucknow. Sir has more than 25 years of experience in complex reconstructive surgery for congenital pediatric anomalies. Sir has also been the founder, member, and former secretary of UP and UK chapter of the IAPS. Welcome, sir.
Thank you. Good afternoon, everybody. Thank you, chairpersons. And I thank Dr. Basan, Dr. Ankur for giving me this opportunity to deliver this talk. The topic which was allotted to me was GI bleeding in children. I was thinking about it, what to speak on this topic. Well, this is something which has not seen much of change over the last 10 or 15 years. And most of the management aspect is in the hands of pediatric gastroenterologists. So we get surgical patients which are already diagnosed most of the times, and the management is straightforward. So anyway, so we'll proceed with the topic. So what is new and what is relevant to the pediatric surgery practice? I am in practice purely and not associated with any academic institution. So my experience is limited to that of a purely private practice sector. So one thing which I would like to say is pediatric surgeons should need to learn upper GI and lower GI endoscopy. So this is something which is lacking in most of the training programs, and most of the GI bleeding patients, they require all of them require endoscopy at some point of time. So if you are not doing endoscopy, you are missing them, and we get only those conditions which are already diagnosed by the pediatric gastroenterologist. But this also opens up another aspect of the cost and or recovery of the cost and everything, and then your conflict with the pediatric gastroenterologist colleagues. But this will be a good idea to start and learn upper GI and lower GI endoscopy. So basically, we can divide GI bleeding into upper GI, lower GI, and bleeding from obscure causes. It is classified on the basis of ligament of Treats, upper GI bleeding above the duodenojejunal flexure, and lower GI bleed below the duodenojejunal flexure beyond ligament of Treats. Practical aspect is that upper GI bleeding is upper GI endoscopy accessible, and mid GI, which is accessible by either capsule endoscopy or enteroscopy or other investigative modalities, and lower GI is colonoscopy accessible. Just to give an idea. So when we have a patient with GI bleeding, 4 important questions are to be asked. Is it actually blood? And is the bleeding from GIT? What is the site of bleeding and how much blood has been lost? So these questions have got management implications. First of all, you have to ensure that the discoloration of stool or the vomiters which the child is having is actually blood or not, because there are certain things which can mimic as GI bleed, like in the newborn, aspirated maternal blood, or sometimes even dye containing food in older children can mimic blood in stool or blood in vomiters. So then the next question is the bleeding from GIT, whether you have bleeding from oral cavity, from nasopharynx, from other sources which get swallowed, and then it can present as hematemesis, either hematemesis or melena, or aspirated gastric contents can show blood. Then next question is, what is the site of bleeding? Site of bleeding, usually we get upper GI bleeding manifesting as hematemesis or presence of altered blood in the gastric aspirate and melena, and lower GI bleeding presenting as hematochezia or blood stained stool or some other similar condition. Then as far as management is concerned, how much blood has been lost has got a very important implication, because the child needs to be resuscitated, and at the time of presentation, the blood pressure, the heart rate, the pallor in the child, and other clinical factors, and then hematological investigations, they help us in determining the amount of blood which has been lost, and then accordingly we proceed with the management. The causes of upper GI bleeding are broadly divided into variceal or non-variceal. Variceal, you can have extrahepatic portal vein obstruction or chronic liver disease. Non-variceal are ulcer, coagulation disorders, vascular malformations, and other miscellaneous causes. Then dividing the causes according to the age, in newborns, you can have swallowed maternal blood, then hemorrhagic disease of newborn, gastritis, vascular malformation, and idiopathic causes. Then in infants, gastritis, esophagitis, stress ulcers, and so on and so forth. And beyond infancy and up to 2 years, you can have commonly esophageal varices, peptic ulcer disease, or gastritis. So these are the common causes. You can have other uncommon causes also, which can have more surgical implication. Then diagnosis, endoscopy is the mainstay. Then other diagnostic modalities are radionuclide studies like technetium 99 label erythrocytes or sulfur colloid. Then conventional angiography, which can also be used for management for embolization of a major bleeding vessel if it can be identified. Then CT angiography and blood urea nitrogen to locate the site of bleeding. The upper GI bleeding will have altered blood urea nitrogen, and lower GI bleeding will not. Then management is a combined effort of pediatric gastroenterologist and pediatric intensivist for diagnosis and initial management, and stabilizing the child, establishing the cause of bleeding, and then role of pediatric surgeon comes when the diagnosis is already established and there is a surgical condition which has been diagnosed. So the initial treatment is with drugs, which include antacids, proton pump inhibitors, H2 receptor antagonists, sucralfate, and so on. And then endoscopic management. Endoscopic management is again in the domain of pediatric gastroenterologists, which can include injection, sclerotherapy, banding, or laser or heat treatment, and so on and so forth. So for upper GI bleeding, there is a very limited role of surgical intervention. Yeah, unless you have some condition like NEC presenting as upper GI bleeding with perforation, or acute gastric dilatation with perforation, or some other such condition. In newborn and smaller children, for upper GI bleeding, there is very limited role of surgery. For variceal bleeding, again, surgery has got a very limited role. In pediatric age group, you will hardly find any patient which will require urgent shunt surgery or some other surgery to control the bleeding, because all of them can be managed either endoscopically or, if not possible, then by tips or something of that sort. And coming to lower GI bleeding, which has got more of surgical implications. And common causes are, again, in different age groups, anal fissure, and also according to the severity. So these are the usual causes. In infancy, most of them are non-surgical causes, anal fissure or dietary protein allergy, and so on. In older children and adolescents, we can have more of surgical causes, like polyps, juvenile or syndromic, or multiple polyps, or in still older children, you can have hemorrhoids or solitary rectal ulcer syndrome, then IBD, and so on. Then moderate and severe bleeding in infants, There can be necrotizing enterocolitis, Hirschsprung enterocolitis, and malrotation with volvulus, duplication cysts, and vascular malformations. So all of them will require surgical management or may require surgical management at some point of time. And then in older children, the most common cause will be mucus diverticulum, followed by the other causes. Then again, duplication cysts, vascular malformations, and intussusception, which have got surgical management. In adolescents, the common causes are NSAID, enteropathy, IBD, vascular malformation, and mucus diverticulum. In clinical presentation, hematochezia will mostly be coming from bleeding from colon, and but it is less reliable in infants because sometimes from upper GI source of bleeding also, due to shorter intestinal transit time, the bleeding may present as hematochezia. And again, massive upper GI bleeding may also present as hematochezia. And melena source is usually above the ileocecal valve, and sometimes it can also be in bleeding from proximal large bowel with slow transit time. And occult GI bleeding, which presents as iron deficiency anemia or fatigue or pallor, and which needs further intensive investigation to localize the cause and then decide the management. Symptoms of severe blood loss, we all know. And coming on to classification by amount of bleeding, by the amount of bleeding, we have large volume bleeds and mucus diverticulum, duplication cysts, AV malformations, and inflammatory bowel disease. Then moderate volume bleeds, intussusception. Small volume bleeds with colitis, you can have IBD, cow milk protein allergies or infectious enterocolitis, and with colitis, we can, without colitis, we can have polyp, SRUS, or anal fissure. The management is initially resuscitation and then followed by diagnosing the cause and location of the bleeding, and then subsequently we have specific therapy. The hemodynamic stabilization of a bleeding child will involve assessing the degree of hemodynamic compromise, establishing a venous access, treatment of shock, arresting further bleed, all common procedures. Then approach, again, you have to identify whether it is blood, and blood is from the child, blood is from the GI tract, and then again whether it is from lower GI tract or upper GI tract. So in gastric aspirate, we can find blood, and then further upper GI endoscopy and other investigations are done to exactly locate the cause of bleeding. In nasogastric aspirate, if there is gross blood or 25% of blood tint fluid or strongly guaic positive dark fluid, then it is a upper GI source. And the sensitivity and the positive predictive value and negative predictive values are as given here. Then presence of bile in the aspirate increases the sensitivity of the test. Then exclusion of an upper GI source of bleeding can be done by estimating the ratio of blood urea nitrogen to creatinine. A high blood urea nitrogen to creatinine is in favor of upper GI bleeding, whereas a lower one will be in favor of a lower GI bleeding. The urea nitrogen increases following gastrointestinal bleeding because of an increased absorption of protein from small intestine, or maybe because of decreased renal excretion of urea nitrogen due to hypovolemic state. If ratio is more than 30, it has got a sensitivity of 60, nearly 70% and specificity of nearly 100% for upper GI bleeding. Then again, esophagogastroduodenoscopy is the gold standard for diagnosing and also for most of the treatment aspect. These are the points in history which are used for identifying the cause and localization of the bleeding. Age, characteristics of blood and stool, associated symptoms, they can all help in localization. And then history of travel, recent use of antibiotic for pseudomembranous colitis, contamination, food consumption, family history, and then history of allergies, and then to rule out any other hematological causes. These are some of the pictures of how the blood on the stool can lead to diagnosis. Hematochezia limited to outer of the stool or spots of red blood coating the stool, the sign of a rectal bleed. Then hematochezia mixed through the stool, colonic source of bleeding is usually present, mixed with mucus and loose stools, suggestive of colitis. Maroon colored stool, distal small bowel bleed, or Curan jelly stools, ischemic bowel lesions like intussusception or volvulus, and then melena, usually due to upper GI, or sometimes maybe from anywhere up to right colon. Then correlation of amount, color, pain, and stool characteristics is as given here. So small to moderate bleeding, usually present with pain, is usually due to anal fissure or enterocolitis or proctocolitis or infectious colitis. And then large amount of bleed, there's a whole spectrum which can be due to mucus diverticulum or angiodysplasia. These are some of the pointers in history towards localizing the cause of bleeding, petechiae and so on in hematological disorders. Then antibiotic administration, pseudomembranous colitis, cow's milk protein allergy in a child with cow's milk. And passage of painless, large amount of maroon stool, mucus diverticulum or duplication. A mass prolapsing per rectum with bleeding is a polyp usually, or a prolapse rectum or intussusception. Then recurrent abdominal pain, diarrhea, so on due to IBD. Then these are some of the signs on physical examination, abdominal and rectal. There can be signs of portal hypertension. Then in intussusception, one can palpate the abdominal mass, or on per rectal examination, one can palpate the intussuscepting bowel. Then abdominal mass can also be due to intestinal duplication or inflammatory bowel disease. Then fissures and Crohn's disease can be identified by local examination. Skin tack, fistula, abscesses in Crohn's disease or immunodeficiency syndromes. Then hemorrhoids, rectal varicosities, portal hypertension and constipation, rectal mass at digital rectal examination, polyp or intussusception. There can be some physical skin markers for aiding in diagnosis, like purpura, jaundice, cafe au lait spots, or the pigmentation of lips, iritis or arthritis, or short stature, all giving indication of some associated syndrome or some associated problem, which can be diagnosed subsequently. Then these are the diagnostic investigations. Laboratory investigation of radiography, upper GI endoscopy is the most useful, and followed by proctosigmoidoscopy, colonoscopy, or enteroscopy. The facilities available, including capsule endoscopy, radionuclide scanning, or angiography, or intraoperative endoscopy if it is required. Some of the laboratory investigations are outlined here. Then coming to radiography, okay, so we just skip through all this. In ultrasound, we can see interception volvulus. Juvenile polyps are the most common colonic polyps in children, and if they are multiple or proximally located, then there is a need of total colonoscopy. And when they are multiple, they have to be removed and biopsied, even if they are asymptomatic because of neoplastic potential. And then further subsequent surveillance colonoscopy is required. We'll skip this again. In mucus diverticulum, approximately 50% have ectopic gastric mucosa which bleeds. So it is the most common cause of painless major lower GI bleeding in children less than 2 years. Mucus scan ranitidine increases the sensitivity of the mucus scan as the uptake by the ectopic gastric mucosa is increased here. Mucus scan has a specificity of 95%, but sensitivity is only 85%. But with strong possibility of, or with a major bleeding or a strong suspicion of mucus diverticulum, diagnostic laparotomy or laparoscopy can also be performed. There can be enough justification to do that. Then superior mesenteric artery angiography or technetium 99 labeled RBC. Again, laparotomy can be done. Then duplication cysts are most common in ileum, and they usually occur on the mesenteric side. Intra-abdominal mass may be appreciated in a child either by abdominal palpation or rectal examination, or it can be diagnosed also by technetium 99 scan. It can detect technetium 99 labeled RBC scan can detect bleeding as low as 0.1 to 0.5 ml per minute, and it has got certain advantages, but active bleeding is required for diagnosis of this. And then again, there are disadvantages of lack of therapeutic capability and doubt about its accuracy. Angiography can detect bleeding of more than 0.5 ml per minute. And these are the bleeding detection rates. Again, not very impressive. But when diagnosed, it can also be used for therapeutic intervention. Capsule endoscopy is a non-invasive mode of examining, but there is a very limited usefulness in children, especially in smaller children. And but the diagnostic yield is greater for capsule endoscopy than for enteroscopy. This is some of the data in use of capsule endoscopy. A diagnostic and treatment algorithm usually used for management of children of bleeding. Okay. So to summarize, lower GI bleeding is common. The common causes are different from adults, and these are the usual causes: polyps, colitis, detailed history and meticulous examination, and endoscopy and colonoscopy are the mainstay of initial management. So this is a few points about the personal experience. Upper GI bleeding are usually ICU referrals, and there is very limited role of surgery. Usually present in conditions like malrotation with acute midgut volvulus, acute gastric dilatations or perforations, and sometimes even foreign bodies can present like that. Lower GI bleeding are more common in general OPDs. We can get up to 5 to 8% of patients with lower GI bleeding, and the anal fissure is the most common. Then followed by rectal polyp, polyposis coli, which is about 1 to 2% of all polyp patients. and mucus diverticulum, hemorrhoids, and vascular malformation. Acute lower GI bleeding is in infective causes mucus diverticulum with or without obstruction, or NEC or malnutrition with all those. These require surgical intervention at some point of time or maybe immediately to salvage the child. Thank you.
Professor J.D. Rawat sir is Head of Department Pediatric Surgery and Deputy Medical Superintendent, King George Medical University, Lucknow. Sir has received multiple awards and medals, has more than 100 publications in various national and international journals, and sir has been supervisor and co-supervisor of more than 50 projects. Welcome, sir.
Thank you, madam, for your kind introduction. Respected chairperson and delegates, at the outset, I'd like to thank the organizing committee, Dr. Basant, Dr. Vijay, and Dr. Anku for inviting me for this talk. I'm going to talk on the gastric tube as a conduit for esophageal replacement, and also discuss about the indication, various techniques, and my experience. As we all know, more than many esophageal substitute has been described, like gastric tube, gastric pull-up, colon, and the small bowel. But the every procedure is associated with various advantages and disadvantages, and there is no randomized control trial which tell that which technique is superior. So you have to select the technique and become expertise in particular technique, and then study the surgical anatomy of the baby, and then you have a good post-op care for a good outcome of these cases. And as for indication of esophageal replacement, we all know the common indication is long gap esophageal atresia with or without fistula, or pure esophageal atresia. Various strictures like caustic strictures, peptic strictures, anastomotic strictures, and rare causes. And what is the ideal esophageal conduits? The ideal esophageal conduits are, it is technically simple, reproducible, and adaptable for small children, and it can replace the entire esophagus and allow normal swallowing without gastroesophageal reflux. And it should not tortuous, redundant, and cause mediastinal compression that leading to respiratory compromise, and should function normally for the lifetime of the individual. The various esophageal replacement, as I told you, gastric interposition, and this is mostly done in the adult patient in the carcinoma of esophagus initially, but now this has been adopted in the children. The gastric tube, either you can use a isoperistaltic or antiperistalsis based on the right or left gastroepiploic vessels. Colonic interpositions, either use a right colon, left colon, depending upon the anatomy of the situations. And small bowel usually use the jejunum for the interposition. Brief about the gastric interposition. And the gastric interposition in entire stomach is mobilized on a vascular pedicle and pulled through the mediastinum and anastomosis in cervical esophagus. And the advantage is excellent blood supply and single anastomosis in the neck, and the less risk of necrosis, leak, and stricture. But the disadvantage is that space occupying mass into the chest, leading to respiratory compromise and gastric stasis, increased gastroesophageal reflux. So because of these reasons, some of the people are not using gastric pull-up, and some of the people are using it. And the gastric tube replacement, as I told you, and it can be, it is usually taken from the greater curvature on gastroepiploic vascular vascular pedicle,
and either you can use a stapler or you can do the manual stitching. And the usual route, either you take a retroexternal or mediastinum. And the advantage is that it has an excellent blood supply and resistant to ulceration by gastric acid, ability to bridge a long gap and does not become tortuous and dilated over a time like a colon. So disadvantage is long suture line, and how you can reduce this. Because of the long suture line, there is a very high incidence of leak and mediastinitis. So to avoid that, I am basically staging the procedure to reduce these complications. And other disadvantage is continued acid production in the tube. Since it is a gastric tube, so there is no issue. The acid is produced by that tube, and reduce stomach capacity. That is the one thing which require care during making the gastric tube. The brief about the surgical anatomy and the vascular supply of this stomach. We all know in gastric pull-up, you have to ligate the left gastric artery as well as the short gastric and the left gastroepiploic vessel, and then you have cauterize the duodenum and pull the stomach into the through the mediastinum into the, and do the anastomosis in the neck. But in gastric tube, as if you are using a isoperistaltic, then you have to ligate the left gastric artery as well as the short gastric and preserve the right gastroepiploic artery, and then you make a the gastric tube, and you can bring either retroexternal or through the mediastinal. The colonic interposition, you can use any part of the colon, and the either isoperistalsis or antiperistaltic, and subexternal or transthoracic or mediastinal route. And disadvantage of the colon is that anastomotic leak, which has been reported around 30 to 50%, stricture formations, intrathoracic redundant colon with stasis, and that lead to the respiratory distress and gastric reflux. So every procedure have its advantage and disadvantage. You have to choose and practice accordingly, and then your outcome will be better. The small bowel substitution, usually this is the last priority, and this is commonly used in the adult, and advantage is that its diameter is almost matching with the esophagus, and jejunal retain the peristaltic activity, and the disadvantage is that it has a precarious blood supply and difficult to achieve tension-free anastomosis, and graft necrosis, ischemia, and stricture. These are the common issue, and you have to sacrifice little bit bowel to make a state so that you can make the anastomosis in the neck. My experience in KGMU, I have treated 25 patients from 2007 to till date, and the male-female ratio is 3:1, and the pure esophageal atresia was 17 cases, and 8 cases were long gap esophageal atresia with tracheoesophageal fistula. This is my first patient which I did in 2007, and a gastric tube in 3 stages, and since then I am practicing this technique, and this patient is now 15-year-old and 155 centimeter and 44 kg. So my other patient is also doing well. So this is one of the photographs which I taken day before yesterday from the parents from the Gorakhpur. I usually proceed by 3 stages. The first stage as life-saving, you all know, cervical esophagostomy and the feeding gastrostomy. In the second stage, I make a isoperistaltic gastric tube, and then through a retroexternal route, bringing through that into the neck and making stroma close to the previous ostomy. And in third stage, after 1.5 months later, when the edema gets subside, fibrosis becomes settled, then we are doing the anastomosis like a colostomy closure or ileostomy. And second stage, usually done at the age of 9 months to 1 year, and all the pre-surgical investigation is done. And the most important thing is the dye study. We are doing the contrast study of the stomach. You can see the nice good volume of the stomach, and then you can think for the tube formation. Otherwise, if the size of the stomach is small, then you have to think alternative. Brief about surgical procedure. Under general anesthesia, you have to measure the length required for the gastric tube from the ostomy, this previous cervical esophagostomy, to the lower part of the sternum, and then midline incision is given, and the stomach is mobilized along the greater curvature, right from the fundus, ligating the short gastric, left gastrocleploid, and while preserving the right gastrocleploid, and we are not touching at all to the lesser curvature, and then we are creating a tube, and we put a 24 to 26 number of this abdominal drain through the highest point of the fundus and along the greater curvature, and we usually use a stapler for making a tube, and usually 2 fires are more than enough for completing this gastric tube. And then you can see that this tube is coming up to the neck without tension, and then we make a tunnel retroexternally. It's very simple to make the tunnel. Initially, you make a small incision close to the lower part of the sternum, and by help of the finger and peanut, you can slowly go inside, and you can inject a saline directly under the that sternum, and that will make a good dissection, and you can go up to the upper end and then give an incision here and make a tunnel, so and dilate it sufficiently so that you can bring the tube nicely, and then this tube is brought up to the neck through that retroexternal tunnel. And this is the, then create a ostomy. This is the 7th day post-operative patient, and we are doing the gastrostomy, and same times we are doing the jejunostomy, so that we can start early feeding after 48 to 72 hours. And in the 3rd stage, around 2 months of age, once the edema and other things get subsides, and sometimes this upper end get steno something, then you do the contrast study, and then you can nicely see this gastric tube has been made, which can see the equal diameter, there no stenosis seen, and then you close the ostomy like a normal colostomy or ileostomy. And this is the follow-up contrast study. You can see this is the dye study. You can nicely see the gastric tube and the size of the stomach, and so we have total 25 patients. 19 patients have completed all stage of surgery. 4 patients is waiting for definitive surgery, means 3rd stage, 2nd stage surgery. The mean weight at time of 2nd surgery was 9.5 kg, and mean age at the time of 2nd surgery was 8 to 9 months. And the mean time of surgery in the 2nd stage was 90 minutes, and the duration of hospital stay was 7.7 to 10 days. And in 3rd stage, 35 minutes and 4 to 5 days. And out of 19 patients, 4 patients developed minor leak at the anastomotic site in the 3rd stage. That was managed conservatively. 1 patient developed anastomotic stenosis at the cervical anastomotic site. That was managed by simple dilatation. 1 patient died in the 3rd stage on the 3rd day, probably due to upper respiratory tract infections. Patient was otherwise well initially 2 days, and none of the patients required post-operative ventilatory support. That this is things which I want to stress you, that in the beginning, on the places where there is no PICU and ICU are good backup of pediatrics. In that situation, this technique is very good because no patient require any sort of post-operative ventilatory support. All patient is surviving well. And this is the follow-up endoscopic view in some patient. This is distal rudimentary esophagus, and this is the esophagogastric anastomosis in the neck, and this is what gastric tube looks like. So on conclusion, the 3-stage surgery for gastric tube reconstruction may avoid major complication, which is normally blamed for gastric tube, is that long suture line, leak, anastomosis stricture. If you are staging the procedure, you can avoid all the things. And short operative period, basically
In the second stage, who are doing the complete surgery, it will take 2 to 3 hours to complete it. But here you are hardly 1.5 hours, you can complete the second stage. So the short operative time, less surgical trauma and better outcome. And this is useful alternative in the resource limited condition with optimal outcome. Thank you very much for patience sharing. Thank you, sir.
I request all the esteemed speaker to kindly come on the dais for group photo. Professor S. Rai Chaudhary, sir. Professor J.D. Rawat, sir. Dr. Ashutosh Pandey, sir. Professor Ekangli, sir.
लाइट बंद करवाओ पीछे वाला प्लीज एवी प्लीज टेक दिस ऑफ one more is coming.
Thank you.
So we will start the next session. Tea is the tea counter is live, so we'll have we will not break for tea. We are sorry. We'll just continue with the next session. People can take tea inside if you want. It's okay.
Yeah. Before to going to next session, there is an announcement. The faculty who is registered here, either junior faculty, every person who is registered here, we have a small memento for them. That is the gratitude for him to coming here. Okay? So please attend this session. After this session, we will provide each. Okay.
वहाँ से वो खोल लीजिए चेयरपर्सन वाला
एक सेकंड इसको खोल देता हूँ इसका ये है ना खोल लो
नेक्स्ट स्लाइड
ये ना
अभी पहले चेयरपर्सन वाला
ओके
हाँ
वो आज है प्रोजेक्ट
Yes, sir. So coming to the third session, that is oncology and the urology part, I would like to invite the chairpersons to grace the dais. First, I will invite Dr. Vireshwar Bhatnagar, sir. Sir, please come on to the dais. And secondly, I would like to invite Dr. Rajesh Gupta, sir, and Dr. Arun Gupta, sir, and Dr. Nitin J. Peters, sir. Sir, please come on to the dais. So, as I said, this is the last session of the day and it includes both oncology and the urology part.
Starting with the oncology part, first talk will be given up by the Dr. Sandeep Agarwala sir. He will be giving a talk on the hepatic resection. So a brief introduction about sir. Sir is a professor at the Department of Pediatric Surgery at AIIMS New Delhi, where he is a faculty since 1994, and his key areas of interest are oncology, thoracic, and the neonatal surgery. He had more than 300 of publications in peer-reviewed journals, and also he was the author for the 95 chapters, and he is also editor of many books. He was also a member of the IAPS. He was the chair of surgical section of the IAPS, and he was also an executive board member of the various societies. Sir, over to you, sir.
A gentle request to all the speakers, please stick to your time allotted. Thank you.
Good evening, and I must thank the organizers of this conference to invite me for this talk, and I like to keep it short and crisp. So today I will be talking on liver resections in children, indications, and some aspects of surgical technique, which we'll cover. So these are the causes of hepatic masses in children as described by Weinberg way back many years ago, and most of these causes actually lead to resections. Some of them, as the benign vascular tumors, may not need resection sometimes, but in others resection may be required for cure. So like in hepatoblastoma and HCC, tumor resection is the mainstay of therapy, and unless you get a gross complete resection of the tumor, there is no hope for the child. Resectability also depends upon the area that you're working in, the expertise of the surgeon, and the support systems which are available, the technical help which is available. And that can at times extend the quality of resection that you can do. So there are various modes or timing of resection. One is the primary resection for those tumors which do not respond to chemotherapy or chemotherapy is not required for them. Then there is resection after neoadjuvant chemotherapy, as is commonly done for hepatoblastoma, in which I will explain the advantages of neoadjuvant chemotherapy. And resection can also be done with hepatectomy for patients who need liver transplantation. So pre-op chemotherapy, especially in hepatoblastoma, it increases the resectability rate. Upfront resection is less than 25%, but with chemotherapy, more than 90% of the patients can be resected. It makes the tumor more solid, easier to resect, less blood loss, and the tumor is more delineated. So you can actually decide which sectors to resect. Primary resections are usually associated with high rates of incomplete resection and can lead to recurrences. So in hepatoblastoma, the current resection rates are upward of 90% for standard risk hepatoblastoma and more than 80% for high risk hepatoblastomas. But this includes those patients who need hepatectomy. So 85% of, unfortunately, 85% of HCC patients in pediatric age group are not resectable at presentation, and we usually lose them. So as I said that it includes resectability. If you look at this chart in SIOPEL 4 way back in 2009, they reported a resection rate of 97%. But this included 27% of the patients who actually underwent liver transplantation. It means their liver tumors were such that needed resection of all the 4 segments or certain other added parameters which could not undergo routine resection. So liver transplantation, hepatectomy and liver transplantation forms an important part of the resectability quotient. And you look at the overall survival is upward of 80% for hepatoblastoma and high risk. Pre-op assessment of patients is very important for planning the resection. This includes a triple phase or a phase contrast CT scan, a good ultrasound Doppler, especially for vascular involvement. Sometimes now more and more 3D reconstructions are described to actually assess the vascular anatomy and the relationship of the tumor with the vessels. A diffusion weighted MRI is now nearly an essential part of the workup of these patients because this is the best modality to pick up satellite nodules. And if there are satellite nodules in the segments that you're planning to leave behind, then you have a problem. And now
more and more 3D models are being developed to help the surgeons in planning beforehand surgery, where are the problems going to arise. The technique of liver resection is quite standardized, and it is based on the cuneous segments, which we all know. And the best form of resection is the anatomical resection of various segments. The standard resections include a right hepatectomy, which includes segment 5, 6, 7, 8, a left hepatectomy, which includes segment 2, 3, 4, a left lobectomy or left lateral segmentectomy, which is segment 2, 3, a right extended hepatectomy, which is right hepatectomy plus segment 4, and a left extended hepatectomy, which is left hepatectomy plus segment 5 and 8. The most difficult resection is a left extended hepatectomy because of various anatomical considerations. Non-anatomical resections are best avoided and can be used in very special circumstances only, should be used in very special circumstances only. Adequate exposure is a must, which can be through a rooftop incision or a Mercedes-Benz incision. And this is a retractor which I've highlighted here, which was designed by Dr. Bhatnagar. And we use it regularly for a good exposure. And this leaves the hands of the assistant free for it. The other part is the mobilization of the liver, as was explained in choledochal cyst also. And it nearly brings out the liver to the surface and exposes all the supra and intrahepatic IVC also. The intraoperatic assessment, both clinical and if required, ultrasonic, is very important to assess the margins and the resectability of the tumor. So intraop assessment, as I said, has to be performed before we start resection. And most important part clinically is to judge whether the retrohepatic IVC can be cleared, especially for the right hepatectomies or not. Then the porta dissection is carried out. And as we learned from Dr. Bhatnagar, all the portal structures are identified and looped before we start to divide anything. So one must not be in a hurry to start dividing artery or vein or something. So loop all the structures, identify all the structures for a safe dissection. And usually most surgeons would get control of the IVC, especially in right-sided resections. The suprahepatic IVC is shown here looped. The infrahepatic IVC is looped just superior to the renal vein, and that way we have a control on IVC. So if there is excessive bleeding, then the IVC can be snugged down, and the gastroduodenal ligament can also be snugged to control the bleeding. The resection margins, after having tied the vessels, clear margin appears, and the resection margin is first marked, and the first about 0.5 centimeters of the resection of the parenchyma can easily be done with the standard monopolar cautery or a spray cautery without any other equipment. The Pringle maneuver can be performed to decrease the bleeding. Both the surgeon and the assistants have to be good. They have to use their hands to compress the liver as shown in this diagram here. And there, if required, in some cases, total vascular exclusion can be obtained by simultaneous supra and infrahepatic IVC control and hepatoduodenal ligament control, as I said. Various modes or various equipment are used for parenchymal transection. The monopolar bipolar cautery is the commonest. Finger fracture or Kelly's clamp fracture has been described. All the techniques take time, and to decrease the blood loss, you have to be careful. Harmonic scalpel is now routinely used for this division, and the best dissector, which also takes time, is a CUSA dissector, which is shown here, which will divide the parenchyma but leave all the vessels and the ducts, which can be ligated off. Ligashore is also used by some people, and now the more and more commonly being used is the hydrojet technique instead of CUSA. So any of these techniques, whichever you have, whichever you become comfortable with, can be used to assist to decrease the blood loss. They all don't decrease the time of surgery required, but they decrease the blood loss, which is very important in small children. Hepatoblastomas are usually 1.5 years old children with weight of usually less than 10 kg. So blood loss is an important thing to consider. Hemostasis is then achieved either by sutures, liga clips, and at the end by argon coagulator, if you have one. Otherwise, hemostatic agents could be used, any of these agents on this surface, and you should have a clean and dry surface. Any bile leak is confirmed by placing a clean gauze on the surface and transfixing those bile leaks there. Now, a few words about the various aspects of resection. Margin is a very controversial term.
recommended margin of 1 centimeter as in adults is usually not achievable in children. And so closer margins, especially to the hepatic vein, portal vein or IVC is acceptable in children. And a few millimeters is more than enough because our tumors, hepatoblastoma if you consider, another benign tumors can tolerate these small margins, and chemotherapy is very good for hepatoblastoma. And it has been very clearly shown that macroscopic residual disease is not acceptable at all because it will lead to recurrence in 100% of the cases, while microscopic residual disease has been shown not to be associated with any inferior results. And this was shown with a very large sample 2 study. And so one must not bother because you must realize that if you, especially if you're using a CUSA, the margins get sucked away from both the sides. So the margins which the histopathologist is seeing is not the actual margin. It is closer to the tumor. So probably that's why the microscopic margins do not cause any problem. Now the other question is how much residual liver is acceptable. So mostly these patients don't have any pre-existing liver disease. So even if you leave 20 to 25% of residual volume, that is good enough for a child. And within 6 months period of a major resection, the liver nearly goes back to normal size. In case of pre-existing liver disease like cirrhosis, which happens very rarely in children, then it's important to assess the residual liver disease, which could be done, the hepatic reserve could be assessed by using ICG clearance test or by using the various radiographic tests for residual liver volume. This is routinely done in adults because they are cirrhotic livers. And then we assess whether the patient will go into liver failure or not. And if the assessment is so that the residual volume is going to be inadequate for sustaining life, in those cases, preoperative portal vein embolization can be done. The portal vein embolization of the part of the liver which is to be resected leads to hypertrophy of the residual liver, and then we can go ahead in 3 weeks' time for a safe resection of the patient. So what are the indications of liver transplantation in hepatoblastoma? All Ptcc4 disease, especially multifocal Ptcc3 and Ptcc4 or unifocal Ptcc4, all central tumors. The best mode of resection for hepatoblastoma for central tumors is basically recommended is liver transplantation because there are large number of complications with central tumor resections. Involvement of portal vein and IVC also recommendation is for transplantation, and involvement of all 3 hepatic veins is also a recommendation for hepatectomy and transplantation. There are various problems of transplantation. Main is the availability of liver, as we heard Dr. Rao speak, and the lack of donors, timing of surgery, especially in hepatoblastoma, cost and acceptability by parents, and then the need for lifelong immunosuppression, which includes the cost, the repeated infections, acute and late rejections, and also long-term use leads to lymphoproliferative diseases like lymphoma. So there are real causes. So once it was shown that transplant is very effective for hepatoblastoma where indicated, people started thinking for those people where transplantation is not available. And also for those, even when transplantation is available, that can transplantation be avoided in certain set of patients. And that is where the other options started to be explored. So as I said in this slide, what when liver transplantation is not an option, as it is in a lot of centers in India, either it is not available or it cannot be afforded by the parents, which means, as I showed in the earlier slide, that complete hepatectomy or reasonable hepatectomy can only be achieved in about 25% of the patients by hepatectomy and transplantation. So which means that 20 to 25% of the patients who cannot undergo transplantation will have to abandon them in hepatoblastoma, which is a large number of patients. So there is where the question of extensive liver resection came into picture, and extensive liver resection may be the only option in these patients, especially for various centers in India. But doing an extensive liver resection, one must realize that rescue transplantation after local relapse has a poorer outcome. So if possible in these patients, transplantation is still the best option. But if transplantation cannot be done because of various reasons that I highlighted, then one can attempt a extensive liver resection if one has the expertise to do that. So what is the feasibility of extensive liver resections? It is because of availability of better devices, as I just showed, knowledge and delineation of the surgical anatomy, which is better done now, and also sometimes
the availability of cardiopulmonary bypass, which could be used for IVC resection and constructions. So these all help us in deciding if we can do a extensive liver resection. What are the indications? As I said, the same indications for liver transplantation would be indications of extensive liver resection if something can be saved. So unifocal, pretext or post-text 4, multifocal, pretext or post-text 3 and 4, and as I said, central hepatic resections. They have complications, but if it can be done by an expert surgeon, then you still have survivals. Otherwise, you'll have to abandon these patients, especially when major vessels are involved. So planned extensive resection, knowing very well that we may have a microscopic positive margin, can avoid liver transplantation in a number of patients. So what are these extended hepatectomies? Like extended right hepatectomy, I said, this where it is done in a pretext 4 tumor where initially all the 4 segments were involved, but post-text 2 and 3 or 4, this is also called an extended because you are risking the patient for a recurrence. And same way extended left hepatectomy in post-text 3 patients. So central resections when hepatic veins are not involved can be done with total vascular exclusion. The problem is this surface. This is easy, but the division between 5, 8 and 6 and 7 is the problem. And that is where a lot of blood loss takes place, and that is where the complications take place. So if one has an expertise and knowledge, one can still proceed with central resection, and after explaining to the parents the risk of this thing. And it becomes even more difficult when all the 3 hepatic veins are involved, because resection of the hepatic veins may either we depend on the direct retrohepatic drainage into the IVC, which may not be adequate, or we have to reconstruct the hepatic veins using prosthesis of vascular autograft, which is not easy at times because they are very thin and friable, and sometimes you need the help of the cardiovascular surgeons to help you out in this. The IVC encasement usually will say no, and centers which have liver transplantation will straight away go ahead with liver transplantation of these patients. But in case, as I said, liver transplantation is not available, then in limited involvement, the resection of the part of IVC and repair with a patch, which is either Gore-Tex or an autologous pericardium, can be done. Or at times in en bloc resection of the whole IVC can be done, especially on cardiopulmonary bypass, and the IVC can be replaced with various grafts. So these are extensive resections which can only be performed by expert liver resection surgeons, especially the liver transplant surgeons, and best performed in centers which have liver transplantation as backup. Caudate lobe resection is also a difficult proposition at times, and a lot of people hesitate in doing this, but after understanding the anatomy clearly, these can be done more easily. So as I said, most surgeons would like to avoid extensive resections. This should be left to people or surgeons who have more expertise of doing liver resections day in and day out. And it is controversial because the results of liver transplantation are very good. More than 80% survival at 5 years was shown way back in 2004. It is now upward of 90% for hepatoblastoma. So primary liver transplantation is much better than rescue transplantation, but unfortunately liver transplantation is still not available to a lot of our patients. So what are the results with extensive liver resections? There are some results which are published, small number of patients from good centers. This is from Georg Fuchs Center in Tübingen, 27 patients, and look at the outcomes of extensive liver resection. They have transplantation, but they chose to do these extensive liver resections in some patients, and good overall survival of 80% and event-free survival of more than 60%. So this is avoiding liver transplantation in a lot of patients. This is from Toronto, Canada, 6 patients, but again, over a 3-year period, no local recurrences and no pulmonary recurrences. So very good outcome. This can be done. This is from Sao Paulo, Brazil, another big center, 24 patients, various kinds of surgeries performed, and overall survival of upward of 95%. So extensive liver resections are also a feasibility in centers. Now, they can be done in various ways, extensive liver resection. One is that you do it because you are expert and you take a chance and a patient makes it. The other is that extensive liver resection is done in a liver transplant center where a donor is on standby, and if you during surgery feel that you cannot proceed with extensive liver resection, you close the patient and next day go for a transplant.
Or even better, the donor is ready in the next table, on the next table at the same time. And once the surgeon who's doing the resection feels that cannot go forward and extensive resection cannot be done, the donor is induced and the transplant proceeds. So these are the various options in centers where transplant is available. So for these kind of difficult resections, it is always advisable to send the patient to a transplant center where the people are more expert, and then they can proceed from there. They may not be able to do a extended resection, but that is the best chance for the patient. So extensive resection should be done if technical expertise is available, and this verdict is still open to house for countries and centers where liver transplantation is available. But even if liver transplantation is available for most places, the donor availability is still a problem for hepatoblastoma, where timing is very important. So to conclude this talk, a structured surgical management algorithm has to be devised for all the patients who require a liver resection, whether it is for benign disease or a malignant disease, to maximize the survival. And if required, expeditious referral, which Dr. Sanjay Rao referred to very elegantly in his talk, that the transplant can't happen the next day or the next night. It has to be done beforehand so that the preparation is made and people are ready to do it on time. And the best time for hepatoblastoma is after 4 courses of chemotherapy, and that should be the time. So post-text 3 patients with at least 1 hepatic vein and 1 portal vein branch which can be spared can usually be resected by most surgeons who are doing regular hepatectomies. So one can attempt this extensive resection. So this is all I have to say for the resection. It has its own set of complications which are not less. Post-operative complications in nearly 20% of the patients, which can be managed by most centers. Thank you.
Thank you, Sandeep, for finishing in time. The subject is open for discussion. My colleagues on the dais, I think they have the preference. So please start, and then maybe 2 questions or comments from the audience.
Short, nice presentation, sir. Just out of curiosity, I want to ask you, in cases of extensive liver lesions where resection may not be possible, sir, is there any role of hepatic artery or branch ligation to reduce the volume of the tumor?
So one must understand ligation of hepatic artery and ligation of portal vein. So one, if we find a tumor which is very vascular, especially in hemangioma, then we can ligate the hepatic artery because these are fed by arteries, and that can decrease the vascularity. And in 48 hours time, you can go in and do a resection, which may be safer. But as I mentioned in the talk, if you're looking for hypertrophy of the residual liver lesion, then you have to ligate the portal vein. That the affected segments portal vein is ligated, then the residual liver undergoes hypertrophy. That usually takes 3 to 4 weeks. So it depends what you are ligating or embolizing the artery or vein for. So it can be done, especially done for vascular lesions. We have done it for some very vascular hemangiomas, and it reduces the. But if you wait for too long, then the new vascularization develops.
Thank you. Thank you for that presentation, sir. My question is that in case of very central tumors which are extending more into the middle hepatic vein, would you still go in for a total intravascular, total vascular occlusion, or go in for an inflow control and then go along and ligate the middle hepatic vein as and when it comes? Because it may be challenging to, isolate the middle hepatic vein or the right and left hepatics during the total vascular exclusion.
So I would say that if in case there is any doubt, I think one must be ready for total vascular control, which means you must have a loop around the IVC, both up and down, and must have a hepatoduodenal loop ready for this. But another thing that's said, if it's a tumor which is involving segment 4, 5, and 8, a central tumor, and the other segments are free, I would do a much easier extended right hepatectomy. That means take out 6 and 7 together, that is safer, and leave 2, 3, which is good enough for a normal patient. Instead of trying to do a central hepatectomy, have problems on that surface with 6, 7, and 5 and 8. So extended right hepatectomy is a safer procedure than trying to do a central hepatectomy with that surface 6, 7 surface. For most regular hepatic surgeons. I mean, liver transplant surgeons can do that all the time, but maybe not for.
So the Japanese have actually mastered the technique of total vascular effusion, and it gives them a window of about 10 minutes to do, and then they have to reperfuse the liver, and then after some time they can again do a total effusion and get another window of up to 10 minutes. So that is how it is done. And in order to preserve the liver, hypothermia again is something which is used. So that kind of gives them more opportunities of these short time segments. Yeah.
Just want to know, how is the hydrojet technology different from CUSA? We use CUSA, but I have no idea about
So
hydrojet.
CUSA is basically ultrasonic.
Right.
And the water which is sprinkled in CUSA is for aspiration. You know, that is CUSA is totally different. A hydrojet is a very high force jet which is saline. So the newer Ercp machines have a hydrojet facility. They have a handle just like a CUSA handle. But you can set the power and it squirts out, which we used to use saline dissection. You know, you use a needle and a syringe for that. That is
So breaks the tissue with the mechanical force of the
so it is a mechanical force which disrupts the
the liver
It is
parenchyma.
not enough force to disrupt the various collagen structures of the vessels and the bile ducts. So it works, but we have used it in a number of patients now that we have it. But it makes the assessment of blood loss very difficult in smaller children. And you have to be very careful with hypothermia because the water, unless you keep warm water, it can be cold water, and large surface area exposed with a lot of water can sometimes cause problems. But hydrojet is very good.
So just to add to that, the tip doesn't have a metallic probe like the CUSA has. CUSA would have a metallic probe which vibrates
just a tip
ultra.
for,
So it just has an opening through which a fine jet comes.
Sir, I'm asking about total vascular exclusion. Sir, what is the window time in pediatric patient, especially less than 1 year? How much time we can exclude total?
So 10 minutes is safe. That's the set.
10
minutes is very safe, but you can do it repeatedly. You know, you exclude. If you can do the surgery without exclusion, it is very good because when you reperfuse, there are various problems. But 10 minutes is very safe. So you do it for either for controlling a very severe bleeder or during parenchymal transplant.
Yeah, during parenchymal dissection, sir, if there is excessive bleeding and we take it is around only 10 minutes, it's too much.
10 minutes is
So
good enough,
usually exceeded the time, and when we release it, child goes into shock and some kind of
Yeah, so you have to be
acidosis.
careful. 10 minutes. Then you use compression, reperfuse the rest of the liver, then go back.
Okay.
Yes, Sanjay. Yeah, no,
Thanks, Sandeep. I think a very, very succinct and very nice, clear presentation. Couple of things. I think I think a standard left lateral, a standard right is, I think, a good operation to start if people are starting out.
Yeah.
They are very standard. They are relatively low risk. The anatomy is very predictable and it's good. What we would recommend, I think it is important that the anesthetists are involved, and at the time of transaction, your CVP should be 0 to 1 or 0 to 2.
Very good.
You should not have high CVP. If you don't have high CVP, when you open into the hepatic venous side of things, you will not have bleeding. You can see the opening, but no blood will come out. The only bleeding that happens from the portal side and the arterial side, and that you can use intermittent Pringle if it is becoming a problem. So I think these are good operations to start, but you must have your anesthetist on board. You know, they have to be stable. The CVP should be low. If they have to use inotropes to perfuse the patient, they should do that, and that makes your dissection safer. And once you are comfortable there, then you can go to other things like central or whatever else, where you require better intra-op imaging. I cannot also overstress the importance of good preoperative imaging. I think it's extremely important. And today's radiologists, I mean, they can create wonders with the kind of modeling that they can do. It's beautiful. So I think those two things are really important. Otherwise, what technique you use really is not so much, as far as you follow this, you know, the safe ways to do it. Whichever machine you have is fine. So they are very good. The one other thing is that at the end of the procedure, we usually, for bile, we put intralipid into the gallbladder and see whether you have the lipid leaking out to your cut surface, and then you can suture. So that works well. And it has, so you leave the gallbladder hanging till the end and then do a cholangiogram type thing with intralipid. Yeah. Intralipid. No, you can see the white. It looks very nice when you see it. It just leaks from the surface. So it's very easy to identify.
Thank you, Sandeep sir, for the very informative talk. And I feel blessed to hear this talk. Next up in the oncology session, I would like to invite YK Sarin sir for the talk on the partial nephrectomy for the unilateral tumors. A brief introduction about the Sarin sir. He is the Director Professor, Head of the Pediatric Surgery Department at Lady Hardinge Medical College, New Delhi. And he is the present President of the Indian Association of the Pediatric Surgeons. And he is also Executive Member of the various societies and the associations. And he also had more than 300 articles published. And he is also author for the several books and the chapters in the textbooks. Sarin sir, please.
Thank you very much.
Yeah, good. Thank you very much. So I'm going to talk about my favorite subject. I keep talking about it and I wonder how many people would buy it eventually. It's about partial nephrectomy. About partial nephrectomy in unilateral, sorry, it's been typed twice, Wilms tumor, indication, surgical technique. So first of all, I want that people should know all this terminology very well. We used to read our textbooks and the only thing that used to be written was radical nephrouretrectomy. And I saw a lot of masters in the world operating India, abroad, and I never saw radical nephrouretrectomy being done. Because when we say radical nephrouretrectomy, we mean we are operating outside the Gerota's fascia and removing everything along with the adrenal most of the time. So eventually I used to question people, nobody would answer me, but eventually there was an article written in some early 2003 or 4 where they described, yes, there is a term by simple nephrouretrectomy when you actually go inside the Gerota's fascia, just go right at the renal capsule and do the surgery. And then, of course, we come to know that only 4% of the adrenal glands get involved because of Wilms tumor. So people stop doing adrenal excision along, so adrenal sparing nephrouretrectomy. The other definitions which are used in literature by different people are total nephrouretrectomy and ablative nephrouretrectomy. It means the same. That means if the patient has got a unilateral Wilms tumor, you are removing the entire kidney basically. And then came the nephron sparing surgery. It didn't just drop down with me, born in this country. It was actually first done sometime in 1960s. Somebody did it in Cuba. It became a little popular in Italy in early 90s, and then some Americans and Canadians and some other people started doing it. And now with the 2016 umbrella protocol of PSYOP talking about it, and they're describing how to kind of document whenever you do NSS. They have also described 2 different ways of doing it. Not that this is also something very new. It used to always exist. So now they call it NSS-A, where you do a partial nephrectomy, meaning by that you remove some bit of normal renal parenchyma when you remove the tumor, and then NSS-B is enucleation. You go right up to the pseudocapsule of the tumor, and there is a dissection plane with little bit of blunt dissection. You will be able to remove this tumor just like a tennis ball or whatever. So all these terminologies that you see on this side, which says polar resection, enucleation, wedge resection, excavation, and all. So they are not to be used. We will call them either partial nephrectomy or we will call them enucleation. And PSYOP says that partial nephrectomy is the best.
in RCC, which is in adolescent and adults, we know that we should remove about 5 mm of renal parenchyma. But for Wilms tumor, although whatever number of articles have been written, there is no clear cut. Some people say 1 centimeter, some say 5 millimeter, some say even 1 millimeter of normal renal parenchyma along is good enough. The diagram which is below, I've drawn it myself just to explain what is simple nephrouretectomy. You are actually within the ureters. And in countries like ours, where the tumor is so big and many of us don't believe in giving chemotherapy, and many times even after giving chemotherapy, the tumor doesn't shrink, the ureter sphacia actually does not show. So really, at times you don't know whether you're really doing a simple or you're doing a radical nephrouretectomy. So this is a disclaimer because I know that a lot of questions otherwise will be asked for those who know the stuff well. The CUG protocol ARN 0534 has allowed NSS in children with bilateral Wilms tumor in a solitary kidney or patients with syndromic Wilms tumor. So these are the patients where doing a partial nephrectomy is indisputable. You go ahead and do it. Or even if the patient has got Wilms tumor and a lot of nephroblastomatosis on the contralateral side, when you think that you need to save, there is no question on that. But SIOP says that, oh, if you have an expertise and if there's a polar or peripherally non-infiltrating tumor where clear margins are anticipated in order to preserve renal function, go ahead and do it. So how did this idea originate? I'm very sure everybody in this hall has been dealing with bilateral Wilms tumor maybe once in a year, maybe 2 in a year, maybe once in 2 years. So similarly, I started getting bilateral Wilms tumor, I started giving chemotherapy to them, tumor would shrink. It was very difficult and it is still very difficult to predict which tumor will shrink and which tumor will not shrink. But what I've been doing is I've been doing the volumetry on the CT scans, and then at times it is 12%, at times even 86%. So I don't know how and why. If I had that kind of genetic and other studies available in my setup, probably I'll be able to decipher that sometime. So, but I will always do a renal dynamics DMSA scan with SRF before or and after surgery and prove that you know, even if I'm doing bilateral or if I'm doing unilateral, I'm being able to save the functioning kidney at least. So the numbers in both pre and post-op were always very similar. So this is another patient with bilateral Wilms tumor. Imagine a very, very large tumor on the right side and a small central sitting tumor on the left side. I mean, traditional literature would say that, oh, remove the right nephrouretectomy definitely. And if you could not remove that central, just wait, give some more chemotherapy and try to something. But once you have the mindset, no, you can actually resect them. You can resect them actually. So we did 3D reconstructions, etc. Of course, we don't have the best of radiology available, but we knew what we are dealing with. And these are the pictures which are post chemotherapy. So I went ahead and did resections of both the tumors, and this patient is tumor free for last 4 years. So operated in 2018. So when such tumors were being operated, mind said that why not, even in a unilateral Wilms tumor, read the literature and then started doing it. So the figures still stay the same. As I said, the RDS still stay the same. So what are other points in favor of NSS? One is that, okay, I can do it. Other is experience with NSS for RCC. Sure, RCC, they've been doing nephron sparing for a long time. Metachronous bilateralization or trauma is known. Second malignancy is known. Hyperperfusion nephropathy after total nephrectomy is known. End-stage renal disease in a unilateral Wilms tumor does not occur even up to 1% of long series. And that was the reason that was given against nephron sparing surgery all these many years. But what people realize is, fine, they do not have end-stage renal disease. But end-stage renal disease eventually becomes the second important cause of death in these patients. And secondly, when they started comparing these patients with the ones who go NSS for unilateral Wilms tumor, they realized that the CKD, say grade 3 or 4, was so much more common when a total nephrectomy was done for a unilateral Wilms tumor. They realized that the need of antihypertensive drugs in these patients was so much more than when a NSS was done. So eventually it became acceptable to at least few people. I'll very quickly run through this review. So there was surgical selection criteria and there were radiological selection criteria, I mentioned before. So polar tumor, which can just occupy 1/3 of the tumor and you could still save 2/3 of the tumor. That was the concept. And PSYOP, even in umbrella protocol, says the same. They say you must be able to save 66% of the kidney if you wish to do a nephron sparing surgery. But if you would read the literature, and a lot of people then came down to 50%. And now a lot of articles, Cme et al. From Italy, they say even if you can save 20% of the functioning kidney on the unilateral side, do the surgery. So SAP also says that at the time of admission, not post-chemotherapy, at the time of admission, if the tumor volume is less than 300 ml, then probably they are suitable candidates if you know how to do it, but make sure that few things are present. Lymph nodes are not positive and substantial remnant kidney function remains, and there is no thrombus in the IVC, etc., etc. So there are a lot of contraindications as well. So this article is from 1998 from Netherlands. They say SFR of the kidney remnant remained well and even permitted contralateral nephrectomy in one patient. So in 98, about 25 years back, or even before that, actually people start talking about the SRF stage of those kidney remnants. The majority of the cases, this is an ad hoc analysis. They did nephrectomies and then they gave the specimen to the surgeon and then they decide, okay, if chance be, if you would have done nephrectomy, could you have done it? So the surgeon sat with the pathologist and they decided, yeah, quite a few of them, they could have actually got away with doing partial nephrectomies. So again, it went on like this. Now, another paper which came from COST. COST is also one of the groups which have supported this NSS in a big way. They said, even if you can spare 1/3 of the kidney, it's good enough. Then Cozy and all came out with a systemic review and the whole lot of patients they had enrolled, and they said that in children with low risk histology, stage 1 intermediate risk histology, Wilms tumor, and a normal opposite kidney, the involved oncological risk of NSS is rather low. And then people started comparing radical nephroureterectomy, and of course they were not RCTs, by the way. They had picked up literature and found this many patients done radical nephrectomy, these many done, and they started doing some comparisons, and they found that there are no statistical significant differences in the oncological outcomes between the two groups, and a reasonable partial nephrectomy candidate will be where we could save 50% of the kidney. So a lot of different versions, 66%, 33%, 50%, 20%. Another paper. Now, this man was the first one who said that the radical nephrectomy is an overly aggressive treatment modality in children with stage 1 Wilms tumor. But the problem is that we know stage only after the surgery. I remember even in an international conference, I snubbed one of my Indian colleagues when she started talking about radiological staging, because there's nothing like radiological staging. Of course, in 90s, there's some articles published where they have talked about radiological staging, but the radiological staging actually does not occur. So how do you know? You can know from your imaging whether it is a metastatic disease or a localized disease. You may say, oh, a CT may pick up a very large lymphadenopathy, but you can never be sure whether the lymph nodes are positive or negative. A lot of studies kept on coming. I kind of would skip it. In SAOP 2001 experience, which is right till very few patients, only 3% of the patients actually had NSS done. But they said when they wrote down umbrella protocol that you can go ahead and do it. So this is the first article that came from India. Narli is a very big name in urology and research. If you would go to his center any given time, some 20 ISMR and other extra neurally funded big projects are going on. So he did the first study and said that, you know, NSS in unilateral Wilms tumor should be done because the serum creatinine clearances, etc., are better. Then we came to know from many studies that actually the overall survival is as good or even better
recurrence rates are not as bad as we were expecting. So this is what they talked about in 2016 umbrella protocol. They said anybody, if it does it, because it's a new thing, new concept, must talk about surgical technique, must tell about a surgical resection margin, pathological section margin should be reported by the pathologist, and remaining renal parenchyma, whatever the surgeon thinks he has left behind should be mentioned in the notes. So complications, of course, the complication, the intra-bleeding urinary leak, and the margin positive. And there's an article in 1999 with Schamberger, who used to be the chairman of NWTS and with whom I worked in Boston as visiting professor along with them. The gentleman had written a paper that, oh, recurrence is very high if you do NSS, and if you have to give a second line treatment, the morbidity, mortality is much more. But then last 20 years, a lot of new articles came which said that, oh, chemotherapy in Wilms tumor is very, very safe, and even there is positive margins, they never turn into recurrence and mortality. So there's no issue about positive margins. Go ahead. Of course, it doesn't mean that you leave some macroscopic disease, but if it is microscopic, just the way we talked about in liver, it doesn't matter really. So then somebody talked about the surgical adjuncts, which include the intraoperative ultrasound. Although in his particular study, he said that there's not much statistical difference, but he said he gave the reasons because till then the probes were not good for the children. They were adult probes, that's that. He also talked about vascular isolation or clamping, renal cooling, intravenous mannitol administration just before the surgery and bench surgery and auto transplantation. Of this, he said eventually intraoperative ultrasound will be very good, and the ones, I mean, I don't have it, but ideally one should have it if he wants to do. Ischemia is another issue, and people used to talk about cold ischemia. I mean, Miller from Cape Town has got a long series of bilateral Wilms tumors, etc. And he would talk about, surface hypothermia using cold slush, and he would talk about ice dams and all that, which he used to make with his opsites and all that. Warm ischemia is approximately 20 to 30 minutes. So you can probably put a soft clamp at the hilum and do it. But mind it, for the smaller babies, even putting that soft clamps for 20, 30 minutes could be very, very bad. But suddenly the concept of zero ischemia came, and now almost everybody is doing without any clamping and without any cooling. I have done whatever numbers I've done in bilateral, unilateral, always zero ischemias. Just loop those vessels there and then did the surgery. Systemic or regional anticoagulation is not required. So this is the article which came in 2020, I think, which is the first RCT done over many years, again by Nurli. This is the first RCT in the world coming from Belgaum. And he has proved that NSS in unilateral Wilms tumor brings much better results when we talk about the incidence of hypertension and incidence of CKD in the two groups. And of course, in this year, very first issue of JIPS, I did a big systemic review and shown I had to work very, very hard because there were a lot of terminology issues and et cetera, to I had to exclude a lot of patients which were otherwise called NSS. And eventually 306 patients were already available for me to write this paper. So what I do is routine and metastatic workup, including NCCT of chest, but CECT of abdominal. But if they both are being done together, then of course a CECT. I always do an ultrasounded guide core needle biopsy by retroperitoneal route since 2008. I understand that in 2016, even UKCCG now is doing only in limited. But my idea is that there are a lot of papers which are available that the non-Wilms renal tumor are much commoner in the South Asia and India, Indonesia, Vietnam, etc. And my series, the number of patients having non-Wilms renal tumor are very high. And another thing, if you wish to do NSS, is that anaplastic Wilms tumor is definitely no. So if you do a true cut biopsy and you pick up anaplastic, then it means it's the diffuse anaplasia. You will not touch this patient with a pole. You would always do a total nephrectomy in this patient. Once you know that's a favorable histology tumor, I would give 4 cycles of actinomycin D and vincristine, just like Sayob says, and then again reassess this patient. One, I come to know how much my tumor has shrunk, and also I will do at this stage a renal dynamics scan to know about the renal function on both sides. Then intraoperatively, the first thing that I will do is send frozen sections for the lymph nodes. If the lymph nodes are reported positive, then obviously I will abandon NSS and do total nephrectomy. Then how to do the surgery? Next few slides, nothing much great. You all have been doing it for bilateral Wilms tumors. There's nothing new about doing it in unilateral Wilms tumor. We'll talk about it. And then I would do the nephron sparing surgery and send it for histopathology, and then I will do a follow-up RDS to know whether I could retain the same function which was there preoperatively, and then follow up the same patients with the same protocols that we always use for. And the surgical technique, this is something which I have been doing for all tumors, nothing new for NSS. Most of us, I know traditionally, those who I call purists, would go in, attack the hilum first. So 5 minutes, at least 5-10 minutes. I can stop here. There's no issues. Just 5-10 minutes. I will skip my own cases if you will. So they would first attack the renal hilum and then they will go around the kidney. I will do just the opposite. I would first release the kidney all around and leave the hilum for the last. And for me, artery first, venous first, vein first doesn't really make a difference. It has never made a difference to my results. So these are the slides. So you can use ordinary monopolar cautery to do the scoring on the renal parenchyma where you need to cut. And then you cut. You can use any of those instruments, those tools that you have, ultrasonic, whatever you have. Even CUSA has been used by people. And then you close the margins so as to give the same renal contour. These two pictures are actually from an article of 1950s. So people knew how to do this. Of course, they did not mention unilateral there. It was to do partial nephrectomies. And I understand that they probably were talking about bilateral Wilms tumor. But these pictures were available in literature in 1950s. So nothing new I'm doing. So in 2018-22, I mean, COVID, 1 year, we hardly worked. I got 19 patients, few in Maulana Azad, few in Lady Harding. And out of 19, I could do 9 patients partial nephrectomy. All of them had a monofocal or a unifocal tumor, but one patient had 3 foci, and I removed all 3 of them. Sorry. So this is case 1, some reduction, and I go ahead and operate. Same RDS, pre-op, post-op. This is another patient. CT is done. We know where to cut. Same RDS. This patient had 54% reduction. So as I said, I don't know which one will work, which will not work. This one is 3D reconstruction. If you would see this particular patient, the tumor is actually protruding into the pelvis, the so-called botryoid tumor. No hassles. For me, that's not a contraindication. It's written very well in literature too. So I would cut on the pelvis, leaving a margin, repair the pelvis over a DJ stent, and things are going well. This patient was done about 3 years back with no recurrence. So here it is 82% reduction. You see, so chemotherapy has really worked. So I can always do my analysis on this. Again, central hilum tumors, which a lot of literature says very difficult. No, you can actually go ahead and do it. And enucleation works very well in these areas. Now, this is case 7. If you would see the slide on the other side, very large tumors. In fact, with great difficulty, you come to know that it's not one focus, there are 3 foci. Given chemotherapy for 4 weeks, all those foci is reduced. Look at the lateral focus, which was so huge. It's become such tiny thing. And I went ahead. I agree, the literature says don't do multifocal. But obviously, this patient had nephrogenic rest, and that's why multifocal. So in very, very probability, he would have a metachronous tumor, whether monofocal or multifocal on the other side. So I justify this surgery and do it. And this patient was operated about a year back or so, no recurrence. So carry home messages are NSS has slowly and steadily ascended to its present position when it's no more considered as a mere tentative option of surgical management of Wilms tumor. some people on my back said, Dr. Serene ka fitur. It is no more a futur, but a validated surgical principle that could give the radical nephrectomy run for its money in the coming future. You see, we always have standard of care and gold standard, those terms which I really don't like. But then something else comes up and people keep trying and then they find the results are good or even better, then they start accepting it. It's no more indicated only for bilateral Wilms tumor. You can do it for unilateral Wilms tumor also. It has been now known to have similar, if not better, oncologic outcomes, but also leads to better long-term renal function and lesser incidence of hypertension. Procedure is advised in early stages of disease. The metastatic disease is not an absolute contraindication. Now we have started a 9 multi-site center study in the country. Results will be compiled and we will publish it. And even if you don't agree with my lecture, fine. But please do buy my book. It's going to be in the markets very, very soon. I've worked very, very hard on this, 39 chapters with so many different authors from India and UK. So with that, I would close my talk. Thank you so much.
Presentation and covering all the details of nephron sparing surgery. We are in modern era of medicine where restorative rather function preserving surgery is very important rather than destructive surgery, which we are doing for years together. Just one question from my side, sir. During nephron sparing surgery, which you do, sir, what kind of ischemia do you use? So warm, cold, or no ischemia?
What kind of? Ischemia?
Yeah.
Zero ischemia.
No ischemia.
People have done laparoscopically zero ischemia.
How do you control bleeding, sir?
I have never clamped at the hilum ever.
How do you control bleeding, sir?
Bleeding is not a problem. That's what I'm saying. Try doing it. Bleeding is never a problem. Just loop those on your red tape, blue tapes, and bleeding does not. I don't remember even transfusing a single patient. No issues at all. Once you do it, and if you're scared, initially do some enucleations and then move on to doing partial reflection.
And what is the purpose of, sir, doing it? You said, sir, there is metastatic disease is also not a contraindication for
not a contraindication. Not a contraindication.
Reasons for it, sir?
No. Question is, we must understand this. This concept has again come up for last few years only. In Wilms tumor, there's something called local disease and there's something called metastatic disease. Metastatic disease, we are giving chemotherapy. So once it is stage 4, whatever chemotherapy is to be given, that will be given. But then there is something called local disease. What I'm trying to say is that suppose a local stage 1 disease has pulmonary metastasis, right? We would give chemotherapy as stage 4 disease, but we will not give radiotherapy to this flank because it was a stage 1 disease. So we must understand that having metastasis away from this kidney is no contraindication at all. We are doing analysis. People have done it for years actually.
Because of lack of time, just one question from the audience, if anybody is.
So, may I ask you a question, please?
Yes.
So, your views on, so the basic premise of NSS comes out of bilateral Wilms, and that's where we've learned it from. So, the basic premise of the American way of giving free drugs versus the 2 drugs which you are giving in PSYOP, because the Americans upfront gave free drugs where they're planning to do an NSS, even of bilateral NSS when they're doing. So, your take on that. And the second question is that what would be your options if your NSS has a recurrence? Would you go in for a redo NSS or a total nephrectomy?
Can you repeat the second question?
What would be your options in case the NSS has a recurrence? Would you go in for a redo NSS like the Americans are doing? There are a lot of papers from David Hoffman group which are coming out on that. And would you go in for a redo NSS or a total nephrectomy?
I had given up on COG way back in 2007 and moved on to UKCCLG. So my take is that I will only give 2 drugs, not 3 drugs as COG drugs. I was also trained and did a fellowship in Memphis with David Hoff was also there. I am still not very brave to do a redo, and I have not had a recurrence, touch wood. But what happened once was that I did the surgery and I sent a frozen section of the margin. That was negative, but I was told negative. But when the biopsy came, HP after 3 days of that surgical margin, they said it is positive. So I went ahead and did total nephrectomy on that patient. So now it is known that if it is a positive margin, you really don't need to do total nephrectomy, or you do not need to give radiotherapy to just for the positive margin alone. So if recurrence ever comes, as of now, I would probably go ahead and treat it as a relapsed kidney. I would probably do total nephrectomy and would give chemotherapy and radiotherapy as indicated as for any other unilateral tumor.
Thank you so much, sir. Thank you so much.
Thank you, sir, for the insightful talk. That concludes our oncology part. Now, moving on to the urology part, we have two stalwarts with us. That is Professor Minu Bajpai, sir, and Padmashri S.N. Kuril, sir, to give a talk on the and sharing their experience on the extrophy epispadias complex. First up, I would like to invite Professor Minu Bajpai, sir, for his talk on the bladder extrophy epispadias complex, meeting the challenge. And I would like to give a brief introduction about Professor Minu Bajpai, sir. Sir is the professor head and department of the pediatric surgery at AIIMS, New Delhi. He is also executive director and vice president at NBE, and he acted as the president of IAPS between 2014 and 15. And he had made more than 300 publications in peer-reviewed journals, and also he was the author for many chapters and textbooks, and also the scientific reviews. His key area of work is in pediatric urology, ranging from the genital reconstruction, umbilicoscopy, genitoscopy, and up to the almost to the molecular workup in the uropathies. Sir.
Thank you. Good afternoon, Mr. Chairman. Well, we are running out of time. I want to be very crisp. So I have chosen this title, Bladder Extrophy Epispadias Complex Meeting the Challenge, because the last almost 4 decades going through the management of this condition, we have come across many problems. Unfortunately, also the literature doesn't actually holistically report the outcomes. And that's where there are many nooks and corners where we have to really struggle to find the real solution. Now, as we all know, it's a small patch of bladder, and with a small stubby penis in the male, the sphincter of the bladder neck are not developed, and there is a very short vesicourethral canal. Now, these patients have got these recti which are laterally displaced and wrapped around in the lower part around the bladder. What is important to remember is that they have very wide pubic diastasis, but they are all born with normal kidneys. There are so many abnormalities in the lower urinary tract, but they have normal kidneys to begin with. And the morbidities after birth, as we see, is urinary incontinence, small bladder capacity, abnormal bladder dynamics, upper tract deuteration, and now increasingly reported native bladder malignancy. So obviously kids who have been born with a bladder patch which is small in size, it is not only small in size, it is also not normal as far as the detrusor should have been. So the impetus to growth even after repair is not there. And that is the point which people have often missed out. So I want to repeat this sentence repeatedly because as we see our results, to decipher as what is happening is very important. So we, as one would envisage, the goal is to have renal preservation, to provide control to the urine, to provide good sexual function later on in life. They should pass urine per urethra. But that is what we are not able to achieve even after many, rather an evolution of surgical procedures. Many procedures have been advised. 3 broad category of procedures, and most popular one had been classic repair, in which the bladders were turned in, followed by bladder neck repair and epispadias repair. In this consequence, it was soon realized that if you close the bladder and you do the bladder neck tightening, the pressures rise very rapidly into the bladder. So the bladder doesn't remain a receptacle which can store urine in normal pressures, which obviously would be transmitted to the kidneys and the renal injury would take place. After recognizing this, they modified, and most of the work which has started off was from Johns Hopkins, and it was called the modified stage reconstruction extrophy, in which they do bladder turn-in and then did epispadias repair. and bladder neck was avoided. Bladder neck was avoided because that was causing problem and rising pressures. So subsequently they realized that in which patient they would have to offer bladder neck repair would depend upon is there adequate capacity in the bladder before they tighten the bladder. And that adequate capacity definition is still eluding. Then again they found the bladders are not growing. They said if you can do complete apparatus together, we do bladder closure, partial bladder neck repair and epispedias repair in one go, we are probably putting the bladder into cycling much early on in life in the neonatal phase, and the bladder capacities might grow. So toying with these approaches and then assessing the results, what has been happening. Now, all the reports, they first of all underreport holistically. They are focusing on continence. They would do good bladder neck repairs, most popular being young D's or its modification, thinking that if you give a good mechanism to the bladder outlet, there will be voluntary voiding, and that which means that the child is continent. And most of the reports which have focused on bladder outlet repair, they've actually forgotten completely what is happening on the upper tract. So holistic reports on continence, results of bladder neck repair, and simultaneously reporting on upper tract function is rarely done. So, so this is what I was trying to. People misconstrue voluntary control with safe bladder pressures. So voluntary control can be obtained. It does not mean that this child who is continent has got safe bladder pressures for the upper tract. And that's what I'm trying to emphasize. This holistic information in the reports is mostly missing. So continence at what cost? So we looked at our data at some point of time. When we looked at, there were 165 cases. We excluded 23 which were redo procedures, and data were available in 142. There was stage repair classic and MSRE, which clubbed together is 77. And subsequently, in the last 15 years or so, I've been doing only single stage total reconstruction, another name for it, which is complete primary repair refractory, which are 65 in number. We looked at upper tracts and lower tracts simultaneously. It was a routine follow-up in our department. We look holistically at what is happening to the upper and lower tracts. For upper tract by DMSA scan, renal dynamic scan, glomerular filtration rate and serum creatinine. Lower tracts by doing urodynamic studies and MCU to look for reflux. So this is a busy table, but it's a very important table. This table will sub-stratify patients as per the age at primary repair, age at secondary repair, age at complete repair. And then it was procedure-wise. The first column shows the classic repair, which we used to do in the early 80s, followed by MSRE, because the evolution of surgeries was happening and the results were as dismal across the globe as we were also finding. We also changed our approaches and we started doing MSRE, which is modified stage reconstruction. That is closure of bladder followed by epispedia and then bladder neck, rarely when the capacity was good enough. And finally, complete primary repair came up forefront because it was realized that if you do a complete apparatus together, the cycling would likely to improve and there will be greater impetus to bladder capacity. Now, then we looked at our data in the same table. If you see lower down, follow-up period after primary repair, follow-up period after secondary repair, and for after completion of repair. So with various stages, various age groups, and the type of repair, we looked holistically into upper tract function and lower tract function. Quickly, in these subsequent 3 or 4 slides, I will show you the results of these. So if you look at this slide, it shows the result of DMSA scanning. And if you see now, is there a pointer? Do we have? Right. So if you look at the first one, you will find that in the initial, the stage repair, which was the classic repair in which bladder was turned in, at the newborn stage, at 3.5 years, bladder neck tightening was carried out. At 5 years, epispedias repair was done. You find that the number of children who had scarring were very small to begin with. But as the time passed and the follow-up increased, more and more children had renal scarring. If you look at the second type of approach, the MSRE, initially there were lesser number of patients who had renal scarring. as the follow-up increased, the renal scarring increased. So with either of these stage procedures, the kidneys kept on getting damaged as the children grew and they were going into CKD. We thought that probably CPRE, which is a complete repair, might give us better capacities and better upper tracts, but it was no different. The number of patients who were scarring was less initially. As the children grew up in age, scarring kept on increasing. So it gives you a bottom line one information that irrespective of the procedure chosen for repair, as the children grew, the renal injury continued. And this information singularly was missing from most of the reports. Now you look at GFR, again, the number of patients with poorer GFR were very small in number, handful only to begin with. As they grew, the number of patients with poor GFR kept on increasing. And if you compare the three types of repair, in every type of repair, this was found. More and more patients, as they grew in age, the GFR, those with less than 80 GFR were many, many more in number. So this all showed that no procedure was a perfect procedure, and either of the approaches was also causing damage. Now, I will come to reflux. In the early part, post-repair, lesser number of patients had reflux, but as the children grew in age, the grades and the number of patients who had reflux also increased. So again, it shows that irrespective of the stage, the reflux is increasing, which only showed that reflux has increased because the bladders were storing urine under very high pressures. Now, this chart will give you a very good glimpse. If you look at it, this was the stage repair. In stage repair, it takes about 5 to 6 years before you could actually reach the complete repair, and the GFR fall is gradual. But if you do complete reconstruction to begin with, right in the beginning, and that was the first chart, you can see this. The fall is very steep. So we thought that complete primary repair is likely to give us better results, but it wasn't. In fact, it was precipitous. It was precipitating rapid injury to the upper tract, which was being translated as falling GFRs. So whether it was newborn done or older children done, the results were no different. See, now we looked at capacity. I was telling you that we looked at urodynamic evaluation also. So if you look at it, we clubbed the stage repair, the classic and MSRE in this way, and we found that when we do urodynamic study, we calculate the maximum systometric capacity and we compare it with the expected capacity for age. If you look at it, the maximum systometric capacity was only 20% of the expected capacity, irrespective of which type of procedure was done, whether classical or whether MSRE. Now, if you look at the complete repair, again the same thing. The maximum systometric capacity was only 1/3 of the expected capacity. So, although in single stage total reconstruction, you can accrue little more capacity as compared to staging out, but it was never enough. It was only 1/3 of expected capacity. So, if you expect in a child that who his expected capacity is say 100 ml and his observed capacity is only 30 ml, he is obviously storing urine under very high pressures. And what will happen to it? He will remain incontinent, irrespective of what continent procedure you offer to him, and his upper tract will get damaged. That's what we saw. So we also did osteotomy. There was a period of time that we thought osteotomy would aid in soft tissue repair as well as outer resistance would increase, and therefore the children will become continent. But we again found that the results were no different. And if you look at it, with or without osteotomy in staged and with and without osteotomy in complete primary repair, the capacity improvement was no different. So we stopped doing osteotomies. Soft tissue repair was never a problem. In soft tissue repair, we can do with mobilization of the rectus abdominis, in extensive mobilization right up to its carceral cartilages, and we can put the soft tissues together. So osteotomy to aid in repair was never a question, and so soft tissue repair was resumed without osteotomy. Now, we came to a conclusion. These bladders do not grow. Irrespective of the approaches we have found, we have looked holistically upper tract and lower tract. and we have found that because of the non-growth of the bladders, the pressures are high and they are transmitted to the kidneys and causing them damage. And no procedure was better than other. So we looked at its histology and we found the histochemistry studies have been done in very, very few centers. We did ours and we found there was a plastic deranged smooth muscle to collagen ratio. And as a result, we came to a conclusion again, and it was being recognized in the world also, that there are intrinsic abnormalities in this detrusor. This is not a normal detrusor. You cannot expect it to grow like a detrusor normally would just by putting it together. And therefore, this call has to be taken. So what we started doing, we thought we should offer augmentation of these bladders as early as possible. So we started doing one procedure that I prefer is gastrocystoplasty, where we all know we would just harvest a patch of stomach from here on the right gastroepiploic artery and put it up. And this is the operative picture. This was done open surgery in which we would do a stomach harvesting, a patch on a pedicle which will brought down to the pelvis and augment the bladder. Now you can make a large bladder ranging from 80 ml to about 250 ml. It gave very good results. Suddenly, if you look at it, the GFR which was falling plateaued off, the creatine which was rising again plateaued off. So the higher pressures were taken away, and we were very happy. We thought that probably we have found an answer to a problem. And if you look at this, the continence, as the child grew after bladder augmentation, the periods of continence also started improving. If you look at X and Y axis, so they are becoming more and more dry. The capacity had improved. Renal function deterioration had almost stalled. And we thought, wonderful. And I presented these data. So I'll show you this video also. People think voluntary voiding is good enough, and the upper tract would remain the same. That's not the goal. So how do I just click it here? Can somebody help me with this video, please? इसमें करना क्या है? Just a minute.
सर आपका कौन सी ऑन्कोलॉजी में ना?
ऑन्कोलॉजी नहीं है।
ये वीडियो कौन सा सर? ये वाला?
नहीं ये ऊपर वाला यूरिन वाला जो था ना, जो भी दिखा रहे थे।
ये वाला? हाँ चलाइए।
नाम उसके टाइटल तो कुछ और है, जो बच्चा था।
नेक्स्ट।
Warm greetings from AIIMS, New Delhi. Today we are presenting a surgical video on laparoscopy.
ये भी नहीं है, ये देखो अकाउंट, ये देखो। Now, I am showing this for the sake of it, because there is people feel that if we should focus only on making the child continent, if he can do voluntary voiding, everything has been achieved. Now, he can stop maturation on command. He can initiate maturation on command, which is what he is doing. Just observe. So we ask him to stop, he stopped. You ask him to. Umpteen number of families, they come and visit, they are happy about it, but we tell them everything is not happy about it. Stop it. Let अगले में आ जाओ, please. Sorry.
Presentation
उसी में दिखाते। Thank you very much. So we were so happy with the fall in pressures, with stabilization of upper tracts, and with improving continence with time after augmentation, that in the symposium, the third symposium on exstrophy held in Johns Hopkins, which is a mecca of bladder exstrophy, because they do in huge numbers actually, and they do nothing else. So I was quite happy and declared that, well, augmentation is not option. It's a stage of repair. We should do it as part and parcel of treatment offered to the children, because the number of children who would not require is far less than those who would actually need of it. But we had also shown why it is important, because we had shown all these data to them, where we had shown that upper and tract, lower tract deterioration continues. So, but our happiness was very short-lived. Very soon, we received a girl, 17 years old, from Assam, for repair of extrophy. On table, I found very suspicious surface. I sent it for frozen section. For the first time in my life, before the repair of frozen section was sent for bladder extrophy, it turned out to be adenocarcinoma, unoperated bladder. And I removed that patch. We gave it a gastric bladder. We did reimplantation of ureters into the stomach patch, and we gave her a mitrofenol. So now, this was a stunning thing. We could have left it as one-off case. This is the MCU after augmentation, after reimplantation. But soon, within a few months, as would serendipity be, I received a child who had operated 25 years ago with a gastrocystoplasty. An engineer in Pune, he said, "Sir, I have had hematuria." I said, "Come over." Hematuria happens after gastrocystoplasty, but it settles down within 1 or 2 years. He was okay for 20 years. Then he said, "I have hematuria." I said, "Come over." I did a scopy and we found a polyp. The biopsy showed it was an adenocarcinoma at the native bladder, very close to the junction. He died within a year. Now that sent me rolling actually. We looked at the literature. It's in established figures. The bladder cancer is 700 times more common in bladder extrophy. The relative risk between segments is very little. Gastric would have 2.3 times more, colon 1.8, and ileum 1.3. So all of these have equal propensity. And there are reports, increasing number of reports in unoperated bladder, as my first case was. So we thought that now I have so many cases in which I have done augmentation, I must do surveillance. Which is the one which is getting into malignancy? I must go and remove it. There's no specific marker which can predict that this child will become malignant. So I thought the only option is call them one by one and ask the families that, well, this may happen to your child, because once the malignancy happens, you can't do anything about it. It has a very galloping course. Adenocarcinoma of the bladder is a very ominous condition. The only thing you can do is to remove the native bladder and leave them with a large native gastric bladder. Because, as I said, there is no specific marker. So we started removing the native bladders and gave them gastric bladders. The technique is very well known. Instead, we were doing hand-sewn surgery earlier. The staplers were available. We gave them elongated large bladders, which was possible by a stapler. So I just showed you that. Now, this is a small, this is 2 clips. One is a 10-minute. I will not do the 10-minute clip. I'll do a 20-second clip because the time is short. How do I, just please. So harvesting the gastric patch, instead of giving a long incision by laparoscopic ports, there are 4 ports. We create a window of the gastroepiploic artery and the antrum, and then we dissect it away. Then the patch I was showing earlier would be carved away by staplers. So you can quickly have a look at this. So these are ports. So that's where the window is being made, and the small tributaries, which the vessels and branches which go from the right, the bounding arteries are right gastroepiploic. So between the stomach and the arcade, which is very close to the antrum, we create a window. This window is extended down. The right gastroepiploic artery is completely freed, and in the upper part, the patch continues to be supplied by its branches. So you can see the particle is free now. we now have a window here. And through this window, we put in a stapler, linear cutter. And we carve out an elongated, large capacity bladder. So the rest is as you see in bariatric surgery. In bariatric surgery, you go from fundus down to the antrum and you excise it. Here we are not excising it. We are just carving it away and it is sustained by the pedicle. Pedicle dissection is the only unique thing from bariatric surgery. And this large patch of bladder is then brought down through the window of the mesocolon, and it goes right up to the pelvis down there, where we open up and do hand-sewn augmentation.
Sir, we are running extremely short of time, sir.
So
Requesting you to please
stop the
conclude.
video. Stop the video. Thank you. So anyway, so we have done 7 gastric neobladders. These are patients in which we had done a gastric cystoplasty earlier. We are removing their native bladders, and that's not the end. We are continuing our research by doing liquid biopsies in these patients on follow-up. Although there is no specific known marker, but we are still looking at some possible markers which are genetic material which can be harvested from the blood as well as from urine, and these are called liquid biopsies. And probably we may find in a huge number of patients doing this study some Ercp marker where we can decide, well, this patient will require removal of native bladder and this will not. Now this is again a very short sort of 2 or 3 segment. Epispadias, they have short penis. We realize that the corpora are longer and the plate is short. So if you divide the plate distally, the corpora can be released and the penis lengthening can be obtained. You can see this gap. We always get 4 centimeter extra length of the corpora when we release from the plate. In between the gap, Dr. Rajesh, I do the Agra repair, which is reverse Asopa repair. I take the trapezial tube, tunnel it between the corpora and lengthen it. So this way we are able to achieve the length of the penis, which is again a very big problem in patients with bladder epispadias. Now, so in short, one line conclusion that these children spend their childhood with very hardships of urinary morbidity and urinary incontinence. During this period, their upper tracts are also lost. They go into CKD gradually, and later on they have a risk of malignancy. Therefore, we have decided that we would, after the initial years of repair, we remove the native bladder, give them gastric bladder, reimplant the ureters into that, give them an amitrofenol. So I'll stop at this. Thank you so much.
Thank you very much, sir, for a very different type of presentation, which has changed our understanding and concept of management of extrophy to a certain extent. The house is open for just one question if anybody wants to ask.
We all had similar experience other than Professor Kuril, of course. I did criticize everybody, including Dr. Vireshwar, when we talked about social continence after exostrophy bladder, because the picture that he painted is the one which I saw in my entire career. But now I understand we are talking about 4 stages and still the patient may not have great continence because we didn't touch the continence bit. So I wrote an article in 2017 in Indian Journal of Pediatrics, and that's what I've been practicing for many years. Why do we need to then get into the reconstruction business at all? Why not suggest them a diversion? Most of my patients are coming from the slums. They can't do CAC. They will not put in a bag at night and whatnot. And I have given options. I've always given options. And those who opted for reconstruction, I've done the reconstruction with whatever has to come after that. And the other ones I've diverted into the bladder. I did read a lot of papers, but not really found papers of adenocarcinoma at the ureterosegmentostomy, etc. There were a lot of articles in adults, of course, from Calcutta, where there's done thousands of ureterosegmentostomy and no cancers. So, but stenosis was an issue. So I started putting the native bladders into the rectum. Now, when you're saying those native bladders may have adenocarcinoma, maybe that is also not a bad idea, a bright idea. Maybe that should be also removed. But what I'm saying is, sir, rather than going to the rigmarole of things and whatever we may do as a research work as you're doing, what matters to the patient, and majority of us coming to me are very low socio profile, that we just give them dry periods, they have control on their maturation and they live long. Maybe they'll not live 80, I don't know. Maybe they'll live 50, maybe they'll live 60. But with this way, the things are going, they live a very miserable life. I mean, I have even done augmentation over augmentation in a patient. I mean, how much suffering would they have? I mean, this is my question. So I personally feel those underprivileged.
What is the question?
My question is for the underprivileged who cannot afford all this, who cannot afford lifeline CIC, etc., etc. Why don't we just divert them into the rectum? Because most of the rectums, even if they're anterior ectopic anus, they have got good continence. They're anally not incontinent. And I can give you a lot of certificates from educated families, redos from other surgeons to me, where I've done diversions and they've said, thank you very much. You're like God, you've done great service to me.
Rectal diversion was done more than 60-50 years ago. It was given up because of very high incidence of malignancy. So what we are going through, what I have shown is a journey of evidence-based medicine where we went with the flow of the world. Procedures came up, they were offered. There was earlier a miserable scenario as far as XTP is concerned in 1870 onwards. So just listen to me.
Yeah.
So people came up, they wanted to give a native bladder, they repaired it, they offered stages, the stages evolved. We went with the flow, we also made our observation. When the CPRE was sort of introduced, we did that also. When osteotomy was introduced, we did that. But we were one up because we were all the time looking at upper tracts and lower tracts together. And we now, so what you are saying, probably we are on the same page, saying, well, these
absolutely, we're saying the same thing.
When I stop saying, please speak after that.
Right.
So once we are done with completion of the procedure, we found there are problems. We are now moving forward, telling, well, these bladders have a urinary incontinence morbidity throughout childhood. The upper tract injuries take place. They are prone to malignancy. Such systemic studies have not been reported. So therefore, we are now saying that we should give them dry life right early on, and they can do CIC, neogastric bladders, reimplantation of ureters into them. They are all established practices. So we are giving them that, saying only this, that we all treat our patients. We should talk to the families. And when I have given it to them, the families have come only asking me one question, sir, why you did not do it earlier? I said, I didn't know that this can be offered. So we all learn over a period of time. So I have just shared this experience with full evidence, and that's the bottom line.
May I speak, sir? So just half a minute, sir.
So I think at the end of the day, we continue practicing what we think is right. And my idea is something based on evidence based. Not be applicable to all patients. If it is not applicable to type of patient, don't do it with them. I think this scientific world is there is nothing to further. I think let us not get into the discussion on, like the way they are.
Sir, I may sound like a disruptor, but I'm not. I have treaded the same path as he did. I treaded the same path as Sudipta did, and we did 80-90% of patients bladder augmentation eventually. And I have started doing bladder augmentations very early in life. That happened about 10 years back. Then I realized that still things are not working out. People are still not happy about the continence. Things are really still not up to the mark. So then I offered them, and I don't put it in the rectum. I put it in the rectal pouch. I mean, there are techniques already there in literature. So, and once that option is given, people opt for it. And now in last 7 years, I've got 2 cohorts. One where I'm doing reconstruction and one I'm doing diversion. And maybe in another 20 years, when I'm 80, I'll present those data.
Maybe we are going to listen to a third perspective from. Yes, so
Thank you so much, sir. I'd like to invite Professor Kuril, sir, for his lecture on.
Thank you, sir, for the insightful talk. Next, moving on with the saga of the extrophy bladder and epispadias complex. Next, I would like to invite Dr. Professor Kuril, sir, Professor and ex-HOD of the KGMU.
Problem is that the system is not able to upload my presentation, so therefore I'll be talking on Zoom platform. So therefore I'm speaking from this. I'm sorry, sir.
No problem.
Respected chairpersons, ladies and gentlemen, at the outset, I express my gratitude to the organizer to give me the opportunity to be here and start talking on extrophy reconstruction for continence. These patients of bladder extrophy and these patients and these female babies, they have come to stalwarts and experts like you with the hope that after the reconstruction, we'll have normal voiding with continence, of course with upper tract preservation, without revisions and complications, preferably one stage, with gratifying aesthetic appearance of abdominal wall in genitals like this in male and like this in female. Not only this, after reconstruction, their performance in terms of micturition and control will be somewhat like this. This video is not running. Please come and help. Yeah. I'll finish before that. So, and like this in male and like this in female, she can hold on command and initiate again. These videos that command on micturition is indirect indicative of the fact that their sympathetic system is intact, their parasympathetic system is intact, their somatic system from the pudendal nerve is also intact. Not only this, their sacral micturition center, ascending circuits, pontine micturition center, and cortical centers are also intact after this repair. Tendlenberg has said, despite severe anatomical defects, all neurophysiological components necessary for continence are present. Not only this, male and female extrophy babies are born with full potential for intercourse and fertility, Woodhouse has said in 2006. And potential can be realized by proper reconstruction, but potential may not survive the onslaught of surgery involved. Therefore, all the scheme of reconstruction should be aimed at a restoration of anatomy with the condition that innervation is preserved, vascularity is preserved, and the integrity of all the organs, including genital organ, is preserved. We all know that continence is the well-defined, synchronized, orchestrated interplay between the reservoir, that is urinary bladder, and outlet, that is bladder neck and striated sphincter. This fine interplay is dependent upon three systems: somatic system from pudendal nerve, parasympathetic system from the pelvic nerve, and sympathetic system from hypogastric nerve. And these three systems are dependent upon the pontine maturation center higher up and cortical center. So this is the animation. This is the bladder from the hypogastric nerve. This animation is not working. No, it is working. Yeah, it's coming, and the bladder is filling. Once the strict reflex has started and bladder has filled up, then parasympathetic action takes place, and then the response to beta adrenergic bladder ceases, and urine is expelled out, and the stimulus of pudendal relaxes the external sphincter. Now this animation shows reflex maturation, which is the type of voiding seen in infant. But as we grow up, this action, this relaxation and contraction from effect of parasympathetic and ability to hold the urine is governed by the pontine maturation center and cortex, and the circuits are intact through the sacral maturation center and through the well-defined tract in the spinal cord. Therefore, scheme of dissection in bladder exstrophy, whatever the technique, should be aimed to preserve the sphincteric branch, which is the branch of the perineal and pudendal nerve, should be aimed to preserve periprostatic plexus, perivesical plexus, that is, and there the perivesical and periprostatic plexus contains sympathetic and parasympathetic both, and the bladder contains beta adrenergic and the bladder neck contains alpha adrenergic blockers. And not only this, the scheme should preserve the hypogastric plexus also. We have also demonstrated that all the muscles of urogenital diaphragm, that is bulbospongiosus, and above this will be rhabdosphincter. The transverse perineal muscle and ischiocavernosus muscle are present in bladder exstrophy. Not only this, between this space here, we have demonstrated the presence of a sphincteric branch of the perineal nerve, which supplies the rhabdosphincter, and the safe plane lies along the medial border of ischiocavernosus muscle, which I'll be showing through forthcoming videos. This is the CT scan showing muscles of urogenital diaphragm, perineal body, and this is the course of sphincteric artery, which is the branch of perineal artery, and just by the side of this lies the sphincteric nerve, which we have identified with nerve locator available in my department. Now we have published these findings in paper Surgical Anatomy of Urogenital Diaphragm, a course of its vessels in Atrophy and Epispadias, published in Urology Gold. And we have also defined the course of neurovascular bundle in relation to ischiopubic ramus. That is, it runs along the inner edge of ischiopubic ramus and not along the outer edge. And it carries the surgical significance that we can radically mobilize the corpora and yet preserve the neurovascular bundle. I'll be showing you the video. And this is the figure showing the course of vessels and nerves and organization of muscles of urogenital diaphragm in classic bladder exstrophy. So, to exploit these anatomical facts, we have devised a novel midline scrotoperineal approach, facilitating innervation, preserving sphincteroplasty, and radical carpal detachment for reconstruction of extrophy epispadias. It is 8 hours procedure, and I will just review this with 20 seconds animation. Here, bladder plate mobilization, carpourethral separation, radical carpal detachment, axial triangular bladder closure, external sphincter repair, ischiopubic osteotomy, and repair. You will be seeing the actual video clips forthcoming. So here follows the actual with the transtubercular line, umbilicoplasty flap. This is the incision line are marked all along the bladder plate, along the margin of urethra down up to glans, and along the margin of prepuce and median raphe of scrotum. The skin along the marked lines are incised. Median raphe of scrotum is also incised, and the inner preputial edge is also incised. Then we develop the subcutaneous plane down a propubic bone, and we effect the vesico-cutaneous disconnection. Final tip cautery we use. And as we proceed down here, we'll have to be careful. This is a spermatic card here, and this is a spermatic card here, but here will be the root of corpora, which must not be damaged. Here, you can see this is the root of corpora here, and this is the recti, and we enter the subperitoneal plane, extraperitoneal plane, down up to the bladder trigone, and keeping the umbilical vessels towards the bladder, and that keeps the perivesical plexus intact and vascularity intact, and branch of superior vesical artery sometimes branches out from this card, that also remains undamaged. Then we revert back to perineum again, and through midline avascular plane, which is as thin as 0.5 mm. Here you can see this is avascular plane here. So we split the scrotal septum and we enter the subdautas plane here. This is the subdautas plane. Then inner prepuce is split off the outer preputial skin daughtas up to the glans here, and bilateral strips of penile skin daughtas complex is reflected off the corporal body away. And yeah, this is a wedge of corpus spongiosum, and we are following the same subdautas plane, and here we have landed on to bulb of urethra, and further back bulbospongiosus is seen here. This is Dr. Bajpayee's stimulator I am using. And onto corpora, when you dissect backward, we land onto ischiocavernosus muscle, and there is a close-up view here. And this is a safe plane I was talking about. This is the safe plane. Here we have the vessels and nerve, but this is the safe plane. Yeah. This is the ischiocavernosus muscle, bulbospongiosus muscle, and then we go for division of this is neurovascular bundle here. So here intersymphygeal band is divided in a manner that the neurovascular bundle remains preserved, and bladder mobilization is complete. Now, this is the radical carpal detachment. Along the outer edge of ischiopubic ramus, periosteum is incised, and with the mounted gauze, with the force drop. This is the levator, the obturator internus here, ischiocavernosus here. Same procedure is repeated onto this side. And with this, the radical carpal detachment, you can go back up to ischial tuberosity, expose the medial surface of ischial tuberosity, and yet carpora remains intact. We have also published paper on surgical anatomy of penis in Atrophy Epispedia, study of arrangement of facial planes and superficial vessels of surgical significance. And based on this anatomy, we have described novel skin management scheme in surgery of epispedias undergoing cantilever repair. So, with this scheme, we achieve aesthetic skin cover, which we'll see in future in forthcoming video slides. And here you can see this is the diagram of surgical anatomy of epispedias penis, and here I have described there's an MR angio showing the vessels of penile skin dartos complex, and there's a lateral view showing the double source of blood supply to prepuce here. So, in this plane, subfacial plane between the neurovascular bundle and urethral plate here, anteriorly and posteriorly. In this well-defined subfacial plane, if we dissect, then the vascularity to wedge of corpus spongiosum is intact, and neurovascular bundles also remain intact, and we separate the rhabdosphincter of the lateral attachment with innervation and vascularity preserved. Ischiocavernosus. Ischiocavernosus on this side, and here in relation to verumontanum here, this is the bulb of penis, and above it you can see the contraction of rhabdosphincter on both sides here. Then bladder neck, triangular mucosal patch or exile of the bladder neck, and we do anatomical bladder neck repair. We do not follow Young D's Ledbetter bladder neck repair. We have published it in JIPS. So bladder neck, anatomical bladder neck repair is done. Bladder is closed. Glansplasty is completed. Urethra is tubularized. Onto tubularized urethra, we anchor both the limbs of rhabdosphincter. Now, in normal individual, rhabdosphincter is omega shaped, which is deficient posteriorly. Here in bladder extrophy, this omega shaped sphincter is strong posteriorly and deficient anteriorly, but we anchor it, and bladder is closed. See, you can see the contraction of the sphincter in response to stimulation. Bladder is also moving. Corporas are joined onto tubularized urethra, and after ischiopubic osteopenic pubic bones are approximated, linea alba is closed, umbilicoplasty is completed, abdominal skin crease alignment is done, and this is penile skin dartos complex sutured in midline, and this in turn joined to the subcoronal skin collar of inner prepuce. And here we are creating the penoscrotal angle. So this technique of novel skin management scheme, this is novel skin management scheme, is published in Urology Gold. And here inner preputial skin provides the ventral penile cover, which is vascular despite being devoid of dartos. So here is the completed repair. And this is the pattern of maturation of a person. This person is pursuing a BTech course and he comes from Bismarck. Sorry? Please help. Please help. वहाँ वो हो गया. Just few slides more. Otherwise, I can directly go on to conclusion also.
Entirely your choice.
Yeah?
Entirely your choice.
Sir, it is your choice only.
No, we've understood your
Yeah?
your concept and your perspective.
Yeah.
So you
Just a
can,
minute.
you
Just
can
a
go
minute.
to your conclusion slide. No problem. No problem.
Yeah. So in female, there is a lateralization of lower abdominal wall structure, and the midline gap is occupied by the late open bladder, and clitoris is bifid. And in how do we locate the external sphincter in female? So this is the incision line, and for shortage of time, I will skip this part of video. Go on to next video. See, next video. This is we reflect the skin of the corporal body. I'm doing this for shortage of time. And we will land on to ischiocavernosus muscle here. This is the ischiocavernosus muscle here, and this is the bulbovaginalis muscle. This is the vagina, and this is the bulbovaginalis muscle, and above it will have the sphincter. And here you can see bilateral muscles are exposed here. This is the bulbovaginalis here. This is the bulb here. So, and this is the urogenital diaphragm in female in relation to ischiopubic ramus. Here you can see this is the pubic bone here, and this is the ischiocavernosus muscle. This is ischiocavernosus. This is the bulb here. This is vagina. And once we detach the bulbovaginalis of the clitoral body, then we land on to external sphincter. So we first excise the triangular mucosal patch here. We are skipping this part, and yeah, we detach the urethrovaginalis muscle of the clitoral body. I think just 3 minutes more. This is the rhabdosphincter here. The rhabdosphincter in female lies above the urethrovaginalis muscle. The nerve here. So you can see the contractile rhabdosphincter, which is less marked in female, but it is present. Ureters are mobilized and reimplanted. And after bladder closure and sphincter reconstruction, clitoris are joined in midline. And in this case, we have done Salter's osteotomy from inside, sir. And the pubic bone are joined. And then linea alba joined. And genitoplasty is completed. I think yeah, this is a completed repair in female extrophy. For short of time I skipped, but this is the video of same patient maturity. She can hold on command and then initiate again. So that tells us that her pontine maturation center is intact, cortical center is intact, sacral center is intact, and Sympathetic, parasympathetic and pituitary nerves are intact after extensive reconstruction. Therefore, Mr. Chairman, sir, ladies and gentlemen, I conclude that the technique of innervation preserving sphincteroplasty is the logical application of anatomical facts to restoration of pathological anatomy towards normal. With meticulous dissection technique and an accurate anatomical restoration of bladder and sphincters with the ureteric implant, it is possible to achieve good functional and cosmetic result with single-stage reconstruction technique without significant complications in properly selected patients. This is the act of ice climbing. The task is difficult but possible. And thank you, sir.
That was most impressive, Dr. Puri.
Sir.
So we have actually.
Now I can come there.
You can stand there.
Yeah.
So that everyone can see you.
Yeah.
So I think we've heard two different presentations and one different perspective. So we actually have three things to ponder upon. One is the anatomical reconstruction, taking into account the neurovascular reconstruction, preservation of the innervation, and of course, very good cosmetic results. That was Dr. Kuriel's perspective, and I think he is absolutely right. And what he has shown us is absolutely astounding and most impressive. Dr. Bajpayee's perspective, I think, is also very valid in its place, because he has identified problems related to the upper tracts, related to the lower tracts, the big risk of malignancy, and keeping all these in mind, what he's practicing currently is a bladder made out of the stomach. Dr. Sareen, in his discussion, has raised the issue that all these are identified in and only afford in terms of financial. And move where these things are not possible, we have the definitive plan for them for as long as they live. So I think these are the three perspectives that all of them are correct in their own perspective. That's up to your take a comment or ask.
So you mesmerize us. You always mesmerize us with your clean and bloodless dissection. I don't know how you are able to do it, sir.
You can come to Lucknow and watch. You're welcome. See, Dr. Joshi. Dr. Joshi has come to my OT, watched it. Sudhir Channa had come to my OT and watched it.
Sir,
he arranged his flight.
I have a case lined up for you, sir. Superior vesicle fissure with a normal penis without urethra. Means
but that's a very easy case.
I don't know. That's not easy for me. It might be easy for you, sir. मैं आप ही के पास भेजने वाला हूँ उसे.
So there is just one. It's a beautiful surgery, obviously. There's just one point. Have you studied the upper tract changes? In the patient?
Oh yes,
so
yes.
We would like to see that.
Please don't start him on that. He'll take another half an hour.
No. Upper tract. See, first single stage reconstruction I did way back in 2001, and I think we did five patients, and the paper were presented in Ahmedabad conference in 2002. And incidentally, two patients, one male and one female, they belong to same village. And in one patient, I had done ureteric implantation, but in female, I could not do ureteric implantation at that time. And that patient came with raised creatinine and anti-reflux, with reflux at the age of 18 years. I mean, 1.5 years back. So that patient I had to go and do the anti-reflux. And there I did the GFR measurement and scarring. So
So in that patient, one scarring was onto one side was present, the other side was not present. But wherever I do blood extrophy, as a rule, they undergo pre-operative DMSA scan and GFR as a rule. And in Bombay conference in 2015, I got a paper presented where unoperated extrophy, where I think in out of, I do not know, but there were 2-3 patients who came late at the age of 18 years, 17 years. And in those patients, despite free donors, renal scarring was present. The data is still there. It is, images are being. And then listen, I'm not complete. Here, there are those patients who have GFR to the tune of 80 and good bladder plate. And those are the patients who receive single stage total reconstruction. But there are patients who have in between bladder plate and GFR is 60. In those patients receive bladder closure and epispadias repair, external sphincter repair, but bladder neck is kept wide open and they're left as such to wait till bladder capacity reaches about more than 60 to 80 ml, and then we will do. So at my center, there's no 3-stage repair. It is either 1-stage total reconstruction or 2-stage repair.
So I think what we need is from Dr. Kuril that in the next conference, we'd like to hear his results, long-term results of the technique that he uses.
Yes.
In terms of upper tract preservation and whether there is a risk of malignancy or not. So I think let us leave it at that. We have one more presentation.
And in the era of mobile, the follow-up has become very easy. You ask the patient to note down his mobile number and give your mobile number, the one which is on internet.
Your reconstruction is 1,000 times better than what all we do.
No.
But जो bladder की इसमें सालों की सबसे पढ़ा है कि उसका दूसरा अच्छा नहीं है, last in this that and so much. How is that the bladders that reach you are better behaving and all are not behaving?
No, we'll wait for his next presentation. Yeah. So we have one more presentation.
Sir, can I request? Yeah, actually, Dr. Kishore Panjwani is not here, and I requested Dr. Rajesh. But Rajesh boss, if you allow, to we can conclude just now. Okay, sir. Okay, sir.
You are the boss.
No, sir.
You tell us what.
I'm never, sir.
Yeah, Dr. Basan, I take this opportunity to request that before presentation, I was so tense because your system was not supporting my laptop. So you report this thing to Director Dhiman, and I will also talk.
When are you not tense?
Sir, I think if we Dr. Rajesh, can we have a short presentation, like 10 minutes?
The problem is that this presentation has 6 or 7 videos. So
Right.
it will take time.
Okay.
So it's better not to present it. Otherwise, I don't think anybody is interested now. After an
Okay.
excellent operative video by Dr. Kuril, who wants to see hypospadias? It's okay.
Okay, thank you, sir. So, yeah. So we'll have just the mementos and the photograph. I invite all the speakers on the dais. A big thanks to all the delegates who have stayed till 7 o'clock to listen to this final session. Thanks to all the chairpersons and speakers. And we will proceed to the banquet. We will have a short GBM of the UP chapter for just 15-20 minutes. We'll wind it up fast. And then we'll proceed to the banquet. All delegates with family are invited to the banquet at Chancellor's Club. Just wait. It's a fresh. Speakers.
Oh, Doctor.
My mother actually asked me this question. Why do you go to so many conferences?
Thank you. UP and UK, all pediatric surgeons are requested to stay in the hall. We are going to for short JVM.
Because we had low CVPs. We've had one.
डॉक्टर सुनीता, आप लोग आगे आ जाओ, जल्दी आओ। सर प्रॉब्लम है, फर्स्ट एजेंडा इज रजिस्ट्रेशन ऑफ यूपी यूके चैप्टर ऑफ IAPS. So it has problem because UK is another state and it can't be combined, and if we combine it can't be registered in UP. यूके को एक हम लोग नहीं सर, इसका यही रास्ता है कि पहले यूपी का रजिस्टर करें, रजिस्टर करने के बाद यूके को एक हम लोग GBM करके यूको को उसमें इंडल्ज करें, ठीक है, एक GBM करनी पड़ेगी। तो दिस नॉट द इशू, और ये यूके चैप्टर ऑफ IAPS के नाम से नहीं होगा सर, ये उत्तर प्रदेश चैप्टर ऑफ IPS के नाम से रजिस्टर होगा। तो दैट्स ओके। हाँ ऐसा कर लें, ठीक है सर। दूसरा क्या है सर, अगर इसको रजिस्टर कराना है तो हमें पोस्ट होल्डर सिलेक्शन करना पड़ेगा, सेलेक्ट करें चाहे इलेक्ट करें। हाँ, जिसमें हमें, जैसे हम IAPS में एक प्रेसिडेंट है, एक सेक्रेटरी है, एंड उसके बाद एक ट्रेजरर है एंड एग्जीक्यूटिव मेंबर है, 3 और 4। नहीं सर, ऐसा हो नहीं सकता, क्योंकि अगर हम प्रेसिडेंट बनाएंगे एक ही होगा, सेक्रेटरी एक ही होगा, ट्रेजरर एक होगा, 3 ये हो गए, और 4 लोग एग्जीक्यूटिव मेंबर चाहिए जो 4 रीजन से हम ले सकते हैं। ठीक है सर जी। सर प्रेसिडेंट भी कोई यंग ही चुनिए सर। ठीक है, मेंबर 4 जगह से, हाँ 4 जगह से 4 मेंबर चाहिए सर। हाँ
है ना सर, 3 साल।
सर यहाँ बुकलेट पड़ी थी, अच्छा सब उठा ले गया नालायक। सर इसके अंदर देख लीजिए, हाँ ये मेरा फोल्डर है, मेरा ही है सर, खोल लीजिए सर, उसी के अंदर होगा, पेन भी होगा, वो भी होगा। पैसे आई नहीं सर, अभी तो आप लोगों से मांगूंगा मैं। सर यूपी चैप्टर ऑफ IAPS के नाम से रजिस्टर करते हैं, ठीक है सर, ठीक है सर। प्रेसिडेंट सर, कोई बात नहीं सर, मैं पढ़ लूंगा। हाँ बिल्कुल, हाँ ठीक है सर, बस बोलने में कमजोर हूँ, पढ़ने में नहीं। है अंकुर नहीं पूछना पड़ेगा सर, क्योंकि आदमी इंटरेस्टेड नहीं हो तो नहीं करता है। किसी और को बना दीजिए। आई विल रिक्वेस्ट, एक ही इंस्टीट्यूट से 2 लोगों को मत बनाइए। हाँ ठीक है। मेंबर्स सर वो गड़बड़ हो जाता है। एवरी पर्सन नोज बिकॉज इट वाज इन आवर प्रोटोकॉल। I have told them, sir. You can see, sir, participation of Uttar Pradesh in this UP conference is very poor. देखिए, एक तो अमित बॉस अरुण बॉस देखिए, एक हैं जो कंफर्म है और इंटरेस्टेड भी हैं, करना भी चाहते हैं। डॉक्टर विजय इज हियर, पूछ लीजिए इनसे भी। हाँ सब कुछ ले लिया ना ये। हाँ अच्छा अब यही छोड़ दो। हाँ इनको बोल के जाएंगे। इंतजार इज हियर अलीगढ़ से। अच्छा उत्तराखंड चलो। डॉक्टर विजय एक्चुअली क्या प्रॉब्लम है बॉस कि आई एम फुल्ली प्रिपेयर्ड। ये थोड़ा सा इधर देख लीजिए। हाँ हाँ सर ग्रुप से नहीं होगा, आगे सुन लीजिए, इसको देख लीजिए। आई एम टेलिंग यू, ये सर हमारा जो बेसिक बायलॉज है यूपीयू के चैप्टर का जो था, ये काफी मोटा है। और इसको देखने के बाद मैं कई बार वहां भी गया था रजिस्ट्रेशन ऑफिस, तो वहां पे पता करने के बाद ये सब पता हुआ। वी कांट गिव ऑल दीज टू इन द सोसाइटी फॉर सोसाइटी के लिए दे हैव पर्टिकुलर प्रोफार्मा, एंड वो प्रोफार्मा सर ये है, मैं ऑलरेडी निकाल के लाया हूं दिस वन। आप देखेंगे तो उसमें एक छोटा छोटा सा कॉलम्स बने हुए हैं। ऑनलाइन आजकल हो गया है, तो ऑनलाइन जब भरते हैं तो एक पर्टिकुलर कॉलम है, उससे ज्यादा आप डाल ही नहीं सकते। बट अवर बाई लॉज जो है उसमें ढेर सारे मैटर है, 35 पेजेस के हैं, और ये जो बन के आया है ये हार्डली 12 पेज का है। तो सर रजिस्ट्रेशन इसी पे होगा, एंड आफ्टर दैट एक जीवीएम करके जो बाई लॉज उसमें है उसका अलग से बना के फिर वो मैनुअल जमा करना पड़ेगा आफ्टर 3 मंथ। तो रजिस्ट्रेशन इसको अर्ली करने के लिए हमें वो एवरी पर्सन का, जैसे आज मीटिंग हो रही है, कल मॉर्निंग में मैंने उसे बुलाया हुआ है। ही विल कम, ही विल टेक फोटोग्राफ्स, और ये ऑलरेडी फॉर्म बिल्कुल तैयार है सर। नेम को फिल करना है,
फोटोग्राफ चिपकाने हैं और उसके सिग्नेचर्स चाहिए, आधार कार्ड एंड एड्रेस प्रूफ एक चाहिए। हाँ, वो कल अगर हमें सारे लोग दे देते हैं 2 बजे तक, वो आके यहाँ से आपके सामने भर के ले जाएगा, साइन करवा के। सर उसमें फोटोग्राफ लगेगा, वो वही आएगा सर। देखिए आप, इसमें कॉलम बने हुए हैं, ये देखिए सर, ये सर, ये सारे कॉलम बने हैं, नेम, फादर्स नेम, डेजिग्नेशन, सिग्नेचर और ये फोटोग्राफ, और ये सारे जब लग जाएंगे सर आ जाएगी। साइन कहां से करेंगे? दिस इज द बेसिक प्रॉब्लम, हमको फिर से भेजना पड़ेगा सर। सर साइन तो करेंगे सर, वो आधार कार्ड और जो फोटो, सर उस पे साइन, फोटोग्राफ चिपका के उस पे साइन करने होंगे सर। हाँ, आपको आधार कार्ड पे भी साइन करके देने पड़ेंगे। सर व्हाट्सएप पे स्कैन कॉपी आती है या कॉपी निकलती है, उनको ओरिजिनल चाहिए होता है ऑफिस में। अरे फर्जी काम क्यों कर रहा है? नहीं सर, कल हमारे पास समय है, ये एवरीथिंग इज रेडी। हम एक ऐसी सोसाइटी बनाए जो यहाँ अवेलेबल हो, और वो कल फटाफट दे दे हमें आके। एक बार तो कोई ना कोई आएगा, जैसे ही आएगा मैं उसे 9 बजे सुबह बुला लूंगा, वो सब कुछ लेके तैयार रहेगा। हाँ, इसीलिए तो मैं कह रहा हूँ सर। हाँ, तो इसीलिए आप, नहीं सर, बाद में इसको हम कोई रिजोल्यूशन लाके चेंज भी कर सकते हैं, 1 साल बाद इलेक्शन करा लेंगे। ये तो सेलेक्टिव प्रोसेस हो रहा है। हाँ। बिल्कुल, जी सर, जी सर, जो भी करना है बिल्कुल कर सकते हैं, बिल्कुल। बिल्कुल बिल्कुल। हाँ, अब सर वो कहाँ साइन कराने वो वही जानता है, मुझे नहीं पता है। नहीं सर, कल मॉर्निंग में तो आप है ना, कितने बजे तक है? अरुण कब तक हो? रजिस्ट्रेशन नहीं हो पाया, वहाँ 2005 में तो करना पड़ेगा। वो तो ठीक है। तो मेरा जो सजेशन है तुम्हारे को ये है कि ये जो हमने जो कराया है तो व्हाट्सएप पे डाल दो, लेटर करिए, उसके बाद इसका परफॉर्मेंस निकाल के यार वो मैं क्या कहते हैं, टीचर लोग यही क्या रखते हैं, बाकी लोगों को है कि पूरे उसे साइन करके एक्सेप्ट करके भेज करेंगे। मेरा कल लेते हैं, यही से हम सोसाइटी बना लें, बाद में हम चेक कर लेंगे क्या प्रॉब्लम चलता जाएगा ना, नहीं तो उसको फिर 2 साइड का बहुत चक्कर होता है ऑफिस में। आप जब कहें हम उसको बुलाए, हम उसको 9 बजे बुलाएंगे तो 2 बजे तक बैठा रहेगा मेरे घर।
काफी लोग यहाँ पर जब आपका प्रेसिडेंट सेक्रेटरी और ट्रेजरर की तो ये बाकी एग्जीक्यूटिव कमेटी में आप फिर आपको ये साइन कल साइन करा मिनिमम 7 होने अरे एक घूमने की डॉक्टर दो कंफर्म हो गए एक डॉक्टर तब करवा के देते हैं हो गया तो आपका नाम डाल देंगे नहीं होता तो किसी और से करवा दें फोटो आधार कार्ड और ऐसा है देखो की नाम है प्रेसिडेंट डॉक्टर रावत सेक्रेटरी डॉक्टर वसंत और ट्रेजरर डॉक्टर संदीप और डॉक्टर वैभव डॉक्टर उमेश और डॉक्टर सुनीता चारों का लेंथ नहीं है तो वैभव नहीं कल आएगा आज तो क्या आज आया हुआ है हो गया आ जाओ यार यही करते हैं ठीक है फिर दो सजेशन Charlie?